Учасники, good morning, dear participants, і вітання нашим вельмишановним
Good
спікерам.
morning,
Good morning,
our
distinguished
distinguished
speakers.
speakers.
Дякуємо усім за вашу
We are
участь
grateful
сьогодні,
to
за
you
вашу
all for
присутність,
your
за те, що
participation, for your
ділитесь
presence, for
досвідом
sparing
та
time, for
надихаєте нового
sharing your
досвіду.
experience
Мене звуть Антоніна
and
Кумка, я
gaining new
генеральний директор
experience. My name is
Протез Хаб.
Antonina Kumka. I'm Director General
Сьогодні ми
of
будемо
Protest
з вами
Hub.
проводити тут
And today
цілий день, навчаючись та
we're going
дізнаваючись
to
більше.
spend the entire day by learning and gaining new knowledge.
Отже, марафон, онлайн-марафон, безмежні
This
можливості,
is
справжній
online
завдяки
marathon,
відкритості
limitless
партнерів,
abilities.
нам проходить
It became possible
проект
only
шлях
due to
реабілітації
the
відомих
support
інноваторів,
of
які
our
реалізуються в
partners
різні регіони України
as
та
part
Протез
of
Хаб в межах
the
ініціативи
road to
Limitless.
rehabilitation from
Це
regions to
постійний
community
постійне
implemented by
здійснення
patients of
розвитку
Ukraine and
реабілітації
Protest
та
Hub
мрій.
within the framework of War Trauma Rehabilitation Initiative and the Belgian Agency for International Cooperation
Трошки про
enable.
нас. Протез Хаб з
A little bit
2014
about
року
us.
розвиває
Since
галузь моделювання
2014, we've
простатів
been
в Україні,
developing the
інформує,
prosthetics and
допомагає та
orthotics industry in
медіасить.
Ukraine. We are informing, assisting, and we are not imposing
Наші
pressure.
пріоритети – це розвиток
Our
формальної
priorities
освіти
is the development
протезистів-ортозистів
of
та
formal
тренерів
education for
протезистів-ортозистів з
prosthesis,
метою
orthosis,
підвищення рівня
and
кваліфікації
prosthetic orthotic
спеціалістів,
technicians with the aim
розвиток
of
та
improving the
підвищення рівня
qualification of
кваліфікації
these specialists,
практикуючих
development and
фахівців з
improvement of qualification
реабілітації
of
загалом.
practicing rehab specialists.
Ми також
We are
приділяємо велику
also
увагу покращенню якості послуг з
trying to
протезування
improve the
вживання
quality
та
of
покращенню
prosthetics and orthotic
мультидисциплінарної
services and
взаємодії фахівців.
improving
Інформуємо
interdisciplinary
та
cooperation between
реінтегруємо в
the
суспільство осіб, які
experts. We are
втратили кінцівки
informing
та
and reintegrating into
через
society
засоби
people who have lost
реабілітації.
limbs and need assistive rehabilitation devices.
Що вже зроблено, на сьогодні ініційовано
Our
та розроблено
achievements.
два національні
As of
стандарти. Ми
today,
щиро
two
вдячні
national
нашим
standards have been
міжнародним партнерам,
initiated
які
and
брали в
developed.
цьому активну
We are
участь та
grateful to our
допомагали нам
international partners
забезпечити
who were
високий,
actively involved and
якісний,
helped us develop these
професійний стандарт
standards in a
протезиста,
quality
ортозиста
level.
та
So,
стандарт
this is
освіти
professional
магістра з
standard
протезування
prosthetist,
протезування.
orthotist,
На
and
сьогодні
the master's
сертифіковано
degree standard in
34 фахівця
prosthetics and
відповідно до
orthotics.
професійного
34
стандарту і
specialists
ще
are
3
certified in
фахівця.
accordance with professional standards,
Також
3 more are
84
pending.
студенти магістри
84 master
перший
students,
і другий рік вже
first
навчаються
and
у
second
4 медичних
year,
університетах з програмами
are
протезування
undergoing
ортезування.
prosthetics and
Це
orthotic
Харківський
program at four
національний
medical
медичний
universities.
університет,
This is Kharkiv National Medical
Тернопільський
University,
національний медичний
Ternopil
університет,
Medical
Національний
University,
університет охорони здоров'я України імені
the
Шевченка
National
та Львівський
University of
національний медичний
Healthcare of
університет.
Ukraine, and Lviv
Програми
National
підвищення
University
кваліфікації
of Danilo
фахівців
Halitsky. The
і викладачів цих університетів зараз в процесі
program of
завдяки
for university
співпраці з
instructors and
університетом Янчепінг.
students is
І
possible
ця
due to
програма
cooperation with Yancheping
здійснюється на
University. And
3
this program
університеті,
has been implemented for
з
3
якими
different
активно
universities
співпрацюємо.
we are cooperating with.
Також ініційовано та розроблено
We have also
стандарт
initiated and
реабілітації
developed
осіб
the
з
standard for
ампутованими кінцівками та
rehabilitation of
приміщення
persons with limb
реабілітації
loss
при
and
ампутації
clinical
кінцівок.
guidelines
Це
for
була масштабна
rehabilitation
робота, яка
in case of limb
незабаром вже
amputation. That was an
стане
extensive
частиною
work
вашого
that will
професійного
become
життя.
part of your
З кінця
professional
22-го року вже
career
надано
and
понад
life.
4
Since the end
тисячі
of
консультацій через
2022, over
гарячу лінію
4,000 consultations have been
стосовно
provided via
підготовки до
hotline
протезування та
regarding
процесу
preparation for
протезування загалом.
prosthetics and prosthetic process.
З 2014 року
Since
онлайн-курси та очні
2014,
тренінги Протез Хаб пройшло
we
понад
have delivered
7500
online
фахівців.
courses and
Сотні
in-person training
фахівців з
courses. More than
реабілітації, психотерапії,
7,500
це
specialists have
загалом
benefited.
медицини,
So these are
фахівців, яких
rehabilitation
цікавить
experts,
тема
doctors,
протезування та
variety of
реабілітація,
specialists who are
реабілітації
interested
та
in
фахівців.
rehabilitation and prosthesis
Команда
and
Протез Хаб та Просвіт
providing
у
support to people who
2015
lost their
році
limbs.
запровадила
In
мультидисциплінарний підхід до реабілітації та
2015, our
ампутації
team
кінцівок
has
перших в Україні.
introduced the
Також
multidisciplinary
створено курс
approach. That was the
онлайн-консультацій з
first in Ukraine. We
реабілітації для
also created
установ та
online
бізнесу.
courses for rehabilitation specialists, government agencies, and business.
Далі. Що необхідно зробити далі?
It is
Необхідно
well, what
продовжувати
we need to
розвивати
do
програми
next. It's
спеціалізації в
vital to
протезуванні,
continue developing
оскільки вони
master's
можуть
program in
масштабно
prosthetics and
впливати на охорону
orthotics.
здоров'я
Those who
та
obtain the
інших
bachelor's
інвалідів.
degrees in
Ми
healthcare and
просимо
biomedical
замовити кілька
engineering
що
are
стосується
eligible to
сертифікованих
enroll.
протезистів
By
працюючих
2028,
та
we are aiming
професійного
to have
стандарду.
300 certified
Система
prosthetics and
фінансування
orthotists
забезпечення процесу
who meet the professional standards. The system for
необхідно
funding
вдосконалити,
thesis
адже
under the state
наразі для передавання
Ministry of Health of Ukraine because the system is pretty effective today. It's also necessary to simplify and smoothen the interaction between information system of the ministries and introduce the concept of case management. The quality of services and the products and their control have to be top priority. It's too early to establish PO workshops based on hospitals. Patients have to have a choice where to get their prosthesis, and only qualified PO certified P&O can work with the patients, those who have practical experience and appropriate education. We have covered all aspects of Protest Hub activity. Now we can move on following our agenda. Thank you very much for your attention. And our first speaker will be Anton Johannesson. We are grateful to him, immensely grateful to have him here today. He joins us from Sweden. He's got abundance of experience in the area, and he contributed a lot to the development of P&O and rehabilitation in Ukraine. And he keeps assisting us and contributing to quality prosthesis and development of rehabilitation in Ukraine in general.
To be in this forum and to be able to share something with the Ukrainian people that might help in their situation when working with amputees. Please go to the next slide. Yes, thank you. If you go back one. Yeah. This presentation is focusing on saving the knee. Saving the knee in amputation is crucial to obtain a good function for those who are amputated. The higher the amputation is, the more energy you need to work, and suspension will always be more of an issue. If you go to the next one. I have a disclosure. I'm an employee of Usher and for Motion Clinics since 2013. I have been in this field since 1978. I'm a certified prosthetist orthotist, and I got my PhD from Lund University in 2009. My current position is that I'm Director of Clinical Development, Prosthetic in the European area. I do research, and I'm also active in different forums like the ISO and the ISPO. I've previously been on the board of ISPO International. Thank you. Next. use of a leg prosthesis. The content of this presentation, we will talk a little bit about the use of a leg prosthesis. We will talk about the skin, delayed wound healing, and then I have 3 case studies. One related to vascular surgery, one is related to compartment syndrome, and one traumatic amputation. Next one, please. It is incredibly abnormal to use a leg prosthesis. We try to connect the prosthesis to the skeleton through soft tissue, not created to bear the body weight. It is suspended to the skin through vacuum and friction, which the skin is uncomfortable with. Trying to engage muscles where the insertion has been cut off. There is actually nothing else comparable with how we treat the body as the use of a leg prosthesis. Next one, please. And it's a bit cynical to claim that we can solve this problem with individual-made prosthesis, or osseointegration, or limb transplantation. The legless person wants to regain their old leg, and we can never fully solve that issue. I think we need to be honest when we discuss amputation and prosthetic fitting. This to be able to achieve realistic goals. Next one, please. However, we achieve more with leg prosthesis today than we ever have believed that we could do. I have a 4 person here, which I like to mention. Richard Whitehead from the UK. He's a bilateral through knee amputee. And he did 40 marathon on 40 days, running from the northeast end of the UK all the way down to the southeast end. Marcus Rehm, who is a below knee amputated, he jumped 8.72 meters in long jump. And he holds the German record in long jump. Andrea Lanfrey, which you saw on the previous picture, he's a bilateral and he has also finger amputations. He went up on Mount Everest recently. And his goal is to get on top of every highest mountain in every continent in the world. And then we have these heroes like Roman Maximets from the Ukraine, who is triple amputees. He lost his eyes on one side and also the hearing on one side as well. He's a role model for many of the amputees in Ukraine, and amazing person. Next one, please. But before we go further, I'd like to bring up 2 books that could be of interest for you to get a hold on. Or one is the Skin Problem of the Amputees from the late Dr. William Levy, who was produced in the 80s, but is still with a very good information. And the other one is a thesis by Henk Meulenbelt from Netherlands, where he has been looking at the skin problems and the prevalence for those who are amputated in Netherlands. And it reveals a high percentage of problem for those who are using prosthesis, close to 40% of all patients. And it's important to bear this in mind, that you don't solve the problem just by giving a person a prosthesis. It needs a lifetime service and help. Next one, please. The goal to provide traumatic amputated patient with a prosthesis is, as we all know, a challenge. Good prosthetic fitting, easy don and doffing, secure suspension is the goal for me as a prosthetist. However, we have to deal with dexterity in the fingers or finger amputation of the patient, dry or fragile skin, short limb can be a challenge, previously or other operation scars, and adherences in different places. All these needs to be individually assessed on every patient. Next, please. In amputation, delayed wound healing will happen. And then it is a challenge for the surgeon to wait and see if it will heal, or have to do a re-amputation to a higher level. And this is a challenging decision for the surgeon to see where the limit is. There is no easy way to find a clear marker of if it will heal or not. Next one, please. In 2008, I presented a paper in the Academy Today in the US about this lady with who was bilateral, and the possibility to save the right leg there was a challenge, and we knew that the blood supply was problematic. So we ended up with a large wound. And here the decision is, how do you solve this? And we solved this in a way that it healed. Next one, please. It took 151 days. However, during that period, the patient was walking on a prosthesis, meaning that they were active. They were just not waiting for the healing to take place. I will go in more detail on that later. Next one, please. Patients who fail to heal are rarely mentioned in scientific papers or in these books about amputations. Clear guidance for ward staff on how to manage these cases is hard to find. Perhaps too complicated to write about. In practice, it is often the most senior clinician who decide on re-amputation or discharge the patient with the message to return once the wound has healed. Next one, please. So what happened is you adopt to the wait and see strategy, and all mobilization and walking therapy is ceased. Inactivity that may go on for months without any wound management strategy. And waiting is painful as well. Forgetting is painful, but not knowing which to do is the worst kind of suffering. This gives also depressing signal to the person, and nothing is happening in the rehabilitation. Next one, please. What we should be is active. We know through evidence and experience that early rehabilitation and mobilization of an amputee higher the odds of a good outcome. Next one, please. There are few studies which have addressed delayed wound healing with a varied approaches. One of them is from Van Ross, where he looked at patients with unhealed transtibial wounds, which could train with a prosthesis, and 74% achieved full healing. Salvo and his co-authors, they adjusted the prosthesis for the patient when they came in with the wound and kept them walking on the prosthesis. 64% of those with wound healed within 6 weeks, and 25% reduces in size of the wound. Trabalesi, he showed that vacuum socket system enhance healing potential. Next one, please. These studies discuss continued prosthetic use, even on unhealed limbs, and the use of vacuum suction socket system as an alternative. We recognize the difficulty of measuring outcome or conducting rigorous study in this group. Still, in many cases, almost any effort is preferable to re-amputation at a higher level. Next one, please. Early walking training in a semi-hydrostatic socket with airtight suspension can create negative pressure at the wound site. The negative pressure during the swing phase helps the blood flow to go down into the wound area, and positive pressure during load. In that way, you get a circulation. This effect does not require any active vacuum pump. The key is to mobilize the amputee, and active pump may be added later in the rehabilitation. Next one, please. So I'd like to present for you 3 cases, as I mentioned. And the first one is a vascular-related case. Next one, please. This was a male, 44 years old, with diabetes type 1 in the beginning. He got a diagnosis in the 80s, and it was complicated to control. He has a lot of variation in his glucose level, and he got into insulin shock many times. In 2014, he got transplantation with a new kidney and no new pancreas, which made a whole difference in his life. He wasn't diabetic after that. However, the perfusion in his left leg was highly affected by the diabetes, the previous diabetes period, and he got sepsis in November 2016. He was treated with antibiotic intravenous for 6 months and using also a vacuum pump. A long period for a male in his best ages. And in July 2017, the foot collapsed. Next one, please. In September, it was decided to do a transtibial amputation on the leg. So 11th of September, they made a sagittal incision, which you can see on the illustration on the right side. And it's the position of the air, which, of the scar, which is important. They use then rigid dressing for the first 5 to 7 days. And after a week, we started a post-operative compression treatment of the limb. Next one, please. At 2 weeks post-op, the patient falls on the limb end at home because he was discharged after 1 week to his home. And he got this distal hematome. And 3 weeks after the amputation, he went to visit the surgeon, and they could notice this necrotic tissue at the distal end. They decided to continue with the compression liner and revisit for control the week after. Next one, please. So, no, back, please. Can you go back? Yes, thank you. No. No, back. Can you go back, please? Please, if possible. Some issue. Some technical issues. Yes, no, you are going forward all the time. No, you're going forward. Please go back. Go back. One more. This. Yes. Okay, let's stop there. He got prosthesis when the wound looked like this. And he was trained at the clinic in the beginning, and the load on the limb was demanded by the or decided by the patient. The patient changed the wound dressing himself, and that was nothing strange with that, as he has been dealing with wounds for many years. the healing process went on. Next one, please. You can see here, this is 6 weeks from amputation and 7 weeks. And you can see where the necrotic part is diminishing and the wound is healing from the bottom. Next one, please. Here the doctor decided to clean up the wound and take away the necrotic tissue. And just a week afterward, you can see how much different this did to the wound, and quite a large difference just in 1 week. Next one, please. Here you can see him walking 2 months after the amputation, and he's walking without any assistive devices, and still with the distal wound. It is important to understand that the wound is taken care of with a bandage that absorbs fluid. The fluid comes in the beginning of the treatment, but it's get less and less the longer the treatment goes on. Next one, please. So he came for a socket replacement in mid-December. This is how it looked at that time. Next one, please. Then he informed us that he was going on a vacation to Uganda for 1 month. We didn't expect that, and we didn't recommend it, because then he was out of control for us, but it was important for him. So he went to Uganda, and he informed us that in the beginning of the year, in January, the wound was not leaking at all. Next one, please. Here you can see when he came back that the wound was totally healed. And you can see the difference between when the prosthetic fitting was started and to fully healed limb. The effect on the patient to be mobile during this treatment period can not be overestimated, the benefit of it. It had a huge difference for his life, so to speak. Next one, please. Compression therapy with a liner can be done in a different way, but the effect of using a silicone to affect, for example, in this cases of a free flap surgery, shows how much effect it can. You see the irregular shape of the limb, and to be able to put a graded compression instead of bandaging is totally different. Next one, please. You can see it on this picture between the initial condition of the limb and the end result on the left side. So with full control of the situation and a good plan and cooperation between stakeholders, a good outcome can be achieved. Next case, please. This one here, a compartment syndrome, was totally different, but rather similar to the case before. Next one. This is a patient that undergone a bilateral knee replacement, and a few weeks later, a right leg amputation was performed due to compartment syndrome, a rare case, so to speak. In such a cases, the team becomes the surgeon's most valuable ally. The pictures was taken after removal of the rigid dressing. Next one, please. Here you can see the effect of the compression during the first 5 days. You see the edema around the suture lines, and the different 5 days later, where you have removed the edema. Next one, please. We discover a couple of deep wounds behind the free flap surgery. That was no surprise. We knew that it has to heal from the bottom and upward to get a complete healing. Next one, please. And here you can see how deep these wounds were. They were filled up with absorbing band-aids to take care of the exudate. Next one, please. Here you can see the patient taking his first step on a prosthesis the day after the fitting. Remember, he has a new knees in both knees. Internal prosthesis. And he still has a little bit of contracture in his right leg. Next one, please. Here you can see him working without assisted devices 11 weeks afterward. And the condition of the leg at that time. Next one, please. So the start point on the left side and the end result on the right side. Conical or cylindrical form, good for prosthetic fitting. But of course, this kind of patient needs to always be monitored because of the scar tissues. In the treatment of this patient, we use a postoperative liner who has been tested on the patient since the beginning of the 90s. In some cases, we have used comfort liners, specifically when you have a free flap surgery. The benefit, as I mentioned, is that it has due to the thickness of the liner, it has a graded compression. You have the most compression distally, and it diminishes the higher up on the limb it goes. Next one, please. This is the third case, and it's a traumatic amputation. The distal circumferences on this case was 48 centimeters, almost a half a meter. And the compression was started on day 5 by the use of tension tube. And 1 week later, the distal circumference had gone to 44 centimeters. 2 weeks later, we were allowed to start compression with the liner. And the reason behind that was that was the transplantation of the skin grafts, which you can see on the picture here. There's a lot of skin grafts that has been put on the limb. And we started with size 40, 2 centimeter smaller than the circumference distally. There was hardly any knee joint movement at that stage. Next, please. 3 weeks later, we were down to 40 centimeters, and we changed to post-op liner size 36. Tension tube was still used during the night, and the patient was discharged from the rehab clinic to come in for training instead. So the patient was staying at home. Next one, please. Two months later, when the patient visited the surgeon, it was and we saw that the healing was progressing well. There was no fluid, or only light, very little fluid coming from the wound, and no need of large bandages. And the knee joint has been trained, so there was a pretty good movement or range of motion in the knee. So here it was decided to fit the patient with prosthesis. Next one, please. And here you can already see the different color of the skin, and also the shape is also getting better. We use direct socket, and the reason for why we use direct socket is that we can be sure that the pressure is divided through the whole surface of the socket. And we use passive vacuum with sleeve. Next one, please. Here you see the patient taking his first step with prosthesis. And you can notice that they don't complain anything about pain, which was surprising for us when we started this method in late 19s. The patient, when they are walking within the parallel bar, they can decide on how much pressure they are putting on the prosthesis. Next one, please. The patient came in for rehabilitation 2 to 3 times per week, and he had some volume changes during the day, which was compensated with socks. And the life for this patient was getting more normal. Next one, please. In the autumn, the patient came back, and we made a new socket for him, and the distal circumference was 26.5 centimeters. So from 48 centimeters down to 26.5. The patient was walking indoor without assistive devices, outdoor with one crutches, and he had a better function in the remaining limb, which was also affected by the trauma. Next one, please. This is taken during the visit in the spring, but you can see the enormous difference of the volume of the limb. Next one, please. The conclusion. silicone postoperative liner are a viable option for compression therapy, much better than bandaging. Early prosthetic fitting with vacuum suspension does not negatively influence rehabilitation. It has a very good psychological effect, specifically on traumatic amputated patient that really needs to see the light at the end of the tunnel. Close monitoring and support of patient activity are essential to optimize functional recovery. But remember, you cannot solve the problem by yourself. You need a team behind you. The surgeon, the rehabilitation doctor, the wound care nurse, physiotherapist, and a prosthetist. Thank you.
Thank you very much, Антон. Дякуємо Антону. І запитання. Ставте, будь
Then we
ласка,
proceed
в
with
чат.
questions. Please write your questions in the
Залежно
chat,
від того, де ви дивитеся
depending on
трансляцію.
where you see
Отже, одне з запитань
the
–
streaming. One of the questions,
який саме лайнер
what kind
використовувався
of liner
для
was
постійного
used
протезу? What kind of
for
liner was used for the definitive
the
prosthesis in
prosthesis
case one?
and the prosthesis?
I use thermoliner with vacuum suspension. I never use pin on these patients.
Thank you. Are there contraindications to wear the prosthesis while having a wound on the stump?
It is important that you have control of a infection, if there is an infection. But if the infection is under treatment and you have control on it, then it's not a contraindication. In all the cases, we don't see any specific contraindication.
Do you face the issue that a prosthetist is against using the prosthesis while the patient still has a wound?
I fully understand if they are afraid of this, because they need to do this in cooperation with a team, with other profession, because there cannot be one profession who is responsible for this. If you have a team, then you can deal with the problem that comes up with it. And at the same time, the experience goes back to the team. So the more you work on this, the better you become in what you are doing. But I would recommend that you start with small wounds, just to see the effect of mobilizing the patient.
Next, can we use compression therapy while having exudate from the wound? And do we just use dressing with liner before using the pneumatic compression therapy?
We don't use. You have to take care of the fluid that comes from the wound, and that's why you use absorbing bandage and a thin film over it, so you don't get fluid from the wound inside of the liner, because that can irritate the skin around the wound. So you have to take care of that.
Can the patient wear a prosthesis while having diabetes or other vascular problems?
Yes, we don't do any distinction between if they have diabetes or vascular problem. If you have a vascular problem, including diabetes, then it is important that you mobilize the patient. The worst thing is that you keep them in a wheelchair and nothing is happening. But if you mobilize the patient, the medication, the oxygen, and everything that you need to have the wound to heal goes all the way to the wound.
Robert, go ahead.
Hi, Anton. Can you hear me?
Yes? Hi, Robert.
Thank you so much for your presentation and for the interesting cases, Anton. I want to ask you about the time protocol of using compression liner therapy in these special cases, especially the last case you showed. How do you consider the protocol of time for using compression in the initial part?
It is as in general that you start with a 1 hour in the morning and 1 hour in the evening. And in the beginning, if you have a special shape of the limb, then you have to be careful so you don't get air in those gaps that can be there. That's why a comfort liner can be a very good when it is so irregular shapes. What the feedback that we get from the patient is that they feel comfortable when the liner is in place, that is something is holding around their limbs. That is important for them. Like any other bandage that you have. And they look forward to it when you come back with the liner and you can put it on the next time.
So there is a question, which recommendations for patients with the border issues, like the wound is kind of irritated of and already, but the scar is already healed. So would you still use a liner for that in that case?
Yes, I would, as long you are not using staples. Staples can be irritating just by themselves. So we always recommend that you use stitches instead of staples. Because when you apply a compression on staples, they can be irritating the bone as well, depending on the placement of the scar. But it is we haven't got any negative feedback in those cases that we have been working with, if they are mobilized and if they are under control. And it is very important to understand that it is the patient that is in the decision role. They decide when to walk and which way they walk and how much load they put on the limb. But the positive benefit is that something is happening and the patient sees that there is a positive feeling of being able to walk again. And that has a huge effect on the total situation.
Thank you. What are some failures that have to do with this method? Like what could go wrong?
What could go wrong is that you lose control of the situation. The patient doesn't return to the rehab settings. That's the only thing that I can imagine is that if you don't have control on it, then like with any other treatment, if you don't have the control of the patient, you are at risk. And that's the only risk I can see.
And what about revisions? How frequently do you think a patient with or such an approach can cause a revision as a result if the wound doesn't heal properly?
Yeah, in one of the cases, we saw that the patient had necrotic tissue distally. What we have found out is that it is important to clean that up, take it away as early as possible, because that is you have a bacteria in this necrotic tissue which needs to be cleaned up. And that alone is one of the changes that we have made, is that we recommend it to be cleaned.
And the question asked before was about the levels of amputation. What are the optimal levels of amputation that you suggest? And does the wound healing happen differently at different levels?
Yes, definitely. If you're trying to save the knee, then you are more at risk of delayed wound healing, because you have a less amount of soft tissue as you have on transfemoral level. That's one of it. It's also it's worth to make a short transtibial amputation in any cases. We have prosthetic technology today that can cope with short limbs, and they can be very functional and work very well on that. So saving the knee joint, as I mentioned, is so critical.
If the amputation is through the knee, what are some suggested approaches to fitting such a patient?
Yeah, and then you are at different level, and you have much more bone to deal with, and you have only a thin layer of soft tissue. In these cases, compression therapy is not as much needed as in transtibial, because there is, as I said, there's not so much soft tissue. There is a higher rate of reamputation in knee disarticulated. So it is a different approach, and need to be addressed differently.
Thank you. We are out of questions at this time. So thank you very much, Anton, for this very insightful lecture. And we're grateful for your time and for your participation today. Thank you so much.
Thank you.
Oh, one more question. Yes, Tatiana, go ahead. Sorry. Oh, I didn't see you. I didn't see your hand, sorry. Дозвольте, будь ласка, Тетяні вмикнути мікрофон.
Please allow Tatiana to turn her mic on.
Так, зараз.
Мене чути?
Так, чути.
Can you hear me? Okay.
Okay. Hello, I have a question. We have a patient and he has an unhealed wound and he was trying to wear prosthesis multiple times but still the wound keeps getting worse, I would say. So he's wearing prosthesis, then he has a break because the wound comes back, and then he goes to wearing it again, and it's like round and round. What would you suggest?
I believe that the prostheses that they are making are properly traditional prostheses, meaning that you make a relief in that area. And if you have a vacuum system and you make a relief, the body tries to fill that gap. So it's important that you have a total surface bearing so you don't create any air or space within the socket. I think that could be the reason behind it. But if you can provide me with more information, I will be glad to guide you in that case. Because I need to see the shape of the limb and where the location of the wound is.
Okay, do you mean right now? The
No,
details?
we need to do it in a separate forum, and you could contact Tonya with my email address, and you get in direct contact, and we can follow up on
Okay,
this
thank you.
patient. Yeah.
Мгм.
Ми вам
You're
напишемо,
welcome.
Тетяно, щоб вас з'єднати.
Дякую.
Дякую вам. Thank you. No more questions? All right. Thank you, Anton. We'll let you
you.
go. Have a
Yeah.
wonderful day.
Thank you.
And thank you very much for your time. Thanks. Bye-bye. Наступним нашим доповідачем є Ольга Щеглюк. Ольга говоритиме
Our
на
next
тему
speaker
військової
is
травми.
Olham Shahluk.
Вітаємо.
She will be talking about military trauma. Welcome, Olham, and we are grateful for your contribution and for your presentation. Over to you. Good morning. I hope you can hear me well. I'm grateful for a chance to share our experience of our center, military hospital, that is in charge of rehabilitation with the patients with the amputated limbs since 2016. We are going to share our experience that we had prior to full-scale war and following its commencement, its beginning. Next slide, please.
Про реабілітацію військовослужбовців після ампутації кінцівок.
I will talk about rehabilitation of servicemen after limb amputation.
Трошки візьмемо статистики.
A little bit of
Напевно,
stats.
чули дуже різні цифри. Яка
You
все ж таки
probably heard
кількість пацієнтів з
different stats, different figures about the number of patients with amputated limbs. There are different speculations. So some say that there are 50,000 amputees, but probably the most accurate number is around 20,000 of servicemen and civilians since the beginning of the full-scale invasion were provided prosthesis, limb prosthesis. If we are talking about the amputation because of the combat trauma, if we take all the patients who we receive at the evacuation stage,
військово-медичного клінічного центру Північного та Південного регіонів,
then following the research of the combat center of southern and northern regions, they did the research. 3.7 patients with limb injuries needed amputation. If we compare the level of amputation, complexity of amputation before the full-scale invasion and after it, then we see the increase in the share of multiple, two or more amputations and exarticulation, so more than 9 times. 30% is the combination of amputation and fracture. Any blast injury is not isolated. It causes other complications, fracture of tubular bones, defects of soft tissues, TBI, etc.
Травми кінцівок загалом серед
Limb
всієї частки
injuries,
поранень становлять
out of
найбільше,
all
приблизно
injuries,
42%.
make the biggest
Насправді
part,
пацієнти, якщо ми
42%
говоримо
on
з точки
average.
зору військової медицини,
And if we are
пацієнти з
talking from
ураженнями
the
кінцівок,
combat
вони є
medicine view, the
найбільш
patients
перспективними
with the
до
limb
повернення
injuries
до військової
can be
служби.
returned
Однак
to
внаслідок
the
складнощів
combat
мінно-вибухової
service
травми,
back,
складнощів ампутації, на
but
жаль,
there are
велика частка
complexities
пацієнтів з ураженнями
with the
нижніх кінцівок,
amputation and a lot of
травми,
patients
це травми, які
with
призводять до
limb
інвалідності.
injuries have traumas that lead to
Далі, будь ласка.
disability. Next slide.
Які ж особливості мінно-вибухових поранень?
Blast injuries to the
Серед поранень,
extremities.
які приймають наші хірурги та травматологів, які надходять по
Usually
етапах
these are the
евакуації.
injuries
І
that our
порівнянні
surgeons
із
and trauma
ампутаціями,
experts
які
deal
проводяться
in
планово,
evacuation
які
stage.
проводяться з
And if we
приводу
compare
якихось
elective
судинних захворювань,
surgeries
з
or
приводу
elective
діабету і так далі,
amputations
мінно-вибухове поранення
regarding
супроводжується незначними дефектами,
diabetes
руйнуванням
mellitus
тканин
or
та кісток,
other
пошкодженням
conditions. So we have significant
магістральних
destruction of
судин.
soft tissues, bone defects, damage of
Так,
greater
здається, пише, що
vessels
не видно
and
презентацію
nerves.
на екрані.
I get a message that my presentation
Крім
does not
того,
show up.
супроводжується наявністю сторонніх тіл, куль,
Also, there is the
осколків,
presence of
пороху
foreign
і
bodies,
так
bullets,
далі.
shrapnel,
І варто,
gunpowder,
що саме важливе,
etc.
видно, чудово, вибачте. Так, і що дуже важливо, що
And what's really
ці рани
important
внаслідок мінно-вибухових
is
поранень,
that
вони завжди
because of blast
первинно-інфекційні і
injuries,
супроводжуються
these
високою
wounds
лікарною
are
контамінацією.
infected and there is
Крім
higher
того, це не лише
contamination,
флора, яку
microbe
вони отримують безпосередньо
contamination. It's not
внаслідок
the flora that they
передовій,
receive
внаслідок бойових дій і так
at the
далі.
front line because
Коли
of the combat
пацієнт
injury.
проходить
Once the patient
евакуацію, він потрапляє в різні
is
медичні
evacuated,
заклади,
they get
де дуже
into
часто
different
все ж таки
medical
поєднується
facilities.
госпітальна флора,
Oftentimes,
яка
there
резистентна
is
до великої
hospital
кількості
flora,
антибіотиків.
which is resistant
Знову
to
ж таки, нераціональне
multiple
використання
antibiotics.
антибіотикотерапії, починаючи із
Also,
початкових первинних
antibiotic
етапів,
management
веде
is
до того,
not used
що
rationally at early stages.
ми маємо шалено високу резистентність і
And we
маємо
have
ускладнення
very
у
high
вигляді
resistance
остеомієлітів,
and
гнійних ран,
osteomyelitis
інфекцій, які дуже важко
um,
лікувати і які
wounds
часто
and
призводять
infections that are
до втрати
difficult to
кінцівки,
treat are
інвалідності та
often
інших
present
наслідків.
and it leads to
І,
the loss
звичайно,
of the
в деяких
limb,
випадках
disability,
розвиток
etc.
інфекції може завершитися
Also,
септичними
sometimes there might
ускладненнями.
be the development of severe
Септицемія, на жаль,
septic
стала досить поширеною.
complications. Septicemia has
Наступний слайд, будь ласка.
been very common recently.
Якщо взяти по співвідношенню верхні та нижні кінцівки,
If
то
we
ампутації
look
нижньої
at the
кінцівки
ratio
зустрічаються
lower
значно
and
частіше,
upper,
близько 72%,
so
і верхні кінцівки близько 28%.
upper
Серед ампутацій
28%,
нижніх
lower
кінцівок рівень гонивки є
72%.
найбільш поширеним.
Lower
Якщо ми беремо
extremities,
серед
so
ампутацій верхніх
TT
кінцівок,
amputation is the
то
most
безпосередньо,
typical.
що ми
If we're
зауважили
talking
частину
about
нашого
upper
виділення, то
extremities, if we
ампутація
look at the stats
на
of our
рівні
department,
плеча зараз,
so the shoulder
зараз
amputation
переважає.
is
На жаль,
probably the
дуже
most
багато
typical.
маємо ампутацій високих внаслідок
We have a
турнікетного
lot
синдрому,
of
про що я скажу далі.
high amputations because of
Далі
the
пізніше
tourniquet
трошки більше
syndrome that
розкажу.
I'm going to talk about
Які ж
later.
основні є проблеми,
What are the
виклики? Як я вже сказала, це
biggest problems and challenges?
комбінація
As I already
ушкоджень
mentioned, the
ампутації з
combination with
ураженням інших
lesions
органів
of
та
other
систем
organs and
і
systems,
турнікетний синдром, про
and
який я
definitely
згадувала. Близько
tourniquet
17%
syndrome.
пацієнтів, які
About
проходили реабілітацію в нас,
17% of
мали
patients
ампутацію
who
внаслідок
undergone
турнікетного синдрому. Насправді
rehabilitation
це
with
досить
us, so they
велика
had
проблема.
amputation because of
Вона
the tourniquet
обумовлена
syndrome.
кількома
It's
чинниками:
quite a
і ситуація на
challenge.
полі бою, і
It is
навченістю
stipulated
персоналу,
by the situation at the
можливостям наших
battlefield, the training
евакуацій і
level
так
of the
далі.
personnel, the
Але
possibility
момент, на
of
який ми можемо
evacuation
сподіватися,
means, etc.
однозначно
But
навчання.
what we can do, so definitely
Ми
is training.
спостерігаємо,
So
що
this is
виникає
our
одночасно велика
contribution.
потреба у
There is
протезуванні
high
значної
demand
кількості
for
складних випадків
prosthesis
високих
in
та множинних
significant number of
ампутацій.
complex cases, high and multiple
Спеціалістів, які
amputations.
займаються
Specialist
протезуванням,
experts who are
протезуванням в
providing
Україні є дуже багато.
prosthetic
Але, на жаль, все ж
services.
таки
There are a lot of them,
кількість
but
людей, які
unfortunately,
займаються
the number of
протезуванням
people
складних випадків, які мають великий
who are
досвід,
doing
є
prosthetics of
трошки
very complex
неспівставною з тою
cases
кількістю
and
травм,
who have
і
abundance
ампутацій,
of
які ми зараз
experience
маємо.
is not proportional to the number of
Помічається,
amputees that we
на
have
жаль,
at the
досі
moment.
значна дисперсія, тобто
There is
значна
also
різниця в
significant
якості надання
variance
послуг
in the
протезування по
quality
Україні.
of prosthetic
Що саме
services
мається на
across
увазі? Що
Ukraine.
може бути дуже
What do I
великий
mean here?
розрив від регіону до регіону
There
і
might
навіть
be a
безпосередньо
huge
в
gap
області в
between
якості
regions
надання
and even
послуг
within the
протезування.
region when it comes to the quality of prosthetic services
Що часто
provided,
призводить до
which
того, що
oftentimes
пацієнти
leads
не завжди
to
мають змогу
the fact that
отримати
patients not always
протезування
have a
у
chance to
кваліфікованих
get
фізичних протезистів,
prosthetic
але
services
нам, як вже
from the
згадували
qualified
вище, є ще над чим працювати, є ще що
P&O
змінювати, і дуже добре,
experts,
що ми
but
зараз маємо
sky is the
можливість
limit. We have room to
навчати
improve,
протезистів,
and it's great that we have a
протезистів-ортезистів
chance to train
за
our
відповідними міжнародними
PO
критеріями.
experts
Також
according to
те, що ми
international
спостерігаємо, це все
requirements
ж
and
таки
criteria.
не завжди
What
протезисти залучаються
we
у
also
процес
see that
прийняття рішення, особливо
involvement
коли
of
стосується прийняття
prosthetists
рішення
in the
щодо
decision-making
рівня
process is not
ампутації,
always the
щодо
case, especially
потреби
when
в
it comes
оперативному
to the
втручанні,
decision-making
вчасному
on the level
проведенню
of amputation,
і так
the
далі.
timely
І
surgery, timely interventions,
невідповідність
etc.
призначення
Also,
призначення протезів
incompatibility
чином
of
пацієнтів. Я думаю,
prosthesis with
ви
the
вже
patient's goals.
дуже багато випадків
I
бачили,
believe
коли
that you've
при
heard of
високих
multiple
ампутаціях
cases
верхні клітини
of high
екзартикуляції на рівні інших
amputations
суглобів
of the
призначаються часто не
high third
зовсім
of the hip
відповідні для даного пацієнта
disarticulation.
типи протезів, які абсолютно дуже
Sometimes the
часто не
types of
відповідають
prostheses
сьогоднішній
that are
необхідній
offered to the
діагностиці.
patient
І,
do
на
not
жаль, у нас
correspond to
часто
the level
є
of their
серед
mobility.
багатьох людей сприйняття
And
крісло-колісного як
oftentimes
якогось
there is a
такого
perception of the wheelchair
засобу, як,
as
скажімо так, останнього порятунку.
the device that is
На
considered to be
насправді
last
крісло-колісне
resort.
є для багатьох випадків,
The
особливо у
wheelchair,
випадках
in
високих
most
ампутацій,
cases,
є
especially when
дуже
it comes
важливим
to high
засобом
level
для того,
amputations,
щоб
is a very
людина була
important
мобільною
assistive
і мала
device
можливість
that
функціонувати.
helps a
І чим
person
раніше для
to be
пацієнта буде
mobile and
підібране
function
правильне
properly. And the
крісло-колісне,
earlier
тим
you
більше він буде
choose
втручатися
the right
в
wheelchair,
його
the
суцільний
more
розвиток,
the
тим краще
person
буде
will be
соціальна
actively
адаптація в
involved
майбутньому.
in social
Тому
adaptation in the
так,
future.
дійсно є випадки, коли
Therefore, there are cases
призначення
when
відповідного для пацієнта, відповідного мобільності та цілям засобу
the patient is
реабілітації,
offered the right assistive
це є
device
надзвичайно
for
важливим, і це
rehabilitation. And mobility, it's very important and it has to be discussed with the team.
Ускладнення, про які я розкажу трошки пізніше, це про інфекції я вже
The complications
згадувала,
I
те,
want
що
to
ви бачите ось на
elaborate on,
малюнках, це
infection, as I mentioned already,
меланоми,
we
гетеротопічні
have neuromas,
пластифікати і більш
heterotopic
специфічні ускладнення, такі
ossification,
як,
and
наприклад,
more
ускладнення
complex
після
problems,
остеоінтеграції.
like
На
after
жаль, маємо такий
osseointegration.
собі бум в цьому напрямку протезування, який
In this area of
має місце
prosthetics,
існувати,
we have
але
more
це
demand. It has
на
to take
даний момент
place, but as of
експериментальна
now,
методика.
we have experimental
І
methods
методика виключення
and
неперервного
exclusion
протезування
method, not
тільки в
initial
випадку,
prosthetics, but
коли
only in
класичне
cases when
протезування
classic
не
prosthetics
підійшло пацієнту.
is not
Не
suitable
підійшло
for the
в
patient
плані
in terms of,
коли пацієнт пробує місяць, два, три, а коли
for example,
мінімум
when patient
протягом
tries for 1 or
року
2 or 3
пацієнт
months. When the
пробує
patient
класичне протезування в різних протезистів, різними
or 1
методами
year
і з тих
tries
чи інших
classic
причин у
prosthetics
пацієнта не вдається,
with different specialists, and for this or
пацієнту не
that
вдається
reason, the
запротезувати.
patient
Про це теж трошки пізніше.
is
Наступний слайд, будь
not
ласка.
suitable for prosthetics course. Next
Значить,
slide.
зараз те, що ми також спостерігаємо,
What we
це
can see now
зростання
is that
частота
we have the growing
ураження
frequency of the
зору.
damage
Знову ж таки, це пов'язано як
to
із
the
електронною
eyesight. This
релігією,
has to do
зокрема
with
з
the
масовим застосуванням
kind of
FPV-дронів.
combat actions, especially
І
the use of FPV
травма, яка
drones,
поєднується із
and
травмами голови, спинного
we
мозку
also have
і так
combined
далі.
injuries like spinal cord injuries, head injuries, and so on.
Відповідно, для мультидисциплінарної команди
For
це
multidisciplinary teams,
значний виклик
this is a
для
major
того, що
challenge
значний виклик у реабілітації таких пацієнтів.
in
Потребує
rehabilitation for
значних
such
зусиль
patients.
як
It
персоналу, так
requires
і пацієнта. Потребує високої кваліфікації членів команди, які беруть участь у
different
відновленні
participants of the team who
пораненого.
take part in the recovery of the
Далі, будь
injured
ласка.
person. Let's move on.
І знову ж вертаючись до турнікетного
And
синдрому,
going
про
back
який я
to the
вже
Tunicki
говорила,
syndrome
можливо, хтось
I
вже,
mentioned,
можливо, ви стикалися також
you may
зі
have
схожими
faced already
випадками.
this
На
problem,
даному
such
слайді
cases.
наведено
The given
двоє
slide shows you
пацієнтів
two
із первинним
examples, two
однаковим
patients with
ураженням,
initial
травматичною ампутацією обох
same
стоп.
traumatic
В першому
amputation
випадку
of two
бойовими медиками
feet.
була
In the first case,
проведена
combat medics
конверсія
carried
турнікетів
out
через
conversion of
20 хвилин
tourniquets
після того, як
in
був
20 minutes
введений перший
after
турнікет максимально
the
високо
initial
в
application,
ділянці верхньої третини
as high as possible in
обох
the
стегон.
upper third of two
У
thighs.
другому випадку
In the second case,
з таким самим первинним пораненням
with
пацієнту
this
конверсія
initial
не була проведена.
wound, the
Була
conversion
тривала
was not
складна
carried out.
евакуація,
There was a
ситуація не
complex
дозволяла
evacuation, and the
пацієнта
situation did not
ситуація на
allow
полі
for
бою не дозволяла пацієнта вчасно евакуювати.
the
І,
timely
на жаль,
evacuation of
як ви
the
бачите,
patient.
ми
And
маємо
sadly, as
абсолютно
you can see, we have a
різні
completely
рівні мобільності,
different level
зовсім різний
of
підхід
mobility,
до
different
протезування
approaches to
і
prosthetics,
якість життя
and the
пацієнта.
quality of life
Звісно, це не
for these
значить, що в
patients are
якомусь
different.
випадку буде
It
вона
doesn't
гірша,
mean, of
буде
course, that in
краща,
one
але
case it will be better or
загалом
worse,
складнощі
but
в
overall,
реабілітації таких
the
пацієнтів
difficulties when it comes to
однозначно,
rehabilitation of such patients
судячи з
can be
цих фото,
seen
можна
based
зробити
on these
висновки.
photos.
Наступний слайд, будь ласка.
Next slide, please.
Етапи реабілітації
The stages of
це в
rehabilitation.
нас
We have
післяопераційний
post-operative,
етап протезування та підготовка до
prosthetic stage, and
протезування.
preparation for
Враховуючи значну кількість
prosthetics.
поранених,
Given that we have a
ми
lot
вже
of
досить
injured
давно в нашому відділенні не бачили
people in
пацієнта,
our
який
department, we have not seen for a
мав
while
поступати до
patients
нас
that have to be admitted as
як чисто реабілітаційний, зі
for
знятими
purely
швами,
rehab purposes with
без
stitches
ознак
removed,
запалення і так далі.
no
Більшість
signs of
пацієнтів, які ми
inflammation.
отримуємо, це
Most
можуть бути
patients
пацієнти, в
admitted
яких
are those
поранення було
patients that may have had
2 тижні тому, тиждень тому.
injuries
Це
like a week ago,
пацієнти зі
2 weeks ago.
швами, це
These are
пацієнти, які
patients with
потребують
stitches,
щоденних
and
перев'язок,
they
відповідно,
require
медичний персонал, який
changing
залучається
dressing
до
every
роботи з
single day.
пацієнтом,
A
це
lot of staff
реабілітаційні
workers
медсестри,
are involved.
повинні
Rehab
володіти
nurses have to
навичками,
be
відповідними
able to
навичками,
have the skills needed
розуміти,
to
що
that
таке
end.
інфекційний контроль,
We have to understand what
починаючи
infection
із
control means,
гігієни рук і лиця
starting from the
і
hygiene
завершуючи
and washing hands
екстремними моментами.
and move into more complex details.
Починається вже після
Preparation for
загоєння ранки або
prosthetics
ще
starts
підготовка
after the
після
wounds have been
протезування,
healed.
формування
We
куксів.
are preparing
І етап
socket for
протезування
the
це
stump
коли
and the
відповідно
formation of a
пацієнт
stump.
опановує
And
ходьбу,
prosthetic
починаючи
stage,
з
when the
етапу
patient
ходьби в
masters
брусах,
gait,
по рівній
working with rails
місцевості,
or
долання
on
пандусів,
even
сходів,
surfaces,
перешкод,
or
різних
walking
поверхонь і так далі.
using ramps,
Наступний слайд, будь
staircases,
ласка.
and other kinds of surfaces. Next slide, please.
Хто залучається до роботи з
Who is
пацієнтом? Хто
involved in the
входить до складу
process
цієї
with the patient?
мультидисциплінарної команди?
Who is
Якби
included in
можна було
this
сказати
interdisciplinary
у
team?
вигляді
If I had to show this
марвелівського фільму, то
using the
мультидисциплінарна
Marvel
команда
movie
приблизно
scene,
виглядала би
the
так. В
multidisciplinary
кожного
team would
із
look as follows.
спеціалістів є своя
Each
суперсила,
specialist has their own
свої навички,
superpower.
свої знання,
They have their own
які
skills
вони
and knowledge
допомагають пацієнту
they use to help patients
відновити функцію
to recover
та
functions
зробити так, щоб
and
цілі
ensure
пацієнта, які він
that
ставить перед
the
собою,
goals of
якщо
the
є вони
patient,
реалістичними,
if they are
що вони
realistic,
були
of course,
обов'язково досягнуті. Тут
they are
хочеться
met.
сказати, що
I
насправді,
want to mention
хоча
here
по
that
офіційно по всім документам травматолог не є
based on all
членом
the documents,
мультидисциплінарної команди,
traumatologist is not a
але
participant of the
це людина,
multidisciplinary team.
яка протягом всього
This
етапу
person,
реабілітації
throughout rehabilitation,
контактує з мультидисциплінарною командою,
works
і
with a
всі будь-які
multidisciplinary team,
рішення,
maintains this
що
contact, and
стосуються
all
оперативних
decisions
втручань
related
пацієнта,
to surgical interventions for the patient
реампутації і так
or
далі,
reamputation
обов'язково узгоджується
have
спільно
to
із
be
травматологом. З
agreed with a
урахуванням
trauma
обов'язково
doctor.
думки кожного члена в команді,
And
протезиста, фізичного
everyone's opinion has to be taken
терапевта,
into account,
ЛФР
including
і
physical
так далі.
therapist,
Протягом
occupational
цього
therapists,
періоду обов'язково пацієнт, починаючи з гострого періоду,
and
працює з
starting from the
психологом.
acute period, the
І
patient starts
соціальний
working
працівник.
with a
Тут я теж хочу
psychologist
зробити
and social
невеличкий
worker.
наголос.
I want
Участь
to
соціолог,
stress here that
знову ж таки,
the
починаючи з
participation of
гострого
social
етапу,
workers
є
starting from the
надзвичайно
acute
важливою.
stages
Тому що,
is
окрім того, що у пацієнта важкий
key
фізичний стан,
because
больовий
given the
синдром і так
complex
далі, в
physical
нього є
state and
ще
pain syndrome, the patient also
абсолютне нерозуміння ситуації, що буде
does not
далі.
have the understanding of the situation, what is
Якісь
going to
питання,
be
які йому задають
later on.
постійно
And the
по
questions
якихось документах, по
based on
довідках, по
documents,
виплатах, проблеми.
notices,
Знову ж таки, він ще ж як
the patient
військовослужбовець,
as
в
a
нього у багатьох
serviceman,
із них є сім'ї.
servicewoman may have
В багатьох із
families.
них після поранень є соціальні проблеми із
After
виплатами
wounds,
і
they
так
have
далі,
social
які дуже
problems with
часто
payments,
можуть виступати навіть на
and
перший
often
план турбота про
this
свою
can be
сім'ю,
even more important,
про
like
добробут
taking
своєї
care
сім'ї,
of
ніж,
the
наприклад, про
family, the
своє
well-being of
фізичне
the
здоров'я.
family,
Тому
may be even
соціальний
more
працівник
important
має
for such a
максимально рано
patient
включатися
compared
для того,
to
щоб
the
дати
personal
розуміння
help.
пацієнту
So the social worker has to give this
інформації,
understanding
що
or the
задати частину
information
цих проблем,
to
бюрократії і так далі,
unload
допомога з
some
оформленням
parts of the problems
документів
like
для
red tape
протезування,
or
ознайомлення із
documentation for
можливостями з
prosthetics,
державною програмою
or for example,
протезування,
how to work,
починаючи
how
від того,
to
що пацієнт має
enroll on
вільний
the
вибір в
state
Україні
program for
протезуватися в
prosthetics,
будь-якому
because the
протезному
patient is free
підприємстві.
to choose any
Інколи
prosthetics enterprise.
так само такі от розмови, чіткий,
In
скажімо так,
such
алгоритмний план
discussions,
для людини
the clear algorithm
усуває
for the
значно багато
person
сумнівів, проблем
removes
і
a lot
заважають
of doubts
реабілітації.
and
І
problems
от саме в
that
питанні
prevent
освіти
rehabilitation. And
і
when it comes to education
подальшого маршруту пацієнта,
and further route of the patient,
це в тому числі і роль кожного спеціаліста із
each
команди.
specialist
Навчання
plays their own
пацієнта
role. They
комунікації
have
є
to
дуже
teach
важливим
the patient
моментом
and
реабілітації.
communicate. This is very
Далі,
important
будь
in
ласка.
the process. Let's move on.
Про больовий синдром. Якщо ми
When it
говоримо
comes to
про
pain syndrome,
післяопераційний період, то
speaking of the post-operative period,
найчастіше больовий
more
синдром
often than not,
виражений в
patients
післяопераційному
face
періоді.
phantom pain, especially in the
Фантомний біль,
post-operative period.
скарги
This kind of
приблизно в
pain
79%
is
пацієнтів.
typical of
Біль
79%
епоксії,
of patients.
який
Stump
зберігається в
pain
подальшому, це
that
близько 39%. І
the
фантомне
patient may
відчуття
perceive later on
висловлюється
39%, and
приблизно 10%
phantom
пацієнтів з
sensations
ампутацією. Далі, будь
10%
ласка.
for the patients with amputations.
Тому стратегія лікування болю
This is why the
і
pain
підхід
healing
має бути
strategy and the
раціональним
approach
і
has to
обдуманим.
be rational and
Агресивне
well
лікування
grounded.
болю ще в
Aggressive
самий гострий
treatments of
період, як
pain
тільки
in
він
the most acute stage
з'являється,
as soon as it appears, leads to the fact that we mitigate the risk of this syndrome becoming chronic. We have a step-by-step approach starting with international recommendations and non-steroid medications and ending with more complex interventions. The first step, if we see the pain syndrome and the pain is mild, for example, 1 to 3 points, the VASH scale, and we have to monitor how severe this pain is. If it is a mild pain, we use non-steroid, non-opioid medications like paracetamol. If this is a moderate pain, 4 to 6 points on the scale, we can use weak opioids like codeine and tramadol. There are also good combinations of paracetamol with tramadol and codeine. If the pain syndrome is stuck, we have to use non-routine but post-operative short-term strong opioids like oxycodone, morphine, hydromorphine. It is important to add that at each of these stages we can add adjuvants, the drugs which enable you to adjust the pain syndrome unless the basic therapy is not sufficient. Like pregabalin, gabapentin can be used. But the basis is non-steroid drugs, anti-inflammatory drugs. Opioids, of course, have to be there. Another thing to consider, regional anesthesia. This is a good way to manage pain, which enables us as doctors to reduce pharmacological influence of opioids and reduce the use and the need for additional analgesics. Lasting blockades of peripheral nerves are recommended, and in case of the amputation at the level of the shin or transtibial area, such drugs are efficient for managing pain syndrome, like phantom pain and stump pain alike. The next slide, please. Likewise, pain management, I mentioned the pharmacological aspect. Evidence-based drugs that reduce phantom pain are not there. We use the protocols for neuropathic pain. We use anti-convulsive medications like pregabalin and gabapentin, antidepressants, amycretin and duloxetine, and opioids are recommended, though not routinely. NMDA receptor antagonists like ketamine can be used in ICU under the supervision of the anesthesiologist. And local anesthetics, if we speak about pharmacological treatment. If we have a chronic pain syndrome caused by neuroma, and neuroma often increases the likelihood and the strength of such pain. We have the blockages of peripheral nerves, even though those blockades are used mostly for diagnosis to confirm or disprove the diagnosis if we want to plan better tactics. For example, in case of neuroma, we may have radio frequency effect, and if this combination with the anesthetics does not yield relief, then surgical interventions may be needed. There are also studies which speak of botulinum toxin therapy, but there is the lack of the evidential base. A common method that we have in the world and here as well are non-medical, non-pharmacological ways to treat like acupuncture and mirror therapy. And they're the most popular methods amidst non-pharmacological methods. We can use transcutaneous electrical nerve stimulation or desensitizing the psychiatrics, cognitive behavioral therapy, distraction therapy, and relaxation techniques. Distraction therapy can be an efficient way for the patient.
This type of therapy, like distraction therapy, can be very effective for patients, especially in the late hours of the day when the phantom pain gets more acute and there are sleep problems. So this really helps. But this type of distraction therapy is very tailored. Sometimes even special cards can be used for this distraction therapy.
Ну от, як ви вже бачите,
As you can see
вкладки, про які я
from
говорила,
those
вони є
images, the
підходять
training
для
games and the
візуалізації, вони
cards
є
for
для незлітових
visualization,
кінцівок,
they are
в
for
разі
lower
чого,
and upper
в тому, що
extremities.
пацієнт
The idea is
повинен
that
повинен назвати, це права чи ліва
the
кінцівка.
patient has to
Там в
say
різних
whether this
положеннях
is
ви
left or
побачите
right
зображені
extremity,
або
and
стопа, або
there
наша
is
кисть.
either a
І
foot
пацієнт
or
має
a
за певний
wrist
проміжок часу
there. And over a
розкласти отаку
period of
колоду цих
time,
карт на
the
праву та
patient
ліву.
has to put the stack of
Враховується швидкість і
cards
кількість помилок,
left
які
and right,
робить пацієнт.
depending on the speed
Також
and the
наступним
number of
етапом можна
mistakes that
додавати
the patient makes.
спроби повторити фантомною
We
кінцівкою рух,
also
який зображений
can
на
ask
даних
him to
картках.
repeat the
І для багатьох
movement
насправді це
that
грає
is
роль більше
depicted on the
як
card. So this game for many
відволікаючої терапії.
patients is
Наступним
more of
етапом можна
distractive
пробувати,
character.
це
The
обов'язково
next
потрібно робити
stage,
або з психологом, або з
but
геротерапевтом,
it has to be done either with
візуалізувати
occupational therapist
кінцівку,
or the
закривати очі
psychologist, is
і
to visualize
уявити
the
образ,
extremity.
уявити
Close
свою
your eyes
кінцівку,
and
промалювавши її
imagine your
контури,
extremity by
починаючи від
drawing
пальчиків і
its
до плеча.
contours, starting
Такі
from
методики
fingers or toes,
використовуються за
ending with the
кордоном. Не з
shoulder.
кожним
These
пацієнтом
methods,
належно вони
techniques are
працюють,
used
але є
overseas.
виключні випадки.
It doesn't work for
Значить,
every patient, but there are
наступне це
success cases
акупунктура.
anyway.
Знову ж таки, в
Acupuncture,
даному випадку для
that's the next
менеджменту болю використовуємо також для
non-pharmacological
менеджменту сну,
treatment
порушення
of
сну.
phantom pain. Also,
Є
it
стимуляція. З
helps
міостимуляціями потрібно
the
бути досить
sleep
обережним, тому що
recovery.
якщо підібрати
Myostimulation, we
невідповідний
have to
режим,
be extra
міостимуляція може
careful because if we choose
викликати
the wrong
посилення
mode,
больового синдрому.
it can cause
Дзеркальна
the
терапія
increase of the pain
дає
syndrome.
можливість
Mirror
зробити
therapy allows
проекцію
the patient
втраченої кінцівки
to renew the
безпосередньо
projection of
в
the
центрах
lost
головного
extremity,
мозку,
especially in the
які раніше
brain,
відповідали за цю кінцівку. Таким
the
чином
parts of the brain that were
може
in
бути
charge of
зменшення
this
больового
limb.
синдрому. Знову ж таки,
In
дзеркальна
that
терапія
case,
працює
it
на
can
усіх.
increase, it can mitigate the pain, but
Компресійна
it doesn't
терапія.
work with every patient.
Компресійна
Compression therapy.
терапія
Compression
насправді
therapy
є ефективною в багатьох пацієнтів.
is
Багато з
pretty
пацієнтів
effective with
говорять про
multiple
те, що
patients,
еластична
many of
компресія
who say
протягом
that
нічного
elastic
періоду і перший день
compression at
рекомендується, як ви
nighttime
знаєте,
and
23 години
during
на
the
добу
evening,
перебувати в
you,
еластичній
you
компресії
understand that
створює відчуття
it's
захисту
recommended
і
to
зменшує фантомні відчуття.
be
І,
in the
звичайно,
compression
активність,
therapy
фізична
during the limited
активність,
period of
техніки
time, and it really
релаксації
helps. And
і
physical
так далі,
activity,
часто це можуть
relaxation
бути групові
techniques,
або
etc.
індивідуальні.
This could be
Далі, будь
team
ласка.
or individual exercises.
Період підготовки до протезування.
The
Що
period
тут
of
важливо?
preparation for
Далі.
prosthetics. What's important here?
Зменшення набряку кокси,
First
який
of
ми
all,
досягаємо
reducing
за рахунок
stump
еластичної
swelling
компресії.
due to elastic
Проводимо, продовжуємо,
compression.
коректуємо больовий синдром та
We are
худоровий
also
синдром, який
trying
часто дуже порушує
to control
функціонування
pain
пацієнта.
syndrome and phantom pain that
Покращення
affects the
мобільності та
patient,
забезпечення
improving
максимальної
mobility and
незалежності. Це
ensuring
те, що ми
maximum
починаємо ще в
independence.
післяопераційному
This is
періоді,
what we start in
періоді
post-operative
підготовки до
period
протезування.
and continue
Наша
throughout
основна
the
ціль
whole period
зробити
until
якомога швидше
prosthesis.
пацієнта
Our
максимально
main
незалежним від
objective is to
допомоги
make the patient as
оточуючих.
independent
Е,
as
Те,
possible
що
from the
можливо
care and
реалістично
nurture
його
of the
навчити, і
environment.
що
What
можливо
we can
йому допомогти, тому
realistically
що є такі
do, how
випадки,
we can train him,
як ви
what
вже
we
бачили,
can
наприклад,
assist him
втратою
with,
зору, потрійними
because
ампутаціями,
you've
коли все ж
seen
таки
that there
людина
are,
не
for
може бути
example,
повністю
trilateral amputations, the loss of
не можемо
eyesight, and
зробити повністю незалежним,
we
все одно вона
can't make the
потребуватиме
person 100%
допомоги оточуючих.
independent. They will need assistance
Мобільності це
of their
пересідання з
family and
ліжка на
loved
візок,
ones.
з ліжка на
Mobility.
крісло
So
колісне
this
і
is
навпаки.
transfer
Це
from the
можливість
bed
самостійно
to the
пересідати в
wheelchair,
туалеті, вертикалізація
transfer to the
пацієнта
toilet,
спершу
verticalization
із
of the
ходунками,
patient,
з милицями, з допомогою спеціальних
using
засобів
steps,
пневматичних,
crutches,
інших систем.
using different pneumatic
Відчуття
means
цієї
that I'm going to
незалежності
talk about
насправді для
later. The
пацієнта є
feeling of being
психологічно дуже важливим
independent
моментом. І якщо
is a
навіть ми
very
бачимо
important psychological factor for the
надмірну
patient.
гіперопіку зі сторони
If we
родичів,
see that there
обов'язково
is
потрібно проводити
hypercare from
освіту
the
і
family, we
пояснювати, для
have
чого це важливо
to
пацієнту, чому
educate
не
them, we
варто
have to
родичам
explain why
перебирати
it's
занадто
important for the
багато в
patient,
плані
why
допомоги пацієнту.
family cannot take too much
Е,
care of the patient and
Продовжуємо
over nurture
профілактику
them.
контрактур, покращення
We
обсягу руху суглобів
also
та інших
do the
кінцівок.
contracture
Обов'язково розповідаємо пацієнту,
prophylaxis.
що погіршує, що
We
сприяє формуванню контрактур,
talk
і
to
що
the
він має робити,
patient
щоб цього
about the
уникнути.
risks
Там не
of
підкладати
contracture
подушку
and
під,
what
під
should be done
суглоби,
to avoid it. For example, do
користуватися
not put the
кріслом
cushion
колісним з
under the
підставкою, яка
joint.
дає
Do
можливість
not use the
тримати кінцівку
wheelchair
під
with the
ногою.
holder
Якщо
that
це ампутація
allows
стегна, лежати
the
не менше
extension
2
of
годин
the
на допоміжній
extremity
і
if this is
так
hip
далі.
amputation. So you should not lie
Наступне
on your
це
belly
покращення низової сили
for
та
longer than
грамотності
2
фізичних вправ
hours.
та рівноваги. Якщо в людини було важке
Uh,
поранення,
improving muscle strength,
дуже
exercise
часто
tolerance, and
страждає
balance. If the person has sustained severe
серцево-судинна
injury,
система, загальне
then
зниження толерантності і
cardiovascular
зниження
system
низової
is
сили
affected
кінцівок і
because
так
of
далі.
the
Тому ми
um,
працюємо не лише на збільшення низової
tolerance.
сили кукси, а й на
That's why
низової
we are
сили
not only
з
trying
інших
to
кінцівок, які
improve the muscle
допомагатимуть
strength of the
пацієнту далі
stump, but also other
мобілізуватися,
extremities that
активізуватися
will help
м'язів
the
пресу,
patient mobilize,
м'язів спини
verticalize
і так
the
далі.
strength of muscles of the
Проводимо
abdominal
менеджмент
muscles,
рубця, як тільки
shoulder muscles, etc.
знімаються
We
шви,
also do scar management.
еластичне
Once the
рубець, яка
sutures
зазнав
are
запалення,
removed, there is the
починаємо
elastic
проводити
scar without any inflammation
десенситизацію його,
signs.
масаж,
We start doing
мобілізацію тканин для
desensitization,
того, щоб не
massage,
покращувати
tissue
із задавленими
mobilization in
тканинами.
order to avoid
Покращуємо
adherences.
порозкітість кукси і, як
We
я вже
also
сказала,
are trying to
починаючи з
improve the
гострого
resistance of the
періоду,
stump, starting from the
робота
acute
із
period.
до спостереження психолога і
We
освіта
monitor the
родичів та
patient,
пацієнта.
the
Що важливо, це
psychologist
залучати
monitors
ще
the patient, and also the education of the
родичів.
patient and the
Родичі
relatives. It's important to involve the
інколи
family of the
насправді
patient.
своєю
Oftentimes,
турботою, гіперопікою,
patients with their
неможливістю
overcare,
контролювати
with
свої почуття,
their
можуть створювати досить
impossibility
значний
to
дискомфорт
control
психологічний
their
для
demeanor
пацієнта.
and their feelings can cause
Тому інколи
significant
навіть
discomfort for the patient.
робота з
Therefore,
психологом
working
безпосередньо
with the
як може бути
psychologist
індивідуально з пацієнтом, так і
could be
робота
individual for the
з іншим
patient
психологом групова
and
для членів
also
сім'ї.
for the family. So it could be
Наступний
group
слайд, прошу.
session, patient and family together.
Ну, от це приблизно як виглядає підготовка до протезування.
This
Те,
is
що я
preparation
сказала
for
вже, це
prosthesis,
компресійна терапія, тренування навичок
compression
мобільності,
therapy,
користування кріслом колісним,
mobility
підбір
skills,
допоміжних засобів реабілітації, є
wheelchair,
надзвичайно важливим.
assistive aid
І, як ви бачите,
selection, which is
максимальна
very
незалежність
important,
пацієнта, ще навіть коли він не має
independence of
протезів,
the
на як у випадку,
patient,
наприклад, з
even
пацієнта
without
з парною
prosthesis,
ампутацією
before
верхніх
the
кінцівок,
prosthesis,
але
even if
інколи
there is
навіть звичайний
bilateral
просто девайс
amputation
може
of the
дати
upper
йому
extremities, simple
значну
devices
незалежність, можливість займатися
can
повсякденною
provide him
повсякденними
independence.
справами,
The
такими як
patient can
самостійно їсти, пити, чистити
do the
зуби
chores,
і так далі.
for example,
І
brush the teeth,
вертикалізація
have
надзвичайно
meals,
важлива,
etc.
якщо
And
особливо, якщо ми,
verticalization is
як я
very
вже сказала,
important
комбінованої травми в нас
if
багато.
there is no combined trauma that I had mentioned earlier.
Співпрацювати з травматологом в плані того, щоб ми могли
Working with the
навантажувати
trauma
кінцівку. Інколи
doctor
для
is
того, щоб
really
ми могли
important to
навантажити
put the load on
іншу
the
кінцівку, у
extremity
разі
so
якщо
that
одна із них
we should
ампутована,
also put the load on another
потрібне
extremity if the
оперативне
other one
втручання з
is
відповідною
amputated.
релаксацією і так
So
далі. Саме
sometimes we
тому
need
протягом свого реабілітаційного періоду робота з травматологом, співпраця з травматологом
to work with
проводиться
the
постійно. Далі, будь
traumatologist
ласка.
during the rehabilitation period. So this work has to be continuous.
Рання вертикалізація. На даному слайді
Early
ви бачите два
verticalization.
пристрої, які ми
Here you
використовуємо
see two
в періоді
devices
підготовки
that
до
we
протезування.
use
Це
in the
пневматичний
period
пристрій
of
для покращення
preparation.
мобільності
This
PPM
is
і
pneumatic
фемурет. Це для
device
пацієнтів з
PPM,
ампутаціями на
and
рівні стегна.
the other one is for the
Ми для себе
patients who
відкрили, що це
have
надзвичайно
hip
круті речі в
amputation,
реабілітації. І
hip level
за
amputation.
нашими
These are really
спостереженнями, у
cool
випадку, якщо
assistive
пацієнт
devices in
починає користуватися цими
rehabilitation.
приладами,
When the patient starts
етап
using those
протезування проходить
devices,
значно легше
the
та набагато
prosthetics
швидше людина
stage is
адаптується до
easier,
протезу.
and the
Загалом,
period
якщо
of adaptation is way
згідно
shorter.
інструкції, ці засоби,
According to
наприклад,
the
PPM, можна
guidelines,
використовувати
for
ще після
example,
операційному
PPM
періоді.
can also
Однак,
be used in
зважаючи на
post-operative
природу травми, на
period.
складність травми, чи
But
це
given the
мінне
nature
поранення,
of
чи
the
це
trauma,
поранення,
the
яке
complexity
потребує
of the
постійної
trauma, be it
перев'язки і так
blast
далі,
injury
ми
or the injury
використовуємо
that
такі
requires
прилади
constant
лише
change of
після
bandage,
загоєння
we
ран
recommend using
та
such
зняття
devices
швів.
only after the full healing of
Тобто в
the
період,
wound
як тільки
and
зняли
removing
шви,
of
і
stitches. Once the stitches
там
are
2-3 дня,
removed,
якщо все окей, ми
2-3
починаємо
days later, if
вертикалізувати
everything is
пацієнта з
fine, we
допомогою цих
start
засобів.
verticalization of the
Як
patient
бачите,
using
їх
those
налаштовує фізичний терапевт.
devices.
Для цього нам навіть не
Physical
потрібні
therapist
втручання
is doing all
протезиста.
the
І
management and settings. We
бачимо
don't
значне
even need a
покращення
PO
балансу,
specialist to be involved
рівноправ'я в
here. You see
пацієнтів,
that the
розуміння
stance and the
біомеханіки
balance
ходьби,
is better,
звикання
the
до кси
biomechanics
безпосередньо
of the
до
gait is
тиску. І варто
better.
додати, що
So the
починаємо
stump
інколи
is
від
getting
50
used to the
хвилин.
pressure.
І
Sometimes we
от
start
в
from
більшості
5-10
тренувань
minutes, and
проходить
in most
в
cases, the
брусах, можна там
training
до 2 годин
is done in the parallel
Далі, будь
bars,
ласка.
and the duration is 2 to 3 hours per day.
Асистивні девайси – це якраз ті
The
речі,
role of
які дають
assisting
можливість
devices. So these are
пацієнтам
the things that enable the
максимально
patient
рано
to
здобути певну
start
незалежність у
living
виконанні
life
повсякденної
in
діяльності.
early stages and be
Те, про що я
independent in
говорила,
their
рання
daily
незалежність пацієнта від
activity
допомоги
and
оточуючих.
chores. So this is what I had
Вони
mentioned
можуть бути
earlier,
дуже
the
різні.
independence of the patient.
Його може виготовити
So these
фізичний терапевт
assistive
самостійно,
devices could
можемо
be different,
використовувати
so they
та
can be made by the
модифікувати
physical therapist.
наявні
We
ранні
can
протези,
use
такі
and
як
modify
софт-протези, наприклад,
the
які ви бачите для
early
прийому
prosthesis,
їжі, а також
soft
для
prosthesis, for example. This
пацієнта,
is
оце що
used
нижче
for
за
having
софт-протез,
meals.
якщо ви бачите,
And
із
below you see the patient
ракеткою
with the
для
soft
настільного
prosthesis.
тенісу.
So basically,
Саме
this is
цю річ
the
використовував
ping
наш
pong
пацієнт з
rocket,
білатеральною
and
ампутацією верхніх кінцівок на
this
рівні
device
верхніх
was
клітинного
used by the
площей.
patient with the bilateral
Це стало
amputation
дуже
of the high
хорошим таким
extremity at the humeral
мотиваційним
level. So that was a great
мотиваційним
motivational
моментом для пацієнта.
factor for the
Значно
patient.
покращило його психологічний стан.
It improved the patient's
Можливість
psychological
займатися
state.
своїм хобі
It
це
enabled the
насправді
patient to
такий
pursue
дуже важливий
his hobby.
лайфхак в реабілітації, який ми
It's a
повинні
very important
обов'язково
thing
включати
in
в нашу
rehabilitation
індивідуальну
process that
програму.
has to be integrated into
Після
our
того, як
individual
пацієнт
tailored program.
почав
After
грати
the
настільний
patient
теніс, а він робив це
started playing
набагато,
ping pong
він
again,
займався цим і до
and that
поранення,
was something he did before the
він
injury a lot,
разом зі своїм сином,
together with
коли
his
спробував
son,
грати в настільний теніс,
when he tried
це
playing ping
потрібно просто
pong.
було бачити
You
його
should have
очі,
seen
які
his
загорілися.
face, his beaming
Це
eyes.
повернення якоїсь там частинки віри знову в себе і так далі.
So part of him was
Будь-який такий момент,
reborn
який дає
and
позитивний
revived again.
результат і
Anything that
без, скажімо
offers
так,
positive
безхідних
outcomes
сподівань,
without
дає нам
false
дуже багато переваг.
expectations
Наступне
gives
це знову
us
ж таки для
major
цього
advantages.
пацієнта це наші ерготерапевти. З
Same very
простих речей
patient,
не
our
обов'язково
occupational
величезне обладнання, як
therapists,
ви бачите,
they
абсолютно
would
прості
use
речі
really
зробили
simple things that are kicking
девайс для
around, so you don't
очищення
need to
зубів,
use
для того, щоб
anything
пацієнт міг
expensive. So
чистити,
this is the
чистити
device
зуби
for
самостійно.
brushing teeth, so that the
І
patient could brush the teeth
наступне виглядає досить
independently.
дивно, але насправді
The
це
next
дуже
one
класна
looks weird,
функціональна річ, за
but
допомогою
it's a
якої пацієнт
very
самостійно в туалеті
functional
може
device
одягнути та
that would help
зняти
the
одяг.
patient
Знову ж таки,
to
речі
don and
прості,
off
не
his
потребують великої
clothes
кількості
in
грошей,
the
потребують
bathroom. So
лише,
it's very simple
скажімо так,
thing,
спроби,
doesn't require a
творчості
lot of money.
від
Just what you need is
ерготерапевтів та
creativity. You need to
мультидисциплінарної
try,
команди
and you
і
need to
пацієнта.
involve occupational
Далі,
therapist
будь
and
ласка.
multidisciplinary team and the patient.
Максимальна незалежність, як я вже казала, покращує психологічний
Independence as much
стан,
as possible,
мобільність і,
improving
що
psychological
важливо,
state,
зменшує
mobility, and
потребу в
what is
залученні
important, it
професійного
reduces
догляду членів сім'ї та персоналу.
the need
Тобто, поки
for the
пацієнт
staff and family
обідає,
members to
людина,
be
яка
involved in
поруч
the
з ним,
process.
дружина
So,
чи
wife,
родичі, які йому постійно
relatives
допомагають, має
that
теж
constantly
можливість
help also
спокійно
have this
прийняти їжу,
chance
попити
to have a
чаю,
meal
просто розвантажитися,
and a calm atmosphere, drink
що
some
для них
tea,
теж є дуже
and
важливим.
unload
Ну, тут приклад, як працює наш
themselves, which
фізичний
is also
терапевт
very important. This is how our physical
і
therapist
ерготерапевт над
and
навичками
occupational
покращення
therapist
незалежності
help to
та
improve the
повсякденного
independent
функціонування.
skills
Далі, будь
for the
ласка.
patient. Proceed.
Хобі, як я вже
Mental
говорила,
health
і
includes
активність,
hobbies
розмови про
and
те,
just
чим пацієнт буде
activity,
займатися далі в майбутньому,
discussing what the patient will be
важливо
doing in the
починати
future. It
якомога
is
раніше.
important that we start
Сіяти
doing that
зерно
as
думки
early
про
as
те,
possible. We need
що
to
буде після
sow
того,
the
коли я
grains
пройду
of
цей
this
шлях,
idea. What
потрібно
happens
якомога
when I cover
раніше,
this path?
ще далеко до того, навіть коли
It has
пацієнт
to be done
отримує
way before the
протез.
patient receives the
Залучати
prosthesis.
його
You have
до
to
різних видів
engage the
активності,
patient
діяльності,
in different
особливо
kinds of
тих,
activities,
які,
especially those
які сприятимуть
that
досягненню його
will
безпосередньо його
contribute to
цілей.
achieving the
Будь-яка
goals
дія,
directly.
будь-яке наше призначення, в тому
Any
числі
action,
призначення
any
рекреаційної
prescription,
терапії, має мати
including recreation
під
therapy,
собою певну мету, для чого ми це
need to
робимо.
have a specific goal
У
underneath.
нас в госпіталі є дуже
At
великий,
our
скажімо
hospital,
так, вибір
we
можливостей
have
для
a
пацієнта,
wide
де вони
choice for
можуть
our patients
займатися
where they can
плаванням, рибалка,
swim,
адаптивні види спорту, такі як
fish. There are
стрільба
adaptive
з
kinds of
лука,
sports like
катання
archery,
верхи,
horse
катання
riding,
на конях і так далі. І дуже важливим
and the like.
також є те, що зараз ми почали більш активно
Importantly, we have
включатися
also
безпосередньо
started being more
включати
included
пацієнтів в професійну
and
орієнтацію,
involve
професійну
patients in
зайнятість, зокрема такі як,
vocational
наприклад, курси
activities like
навчання
courses
dronів, пацієнти, які
like drone
хочуть
train, for
продовжити
example,
службу,
when patients
або
want to
навіть які в
continue with the
ролі
service.
цивільної людини
For example, when
хочуть
they may
пов'язати все
want
одно
as
своє
civilians
життя
to
із
relate
допомогою
their
української армії
lives
і розуміти, що вони
to the
продовжують
Ukrainian
робити щось
army.
важливе,
And if they understand
мають
they
можливість пройти навчальні
can do
курси
something
дронів
important,
із подальшим
they have a
працевлаштуванням,
chance to enroll on such
що є
courses
надзвичайно
and
круто.
receive job opportunities, which is
Англійська,
very
курси
cool.
програмування і так далі.
English coding courses,
Залежно від організації, в різних
depending on the
центрах цим
organization, different
займаються різні люди.
centers
В нашому випадку ми маємо працівника
allocate different
цивільно-військового
people for these
співробітництва,
purposes.
який
We have
повністю
the
покриває цей
worker
напрямок,
for
який займається
civilian and military
комунікаціями із волонтерами та
area, and
організаціями,
that
які
specialist
допомагають нам
covers
все
all the
це реалізувати.
communication and
І
coordination,
дуже
including with
крутим одним із напрямків, який
volunteers.
нещодавно
One cool
ми
area
почали, який
we've just
розвинувся тільки цього року, це
developed this year
парахокей.
is
І
para hockey.
бачите на фото, тут половина команди це
As you can
пацієнти
see
нашого
in this
відділення,
photo, half of this
які,
team are the patients from
яких вже
our
відібрали до
department.
національної збірної України,
They were
які будуть
selected for the
представляти
national
її на
Ukrainian team and
міжнародних
they will
змаганнях.
represent our
І
country
для багатьох
at the international
заняття
competitions.
спортом
In
є
general,
дуже класним
sports
стимулом рухатися
is a
вперед,
cool
рухатися
stimulus
далі,
to move
доводити
on,
самому собі,
to
що
prove to
я
yourself
можу більше.
that you can do more.
Тому залучайте волонтерів, залучайте
So
організації для
engage
того, щоб
volunteers and organizations,
пацієнти мали змогу
reach out to them
саме
so
займатися
patients
своєю
get a
улюбленою
chance
справою.
to take part in their favorite activity that in the future will help these patients to find new job opportunities. Let's move on.
Період протезування. Тут дуже багато моментів.
Prosthetics periods. There are a lot of points to consider here.
Тренування ходьби в протезах,
Gait training
як ви
and
бачите,
prostheses.
починаємо ми із брусів і
We start
потихеньку, як
with
пацієнт готовий, може
bars,
переміщуватись безпечно в брусах,
and the
фізичний
patient
терапевт
may be able to
розширює
move
тренування,
using these bars.
ходьба в межах
Then
відділення, ходьба
training
по пересічній
is
місцевості,
expanded
сходи
in
пандуси і
rugged
так далі.
terrain
Саме
with
найперше,
ramps and
що
stairs.
також робить фізичний
First,
терапевт, це
what the
навчання
physical
правильному
therapist
падінню
does,
та підйому.
they teach the patient
Якщо це в
how
разі
to pull
ампутації
down
гомілки,
and
так, можливо,
stand up
простіше
again.
піднятися.
In
Якщо це
case of the
пацієнт з
amputation,
ампутацією стегна, потрібно
it may
знати, як це
be
правильно зробити.
easy,
Якщо
fairly
це
easy to
пацієнт із парної
stand up,
ампутації,
but when this is the
то
hip
звичайним способом, як
amputation
ми
or
звикли підніматися, він не зможе.
double
Тому
amputation,
перше,
bilateral
що
amputation, it
завжди
will be
навчають
hard for
фізичний
the patient
терапевт,
to
це
stand up.
безпечному
So the
підйому.
physical therapist
Також ви
teaches
бачите
how
тут на
to
слайдах
stand up
коротенькі
safely.
протези, які
This slide
називаються
also shows
це зі
short
стабісами, ці
prostheses
маленькі стопи
with
називаються стабіси.
stubbies,
І
these small feet.
ми їх використовуємо
We use them
в період до моменту, поки пацієнт
just
не
before the
покращиться його
patient
баланс,
improves
толерантність до
balancing,
навантажень,
load
звикання до
tolerance,
тиску куксоприймачів, до навантаження
until the
ходьби.
patient gets used to
Такий період
stump
ходьби на цих
sockets.
стабісах може бути до 4 місяців
Stubbies
в середньому.
can be used for 4
Як
months
тільки
on
пацієнт
average.
готовий,
As soon as the patient is ready,
можна переходити до
we
використання
can
вже
move
більш функціональних
with
протезів
more functional prostheses,
з колінними механізмами,
with
які
knee
можуть бути як
mechanisms
гідравлічні, так і
like
електронні.
hydraulic and
Так,
electrical ones,
колінні механізми з зовнішнім
the knee
джерелом
mechanisms
живлення.
with external
Знову ж таки,
power
потрібно
source.
пам'ятаємо про те, що навчання
We have to remember
володіння кріслом колісним, підбір
that
крісла колісного є
mastering
надзвичайно
the
важливим,
use of
особливо для
wheelchair and the
пацієнтів з
selection of
парною
wheelchair
ампутацією на
is very
рівні
important, especially for
стегна.
bilateral amputation and the level of thighs.
Далі, будь ласка. На даному слайді ви бачите, це наш пацієнт
This slide
із
shows a
подвійною
patient
ампутацією.
with triple
Верхня, одна
amputation,
нижня, на рівні гомілки. Гомілка,
one
там
upper and
протез, там коротка кукса.
two upper and
Приблизно 3
one lower,
сантиметри
three
великої гомілкової
centimeters
кістки. Тут є
of
проблеми технічні із
femur,
протезом.
of
В пацієнта
tibia
була
preserved.
черепно-мозкова травма,
There was a complex
травматичне
brain
ураження
injury,
обох очей
traumatic
з повною втратою зору.
injury to eyes with full
Ми
eyesight
залучали
loss.
також тренера із
We involved
орієнтації,
the
а також
orientation
протезистів, які
coach and
допомогли зробити ось такий девайс для того,
prosthetists
щоб
who
він
helped
міг
to create such a device for the patient
тренувати навички ходьби.
to be able to train gait
Звичайно,
skills.
в період підготовки до протезування
In the preparatory
пацієнт
process, the
перший стан
patient,
на протезі пройшов дуже
before
багато
standing on
кроків,
the prosthesis,
починаючи від
covered a lot of
орієнтування у
steps,
кімнаті, де
starting
він
with the
перебуває на
room
лікуванні.
orientation.
Ерготерапевти навчали, як
Occupational
безпечно
therapists
дістатися
would
до
teach the
ванної
patient
кімнати, як
to
орієнтуватися,
reach to
самостійно
the bathroom, how to
пересідати.
orient,
Він
how to
може самостійно
transfer, how
пересуватися
to
ванною кімнатою,
sit down,
переміщуватися в межах
how to use the
відділення,
bathroom,
самостійно
how
їздити
to
на
move
кухню. Але знову ж
within
таки,
the department. The patient
як
is
я
able
вже
to reach the
сказала,
kitchen on his
100%
own.
бути
But
незалежним
as
від
I
допомоги
mentioned,
оточуючих, на
being
жаль, в цьому
fully
випадку
independent in this case
досягти не вдасться.
is not possible.
Далі, будь ласка.
Let's move on.
Так виглядає тренування ходьби на стабіс.
Stubbies gait training, this is what it looks like.
Двобічною трансфеморальною ампутацією, верхня третина
Bilateral
та нижня третина
transfemoral
стегна.
amputation.
Причому зверніть увагу на рентгенівський знімок.
As you can see on the
Масивний
X-ray
ортопедичний
scanning,
масифікат на косі
massive.
правого стегна, але тим не
Well, on
менше
the right thigh we have
пацієнту
the stump,
це
but for the patient,
були
this
нас
condition,
застереження з приводу
well,
подальшого
we
протезування.
were
Деякі
worried about
протезисти
further
радили
prosthetics process.
навіть
Some
оперативне втручання.
specialists
Однак, коли стоїть
would
якась
advise even
проблема,
surgical
дуже
interventions. But
важливо
when we face a problem,
залучити
it is
кілька
important to
думок
involve
спеціалістів
a
з
couple
цього
of
приводу, щоб прийти
opinions
до
from
раціонального
specialists
рішення.
to
Однак спробували
end up with a
протезування,
rational
протезист
solution.
Звичайно, дуже багато працював над
Of
коксопромачем
course,
і протезами,
a
і
lot of
оперативного
work were
втручання
done
вдалося
on
оминути. Пацієнт
the
зараз уже ходить
stump sockets,
ходить на протезах,
and
больових
the patient
відчуттів
is able
у
to
нього
walk on
немає. І
these
насправді оцей от гідропіхічний
prostheses, no
осифікат, який є в
pain
коксі, він не
sensations,
заважає протезуванню на даний момент. Хоча на
and there's
знімку
no
виглядає,
problem with
звичайно,
prosthetics, even though this image
як таким, що може бути перешкодою. Далі, будь ласка.
may show you that there are
Заміна
obstacles.
методу фіксації важливий момент
Replacing
для того, щоб ми
fixation method
могли
is very important
прогресувати, для того, щоб ми
to
могли
ensure
навантажувати
progress,
кінцівку,
to
яка
load
у нас
the
збережена в
limb
подальшому.
that is
На
intact
жаль,
for the
одноосіві,
future.
наприклад, апарати зовнішньої фіксації, вони не
One
дають можливості
external
цього
fixation
зробити.
apparatus
І
does not
якщо у
allow
пацієнта
you
інша
to do
кінцівка
this. And
ампутована
if
високо, то
another limb
це
is
призводить до
amputated
значного
high,
розтягнення
it leads
реабілітаційного
to
періоду
extension
в
of
часі,
the
затримки
rehabilitation
реабілітації через
period,
те, що
the
ми не
delay in
можемо
rehabilitation,
навантажити іншу
because
кінцівку.
we cannot load the other limb.
Далі, будь ласка.
Let's move on.
Ну, от, власне, це пацієнт, знімки якого ви бачили на
This is the
попередньому
patient
слайді,
whose
з
images you saw on the previous slide.
білатеральною
Bilateral
ампутацією на рівні голівок
amputation
та
at the
переломом
level of
стегнової кістки,
ankles
який був тривалий
and the
час лікований
fracture
апаратом
of the
зовнішньої
thigh
фіксації з
bone.
монтажем,
There was
перемонтажем
external
часовим,
fixation
без ознак консолідації
with
протягом
remounting
6
with no
місяців.
consolidation
І
for 6 months. Decision was
було
taken
прийнято рішення про заміну методу
to
фіксації,
replace the
постановку
fixation
електромагнітного
method
стержня.
to
І от ви
insert
бачите прогрес
intermodular
пацієнта, тому що, на
pin.
жаль, АЗФ, який був в нього до того, він заважав
And sadly,
рухливості, остання його
in this
модифікація
previous
заважала
case, the previous
рухливості
modification
в
did not
кульшовому
allow for
суглобі.
the
Ми не
mobility in
могли,
the hip
пацієнт не
joint.
міг перебувати
The patient was not
в
able
розігнутому положенні
to
в
remain in the
кульшовому
unbent
суглобі
condition
довше
in
кількох
the hip
хвилин, не могли одягнути
joint
протези,
more than a couple of
не
minutes.
могли
We were not
продовжувати
able
тренування.
to put
І
on the
було прийнято спільне
prosthesis.
рішення з травматологом
The
про заміну
training was not
методу
possible.
фіксації.
The decision with the trauma
І
doctor was taken to
після
replace the
цього
fixation
пішов
methods, and
досить
afterwards
швидкий прогрес
there was a,
пацієнта в
quite a
ході.
fast
Далі, будь ласка.
progress in gait.
Тут я хочу поговорити про
Here I want to
екзартикуляцію.
mention
Насправді
disarticulation.
ампутація складна, потребує значних
This is a
зусиль
complex
і
amputation,
кваліфікації
requires a
протезиста.
lot of effort,
Найважливішою
and
деталею в
for
такому протезі, при такому типі
prosthetists
ампутації,
in
звичайно,
such
є
a case of
коксоприймач.
amputation,
Зручний коксоприймач,
a stump
правильна
socket is
схема
very
протезу
important. The correct
дає
prosthesis
дуже
scheme
великі результати. І ось ви бачите, як наш
gives you
пацієнт
great
ходить
results.
перший
And as you
тиждень
can see, our
після
patient
отримання
in his very first
протезу.
week
Все
after
завдяки насправді тому,
the
що
prosthesis is able to walk. And
протез,
this is because the
який
prosthesis
встановили пацієнту,
inserted
був зручним як
was
коксоприймач,
comfortable. Well,
так і
the stump socket
безпосередньо
was comfortable, and the same
була встановлена вісь протезу правильно.
goes
Далі, будь
for
ласка.
the correct insertion of the axis.
Колісне я вже зупинятися не буду.
Wheelchair,
Знову
I
ж
will
таки,
not
тільки наведу приклад
stop
із
here.
про
I
те,
will just
що
show an
близько
example that
22% згідно
around
досліджень серед
22%
ветеранів
based on
В'єтнаму,
research
лише
among
22 є
Vietnam
активними
veterans,
користувачами
only
протезів.
22%
Більшість з них
are active
потребують
users
догляду.
of the
Підбір крісла
prosthesis.
колісного, а воно має бути активне, і його
The wheelchair
повинні
has to be active.
обов'язково прописати
It has to be
мультидисциплінарна
prescribed
команда у
by the
переліку з ліків,
multidisciplinary
які
team
необхідні пацієнту.
in the list of the means
Підбір
needed
під
for the
нього
patient.
є надзвичайно
The
важливим.
selection is very important.
І активне крісло колісне, в нього є
Active
багато
wheelchair
переваг над кріслом
has a lot of
колісним з
advantages
електроприводом
over
насправді.
electrical wheelchair.
Так, звичайно, це дуже індивідуально,
It is all
але
individual, of course,
не забувайте, будь ласка, про цей
but
момент.
do not forget
Тренування
about
навичок
this.
ходьби і
Gait training
забезпечення
skills and
кріслом колісним
ensuring
має бути якомога
and
раніше.
providing a wheelchair has to be as early as possible.
Протез повинен відповідати
A
функціональним
prosthesis
цілям
has to meet the
пацієнта,
functional goals of
інакше
the
він не буде
patient.
використовуватися.
Otherwise,
Про це
the
вже,
patient
мабуть, ви
will not
теж
use
багато
it.
чули.
You may have
Не
heard about
завжди
this.
те, що виглядає красиво і
It
сучасно,
may look
є
nice and
найкращим
modern,
вибором
but
для
it may not
пацієнта.
necessarily be the best choice for
Насправді,
the
хуки,
patient.
які ви бачите на
The hooks that you
відео,
can see
механічні тягові
in the
протези,
video,
для багатьох
mechanical
пацієнтів вони
prosthesis for many
є
patients,
вони є надзвичайно функціональними,
are
більш функціональними, ніж
extremely
безпосередньо
functional, even
біонічні
more functional
ті
compared to
самі
bionic
протези з зовнішнім джерелом
prostheses
живлення,
with the
особливо
external
що стосується
power
пацієнтів, які
source
хочуть
when it comes to
повернутися
patients, especially
до
that
військової
want to
служби.
come back to service.
Просто моделюючи ситуацію на
And
полі бою,
when you
якщо
imagine a situation on the battlefield,
військовослужбовець має
when a serviceman
так звану біонічну кисть, яка в
has a
якийсь
so-called
момент внаслідок
bionic
вологи
wrist
або
that at a certain
розрядки
moment, as a
акумулятора
result of
просто
humidity
випадає з роботи.
or when the battery
Відповідно,
dies, just
людина
stops working.
повністю
And as a
виключається з
result, the person
можливостей
does not
виконувати те,
have
що
the
вона робила до
abilities
цього,
to carry
виконувати
out
свої
the tasks
завдання і так
as
далі.
before.
І відповідно, якщо ми
A-
говоримо про
And
ремонт
when we speak of the repair works,
такого
when we speak
протезу,
of the repair of
то це
such a
вимагатиме
prosthesis,
часу від
this
кількох
will
місяців і так далі.
require a couple of months anon.
Механічні протези, військовослужбовці і тягові
Mechanical
використовують набагато
prostheses
частіше в умовах
are used
бойових
more
дій,
often
ніж
in
біонічні
combat
протези.
actions
Тому для
compared to
кожного
bionic
виду активності, для
prostheses.
кожної діяльності,
So each kind of activity,
до кожного пацієнта має бути індивідуальний підхід. Не завжди те,
Basically,
що
every
виглядає
patient
природньо, те, що
requires
виглядає
tailored
сучасно, як наша
approach.
кість,
What
буде
looks natural, what
функціональним.
looks
Інколи
contemporary, just like our wrist,
для людини
may
важливий
not
просто
always be
косметичний вид
functional. What's
кінцівки,
important for the person is just to have the
наприклад,
cosmetically
при високих
um,
ампутаціях, або якщо в нас є
fit
дисарткуляція плечового суглобу, і
extremity. If we
коли
have this articulation
звичайне
of
порівнювання
humeral
симетрії тіла
shoulder
може
and
значити
alignment
приблизно
and the
більше
symmetry of the
радикулювації,
body
широчина м'язів
might
і так далі. Не
reduce
всім
the
підходить один і
pain
той же
syndrome.
тип
Not
протезу.
everybody, so there
Абсолютно
is
від
no one
пацієнта до
size
пацієнта
fits
це також буде
all
відрізнятися.
prosthesis. So it depends on the individual needs
Тим не
of the
менше, який
patient.
протез не був, якщо в нас збережена одна кінцівка
Whatever
верхня,
prosthesis you
прихильність до
offer,
протезу
if
складає
you save at least
30%.
one limb,
Це
so the
говорить, це
in case of
відбувається тому,
unilateral
що
amputation,
людина дуже
commitment
швидко
to use
звикає
any type of
вести
prosthesis makes
своє
between
активне
43
життя,
to
виконувати
83%.
всю свою
People
роботу
are
з
getting
однією
used to their
збереженою
daily
кінцівкою.
routines.
І чим
They can be
більше часу
operational with
проходить від моменту
one
травми, тим менша
preserved
ймовірність того, що пацієнт в
extremity.
подальшому буде
So,
використовувати протез верхньої кінцівки.
and the
Це я
earlier
маю
the
на увазі більше
intervention, the
стосується
better the
ампутації на
result.
рівні
I mean,
плеча.
I'm talking
Маю на увазі.
about humeral amputation in this case.
Ось тут наведені ускладнення, які
Here
найчастіше
are
ми
some of the
бачимо після
complications
ампутації.
that
Це
we come across
симптоматичні
following the
невриноми.
amputation. This is
57%
symptomatic
пацієнтів
neuroma.
потребують оперативного втручання.
27%
Невринома
of the
це
patients need
болючі
surgical
утворення,
intervention. So these are
болючі утворення нервів, яке виникає після
um,
пересічення, після
painful nerves
процедури
after the
ампутації.
dissection,
Вони є
after
у
the
всіх 100%.
amputation.
Але біль,
Basically,
больові відчуття генерує
100% of
лише частина.
patients
І от та
face
частина,
it, but only
та
part of them
симптоматичного
have these
неврону, які викликають
pain
больові відчуття у
syndromes.
спокої.
And these
При
symptomatic
користуванні протезом,
neuromas,
яке не
in
регулює
the
знижуючи
quiet
загальних
state,
симптомів,
when they use the
модифікувати
prosthesis,
протез. В таких
after
випадках,
the
так,
modification of
ми
prosthesis,
звертаємося до
numerous cases.
хірургічної
In such
методики
cases,
лікування неврином.
we adhere
Якщо в
to
нас тільки
surgical
початкові
intervention
прояви
of
невриному,
neuroma
і це
management.
можна
If this is
скоректувати
the early
усунувачем,
stage
зробити
and
так,
you
щоб не
can
було знову
correct
тиску
it
на
with
невриному
the
і так далі,
socket,
звичайно,
try
мероприятия
to
оперативного
avoid
втручання можуть
any pressure
бути.
points. And definitely in this
Гіперотопічна
case, you will
осифікація
avoid
18%.
surgical intervention.
Потребують
Heterotopic
оперативних втручань.
ossification,
Як ми
18%
вже
require
бачили, не
surgical
завжди те, що ми
intervention.
бачимо на рентгені,
As you have
говорить про те,
seen,
що пацієнту
not
потрібна
always
операція. І не всі
what you
осифікати потрібно
see in the
оперувати.
X-ray requires
Якщо
the
бували
intervention,
такі
and not
випадки, коли
all
пацієнт
ossification
приходить
needs a
до
surgical
протезиста
intervention. There were instances
на
that the patient
протезування,
would
протезист
approach
бачить
the PO
знімок,
expert for
і деякі з
prosthesis.
протезистів
The
просто
prosthetic
відправляють одразу
expert
пацієнта
sees
на
the
оперативне втручання без
X-ray and they
додаткового
refer
протезування.
them
Насправді
directly for
цей підхід
surgical
є не
intervention
зовсім
without even
правильним.
making the
Так, він,
attempt to
звичайно,
offer them a
економічно
prosthesis.
з
This is
точки
the
зору
wrong
протезиста
approach.
можливо правильний, але
Economically, it
насправді,
is
коли
justifiable
немає
from the viewpoint of
поверхневого дефекту кукси,
CPO,
хібних кукс і так далі,
but if there
то
is no
рішення
deficiency
про
of the
проведення
stump,
оперативного втручання може
then the
прийматися
decision
тільки після
on
спроби
surgical intervention has
пацієнта
to be made
користуватися
only
куксоприймачем.
following
Якщо
the
дійсно
attempt to
корекція не
use the
допомагає,
stump
людина
socket
не
by
може
the patient.
користуватися
If
протезом,
this doesn't help,
є
if the
біль у
person
спокої і
cannot
так далі,
use
тоді
the
ми звертаємось
prosthesis,
до
if there is
оперативного
if the pain
втручання.
persists
Реампутація
in
без
the quiet condition, then we should opt for surgical
З
intervention.
приводу
Reamputation happens in 29%
необхідних
of
кіз,
cases. The reasons
це
could be different. So,
міофасціопластичні операції і так далі.
myofascioplastic
Менш
operation,
менш
poor
зустрічаємі
stumps, poor
ускладнення
socket
це
selection.
бурсит,
Among other
гематома. Гематома
complications,
часто виникає
bursitis,
післяопераційному
hematoma.
періоді, ось
Hematoma
бачите на
sometimes
знімку.
happens after
Вона може
postoperative
погноюватися,
period.
викликати підвищення
Sometimes there
температури тіла,
might be
больовий синдром,
inflammation. It can raise
укуси і
to
так
the
далі.
high
І
temperature, pain
після
syndrome,
евакуації гематоми часто
edema.
в тих місцях,
After
де була гематома, за рахунок
the hematoma
того, що
is
рідка
treated,
частина
the
гематоми вона
place where it used to be, because
вона
the
евакуюється,
liquid
реабсорбується,
part of
кальцій, який був
hematoma is
зібраний, сідає
reabsorbed, and the
у
calcium
вигляді
that was in the
осифікацій в
blood
місцях, де була гематома.
um,
Іншою теорією, до речі,
ends up
геперетрофічної осифікації
where
є те,
hematoma
що
used
під
to be
час
in
дії
ossificates. The
вибухової
other theory
хвилі
is that during the
кісткові
blast
клітини, попередники
wave, the
точніше кісткових клітин, які є в кістковому
bone
мозку, такі як
cells that
остеобласти,
are
вони
in
потрапляють
the
вище
brain,
вперед від зони,
osteoblasts,
де було
so they
безпосередньо
end
ураження.
up high enough
Потрапивши в таке
where the
середовище,
injury
вони
was.
можуть продовжувати
Ending in
ділитися
this
і
environment,
утворювати
they
на одному
continue
місці
to
безпосередньо
divide,
ущільнення,
and there might
які з
be
часом
some
кальцифікуються і можуть потребувати
calcifications,
в подальшому хірургічної операції.
and it might require
Операція
surgical
проводиться
intervention
при гетеротопічних
afterwards. This
осифікатах тільки у
surgery
випадках,
during the
коли він
heterotopic
дозріває в середньому це
ossification
12-18
is only done once it
місяців після
matures.
рекомендацій
It's
та
12 to
деяких
18
систематичних
months
оглядів.
following the
Чи
recommendation
дотримуються в Україні
and
такої
visits
рекомендації?
of the
На це важко
doctor.
відповісти,
Do we
тому
follow
що
this
насправді
recommendation
більшість
in Ukraine?
пацієнтів
It's hard to
очікують на
answer
операцію,
because
потім
many
роблять ще
patients are
лікування.
not
І в
waiting for the
середньому операції, які
operation for a
проводилися в
year
нашому
or a
центрі,
year and
вони
a half.
5
And the
місяців
operations that
після.
were done in our center, so they
Після
were
того,
done
як
3 months after the
діагностовані початкові
incident,
ознаки
after the
осифікації.
early
Далі,
indicators
наступне.
of ossification were diagnosed.
Невриноми. Насправді невриноми, як я казала, вони скоріше
Urine
ущільнення, вони можуть бути і
management.
джерелом
So
посилення
these are
фантомного
the
болю.
painful
І перша
places
сходинка,
that can
так, це
cause
будуть операції
phantom
коксограмажу, це можуть бути
pain,
медикаменти, такі як
modification
пригабелін,
of
габапентин.
socket. So
І
this is the first stage with
блокада.
pregabalin
Блокада
and depantene,
використовується
and
більше
also
в
blockage. So they're the
діагностичної метою.
conservative treatment basically. Blockage
Блокада
is
дає
used for
можливість нам
diagnostic purposes
підтвердити
because it
діагноз
allows us
невриноми.
to
Тобто, якщо
confirm
ми
the
робимо
neuronoma
ін'єкцію з
diagnosis.
локальним анестетиком під
If we
контролем
do the
вузлотерапії в місці
injection with a
невриноми,
local
і
anesthetic
ми бачимо зникнення
in
полум'я
the
або
place
значне
of
зменшення
neuronoma, and
больового
we
синдрому
see that
фантомного
it
болю, це дає нам
ceases
плюс
to
один
exist, the
критерій
phantom
для
pain ceases to
діагностики
exist. This is plus
невриноми, і
another
насправді того,
criteria for
що
diagnostics
оперативне
of
втручання
neuronoma, and the
або
fact that
міні-інвазивне
surgical
втручання може бути
intervention or
корисним для
mini
лікування
intervention
неврином.
might be
Також важливо ранніх етапах
justifiable
для
in neuronoma
профілактики
treatment.
це менеджмент
It's
рубця,
also
тому що
important to do
багато
the adherences
діагностованих в
management
ранній період неврином, наприклад,
because
тільки
neuronoma
ми зняли
diagnosed
шви, і пацієнт
early.
скаржиться на
Once
біль,
the
поставляючи
stitches were
епілепсію. Ми
removed, the
проводимо
patient complains about
пробуємо
the
симптом
striking
тунеля
pain
перкусії
in the
ділянці
thumb
рубця, наче є
with
якісь
Tritinel
розстріли,
syndrome,
але
percussion,
коли
whether
починають
there is such type
працювати
of
фізичні
pain, whether it
терапевти з
persists.
рубцем,
But once occupational
ці
therapists start
відчуття
working
потихеньку
with
зменшуються.
adherences,
Тому
this
ми завжди
sensation
при менеджменті йдемо
ceases to
поступово.
exist.
Хірургічне
That's why
лікування
in
це
our management we move
метод
by baby
після того, як ми
steps,
спробували
and
консервативний.
surgical
Хірургічний
intervention
метод
is
раніше
only justifiable
використовував
after
просто
all conservative methods have been
пересічення нерву
exhausted.
без
Before that,
будь-яких
we would
додаткових
do
технік.
just
Але
cutting the
побачили,
nerves
що
without
після
any
пересічення
additional techniques.
нерву
But after we've seen that
знову може
the
формуватися
incision of
неврома, може бути
nerves can
некротизація
cause
рубця і так далі. В середньому
neuroma in
лише
the
6
future,
місяців може бути
neurotization
повторна
of the
ситуація.
adherences, and in
Тому
six,
є
eight
вже
months,
невеликі
the
статті
situation
дані про
might
нову
persist or
хірургічну
might
методику,
recur. That's
які
why there are new
використовуємо зараз дуже активно в
surgical
нашому госпіталі.
techniques that we are
Це
using very actively in our hospital at the moment.
хірургічна методика відновлення
This is surgical
відновлення
intervention
нервів, таргетна м'язова
of
реіннервація та
rebuilding the
ПДРТ,
nerves, target muscle
оскелозована
reinnervation,
регенерація
TMR, regenerative peripheral nerve interface and vascularized denervated muscle target. So we need to make sure that there is the distal end of the nerve and the nerve can rebuild its tissues.
У такому випадку, при кожній із цих методиків,
In when we
нерв
use
має свій
either
цільовий
method, either
м'яз.
technique, the nerve
Відповідно,
has
невронома
its
гарно
target muscle.
утворюється,
Neuronoma does
зберігається
not
свинне живлення,
develop
якщо ми
further.
говоримо про
The
як
vessel
при останній методиці.
nurture
І неврома в майбутньому не
is
утворюється.
preserved and
Кожна з цих
neuroma
методик
is
можна
not
розповідати дуже
developed.
багато, але
I
суть
can
якби
talk a
надати
lot about
цільовий
each of those
певний
techniques, but the
м'яз
idea
для
is
нерва,
to make sure
який
there
буде
is
для нього
target muscle for the
цільовим.
nerve
Далі,
that
будь
would
ласка.
be the target
Олю, у нас
for this type of nerve.
Ми вже
You've got
завершуємо.
5 minutes
Гетеротопічна
left.
осифікація я ось вже вам розказала.
Heterotopic
Близько
ossification, I have
11%
already talked about that.
втручання.
11% of
Тепер
amputees require surgical intervention due to HO.
хибна кукса, пластичні операції, які
False stump
проводилися
and
у
plastic
пацієнтів з
surgeries
ампутаціями,
that were performed for
з
the
різними проблемами
amputees,
зверталися пацієнти,
different
з
problems,
дефектами,
different
дефектами кукс.
deficiencies,
Багато досить було випадків
um, irregular shape of the stump. There were multiple cases
ситуацій із надлишком м'яких тканин,
with the
клітинними ампутаціями.
excessive
Далі, будь
soft
ласка.
tissues.
І що я хотіла б сказати, що
And
мультидисциплінарна команда завжди
last
має
but not
працювати в
least,
одному напрямку, кожен
multidisciplinary
робити
team
свою
has
роботу
to
заради
work
спільної
together. Everybody
певної
has
цілі.
to
І це стосується
contribute for the
насправді не
common
тільки
goal. And it's not
мультидисциплінарної
only
команди,
about
але й нашої країни
multidisciplinary team.
загалом. У нас
It's
має бути
also
більше
true
речей,
about
які
our
нас
country. We
об'єднує,
have
і
to have
найбільша річ,
more
яка може
things
нас
that
об'єднувати,
unite
це
us.
спільна
And
боротьба
what
з нашим
needs to
ворогом
unite us, this
для
is the
нашої
fight
спільної
against
перемоги.
our enemy for our
Тому я всім дуже
victory.
дякую за увагу.
Thank you
І
very
дякую за
much
можливість
for
поділитися
your
нашим досвідом.
attention and for the possibility to share my experience.
Щиро дякуємо, Олю, за таку вичерпну доповідь. Є кілька
Thank you,
питань,
Olga.
буквально
There
два
are a few
питання. Перше
questions for
це
you.
чи застосовується, має
The
сенс
first, is it
застосовувати
possible, is it appropriate to use transcranial magnetic stimulation for phantom pain?
Так, загалом є певні дослідження, що використання
Indeed, there
транскраніальної
is
магнітної
research
стимуляції
that the use of
є
transcranial
продумано,
magnetic stimulation for
як я вже
phantom
говорила, це
pain is
нейропатичний вид,
justifiable. Phantom pain is neuropathic
Є
pain.
деякі дослідження, які показують
There is some
ефективність.
research
На жаль, з
that
досвіду
shows
нашого у
the
нас таких випадків
effectiveness of
застосування
this
транскраніальної
method.
магнітної
We
стимуляції
don't
немає.
have
Але,
experience
звісно,
of
сенс такого
using
звичайно
transcranial
є.
magnetic stimulation, but
Доказових
it does
методів,
make
на жаль,
sense to
показово
use it.
немає.
Unfortunately, there is no evidence, evidentiary
Дякуємо. І ще одне
methods.
питання, чи
Another question,
пацієнту з протезом легше
the
пересуватися
patient with
сходами чи
prosthesis,
пандусом,
is it easier
з
for
вашого
him to
досвіду?
use the stairs, the steps, or
Залежно
the
в яку
ramp?
сторону пандусу,
According
і
to you,
залежно в яку
it
сторону
depends whether
сходи.
it's upwards or
Якщо
downwards.
залежить від
Uh,
рівня
it's both for
ампутації,
ramp
в
and
більшості
steps. Also,
легше,
it depends
звичайно,
on the level of
сходами
amputation.
пересуватися. Але
I
якщо
believe
це
steps
повторна
probably
ампутація
is
на рівні
easier,
стегон,
but if
то
this
пандуси
is
нижче
bilateral
якось долають, а
amputation
зі
on
сходами
the
може
hip
бути значно
level,
складніше. Ситуація
then
від ситуації.
ramp is easier,
Часто
steps might be
при
difficult. It,
високих
it all
ампутаціях
depends.
можуть важко даватися
During the
втримання
high
опору по пандусу, через те,
amputation,
що чіпляється
it might
пацієнт.
be more
Дуже,
difficult
дуже
to
індивідуально.
go up the ramp. So it's very, very
І
individual.
ще одне питання виникло, чи допомагає менеджмент рубця при фантомних болях?
Does adherences management help in phantom pain?
Прям таких
Adherence
статей я
management,
не зустрічала. Але менеджмент
I
рубця
don't
дає
know,
можливість зменшити
but
загально
adherences management
чутливість кукси, і є
allows
важливим
to
етапом для
decrease the
тренувань ходьби в подальшому.
sensitivity of the stump, and it's important for gait training in the
Безпосередньо на сам
future.
фантомний біль не впливає, але через
Probably it doesn't
опосередкований
affect the
механізм
phantom
і
pain as
через
such,
комплексі зусиль
but
інших
because
це
of
може допомогти.
other mechanisms and together with other factors, so
І
it
чи
might be
впливає
effective.
протез на фантомні болі з вашого
Does
досвіду?
the prosthesis affect phantom
Впливає.
pain?
Фантомний
Yes, it
період,
does.
коли людина починає користуватися протезом, у багатьох
When the
зменшується
person
фантомна
starts
болівий
using
синдром.
prosthesis,
Але
so
якщо
the
людина
phantom
далі
pain
перші розкладають
decreases.
протези на
But there is other
час,
side
цей
as well.
фантомний
When
біль може
they
значно
doff the
посилюватися, особливо
prosthesis
якщо
in the evening, the
протез людина
phantom pain
отримала
increases,
трошки
especially
пізніше, ніж
if the person was provided the prosthesis later rather than earlier. So it helps in gait, in symmetry. When the person takes the prosthesis off,
І
so
ще
there
одне
are
питання
other
поставлю, і ми
issues.
тоді йдемо на перерву. Лайнер
Another question
чи
about
бинтування,
the
з
liner. So
вашого
what is more
досвіду?
effective, liner or
Залежно від
bandage?
етапу. Взагалі, в ідеалі
Depending on the
взагалі не
stage.
бинтування, а краще компресійний
Ideally,
чулок, тому що він дає більш
not
рівномірну
bandage, but
компресію. Якщо
compression
немає
stocking because
шнурка,
it
звичайно, те,
allows
що
better
необхідно, це
compression. If there
еластична
is no
компресія.
stocking
Лайнер,
available, then
так,
what's
якщо є
available is
можливість його
elastic
дістати, і
compression.
якщо немає
Liner,
повністю
of
загоєного
course,
м'язу.
if there is access to
Однак
it
на
and if there is
початкових,
completely
скажімо
healed
так, етапах, як
stump.
тільки
But
під
in
час, коли у
early
нас є шви, коли тільки
stages,
зняли шви,
when there are
більш ефективно не
stitches, once
використовувати
the stitches
компресійну
were
терапію.
removed, I believe that compression
Ну, от
therapy is more
останнє вже
justifiable and it's more effective.
цікаве
And
питання.
last, the very
Коли
last
проводиться
question,
рання вертикалізація, якщо здорова
when you
кінцівка має
do
перелом,
early
наскільки це сильно?
verticalization, when the healthy limb has a fracture and there is the
Кожен випадок
platter
завжди аналізується
plate.
дуже індивідуально,
Each
залежно від
case
того,
is
консолідований, неконсолідований
individual,
тест
depending
стоїть
on
саме
whether it's
компресійна,
consolidated,
чи є ще якісь
non-consolidated, where the
додаткові методи
plate is
фіксації.
exactly.
Всі ці
Are there
моменти
any other
неможливо,
fixation, external fixation methods?
неможливо
I believe this is the
чітко
complexity
сказати
of
без
factors that we need to take
консультації
into
травматолога.
account. So we
Завжди
need
слід
to
прийти до
consult the
травматолога.
traumatologist
Якщо,
first. So
наприклад, на
we
даному етапі
cooperate with the
бачите, тривалий час
traumatologist, of
спостерігаєте
course. And
пацієнта, в
if
нього
you
немає
see, if you manage the patient for a lengthy period of time, there is no consolidation of the fracture.
активно спілкуйтеся з
I
травматологом для
believe
того,
you
щоб
need
можливо
to
змінити
talk
хірургічну
to
тактику.
his trauma
Я
doctor in order
добре
to
виявлю
change
питання
the
відповісти.
surgical tactics. I believe this is very, very
Дякуємо, це все,
individual.
Олю. Щиро
Thank you very
дякуємо за
much. Thank
доповідь,
you,
за ваш
Ola. Thank you
час
for
і за
your
те, що
presentation,
робите
for
таку
your
чудову
time,
роботу.
and for
Дякую.
your wonderful job.
І вам.
Have a
У
great job.
нас
Have a
15
great
хвилин
day.
перерва, повертаємося
15
в
minutes
15 хвилин.
break, and we get back in.
усім, хто щойно приєднався, усім, хто
Greetings to colleagues who have just joined,
раннього ранку.
or
Щиро
to those
дякуємо
who
за
have
те,
been with
що ви
us
тут,
from
та
the early
дякуємо
morning.
за те, що
Thanks for your
вам
presence.
цікаво дізнаватися більше.
It's
Наступним
good that you
нашим
want to learn more. And our
доповідачем
next
є
speaker
Роберт Вестергрін.
is Robert
І
Westergreen.
він говоритиме про систему
He'll be talking about
реабілітації та
the
протезування
rehabilitation
у
and prosthetics system
Норвегії. Роберт
in Norway.
наш хороший друг, який
Robert is a good friend of
допомагає
ours who
розвивати галузь
helps to
протезування в
develop
Україні.
the realm of
Він був в
prosthetics in
Україні
Ukraine.
разом з своїм колегою та
With his colleague,
навчав тренерів
he has helped
протезуванню
to teach our
і
trainers
ефективним підходам
and
до
efficient
протезування.
approaches to prosthetics.
Robert, welcome. Thank you
Robert,
for being here with us today. And the floor is yours.
Thank you for that, Tanya. Just a quick mic check. If everything works fine, please give me a thumbs up.
Yep, we can hear you well.
Super. Thank you so much. Hi, everyone, and Dobry Den from Oslo, the capital of Norway. I am happy for the opportunity to be a part of this session and to contribute to this online marathon. First of all, I would like to say thank you for Protesa for the initiative and for lifting the topic of social adaptation to the surface. We all have our role to play in the process of helping these people that have gone through a dramatic life-changing situation. I truly believe that sharing knowledge within and across the borders is a key factor in optimizing the outcome and increasing the quality of life for our patients. Please have the next slide. I'm going to talk about how the system works in Norway when it comes to hospitalization, rehabilitation, and getting a prosthetic device. Each individual that we meet, they're going through their own unique journey. So the journey is as much of an outer journey in terms of the physical status that we talked about in the previous speakers, but as well as an inner journey when it comes to the mental status and the mental situation. I think that our job is so much more than only providing our patients with a medical device. We should consider our job as to guide, support, and give our patients the best possible outcomes for their own unique journey. And by this that we do now, bilateral sharing of knowledge across the borders, we're crafting the new tools that will benefit our patients on their roads towards readapting into society and everyday life. I will just briefly go through a little bit of who am I and my background. So please, next slide. So I'm 32 years old. Actually, I am from Sweden, but I live in Norway, in the capital of Norway, that is Oslo. I was born and raised in a big family in the very south part of Sweden. I'm the youngest of 5 brothers, coming from the same parents. So as you can imagine, I've had my time in the bottom of the pile. And just a quick fun fact that getting 5 children in a row with the same gender, there's a probability of roughly 3%. So a big shout out to my parents for not giving up the thought of having a daughter. I received a bachelor's degree of prosthetics and orthotics in Jönköping University in 2016. These years consisting mostly of theoretical courses and helped create a solid base for the continuous specialization towards lower limb prosthetics in my case. And I know that some of my lecturers are here today, as well as Simon, that's going to speak a little later on. So I would like to take the opportunity to thank you for all the knowledge that you have shared through the years. I wish you continue with the new students within the field. This work that you all do as lecturers are invaluable. After the graduation in Jönköping University in Sweden, I moved to the neighbor country, which is here in Norway, and did 2 years of residency. This is also where I met my fiance. So these 2 years of residency has now become 9. Since 2018, I have been specialized in lower limb prosthetics. And since 2022, I have had a role of the team leader of lower limb prosthetics at our main facility here in Oslo. Last year and this year, I had the pleasure and very much honor to visit Ukraine and all my Ukrainian colleagues, which Tonya talked a little briefly about earlier in the introduction. The job here is to exchange knowledge. This January, me and my Norwegian colleague John will travel to Lviv under the project of Train the Trainer, which was also organized by TESAD, together with the CF Patients of Ukraine and War Rehabilitation Project. Some of us met again during the World Congress in Stockholm in Sweden this year, which was a pleasure. Can I have the next slide, please? All right, so today I will focus on the following topics. Just gonna go briefly through an overview of the P&O workshops in Norway, how it looks like geographically. Then go through the basics of the educational process, how you actually become a certified prosthetist and orthotist. And then we're going to talk a little bit about who is payer for the medical device and how is this regulated in Norway. We'll go through the patient journey, so from hospital to rehabilitation and then back to society and everyday living, and also focusing a little bit about the responsibility from the employer of the patients that are still in a work situation. Okay, please, next slide. So, as you can see, Norway is quite a small country. There are roughly 17 companies that provide orthopedical aids with a total of 60 plus departments for the entire country. So if you look at the geographical locations of these departments, you can find out pretty soon that they're not particularly evenly distributed. So if you look at the topography of the country, you will soon find that point A to B might not be easy unless you have an aircraft. There are a lot of mountains in this country. The Scandinavian mountains, which they are called, they were formed over 300 million years ago, and the biggest cities have always been located near the coastlines. So as you can understand, for the patients, especially if you live in the northern part of Scandinavia, the accessibility to an orthopedical workshop mainly affects the inhabitants here. So sometimes it's actually quicker for them to take a flight down to a bigger city than to travel to the geographically closest P&O workshop. Some of our patients do this, and we treat them here in Oslo, in the capital. The country itself is a small country. It's 5.5 million inhabitants for the entire country. But at the same time, with an increase in the elder population and the demands that is put on the healthcare system, we're experiencing a lack of resources working in the field, and especially regarding CPOs that are in specialization. Can you take the next slide, please? So how do you become a CPO in Norway? Well, you need to go through a bachelor degree, which is 3 years of study in the university. The CPO title is a protected title. This means that by the Norwegian Directorate of Health under the Health Personnel Act, you need to get a certificate. And to do so, you need to do these 3 years of bachelor degree, and then you need to do these 2 years of residency before you can apply for a healthcare registration number. So this means that it's a controlled and protected title. You can also have health personnel number as a CPO if the working experience is sufficient in combination with a bachelor degree. So that can be done. If you have worked for a very long time, you come from abroad, then you can apply for a certificate in Norway. But in the case if you're lacking some of the areas which they demand you to fulfill, then you might have to compensate and go through these areas at a workshop before you apply and receive the certificate. Next slide, please. So I'll go through some of the basics around the funding system, how the patients get finance for their medical device. So it's regulated by the Norwegian Labour and Welfare Administration. We call this government agency NAV. All the taxpayers in Norway pay a specific amount of tax that goes directly to social security contribution. This percentage is roughly 7.7% of the income salary for each taxpayer. And the orthopedic aids and medical devices are financed within this post. To become a prescriber of orthopedic aids in Norway under the finance of the government agency of NAV, the orthopedic workshop needs to receive a framework agreement. So there are a lot of requirements for orthopedic workshops that needs to be fulfilled in order to get this kind of agreement. It's strictly regulated, which I think is good and is beneficial for the work field itself, but especially for the patient. Many of these requirements are guidelines and standards that are set up and supervised by another government agency. This is the Directorate of Health. And usually the framework agreement is valid for 2 years with the possibility of extension for an additional 1 to 2 years. So if you get an agreement, this will be a limited period of time before you need to apply again. One of the demands of the orthopedic workshop is that they must document a quality management system to ensure that routines for prescription, production, adaptation, and nevertheless follow-up of orthopedic devices comply with the requirements of NAV. The companies must also follow established standards for patient safety, traceability of material components, hygiene, documentation, and reporting. If the quality system is not followed by the orthopedic workshop, they might risk losing their framework agreements. Once again, these regulations, they are highly beneficial for the safety of the patient, but in my opinion, is also for the quality of services provided by our profession in keeping a high standard. Next slide, please. Once the framework agreement is at place for an orthopedic workshop, they can start receiving and handle application forms from the specialist doctor. And the specialist doctor is the one that have the right to apply for orthopedic aids for the patients. It is only the doctor with specialization that can apply for orthopedic devices. These include specialized doctors in orthopedics, nephrology, rheumatology, physical medicine, and rehabilitation. So the application form, it describes what kind of medical device that is applied for. It covers all different kinds of orthopedical devices, from insoles of correction of deformities to orthosis and all the way to prosthetics. Amputee patients, they have the right to have expenses covered for an everyday prosthesis and also for a hygiene prosthesis. With a hygiene prosthesis, this means a prosthesis that has components that are waterproof and suitable for showering and bathing. The application form also has its own section where we as CPOs can provide additional information to strengthen or supplement the information given by the doctor. It's also required for us as CPOs to specify if the application involves components that were classified as expensive components. Not too often, this is components when we apply for electrical knee joints or other components that have an increased cost. So for us as CPOs, it's very important that we argue for the need of these components in relation to the expected outcome and benefits for the patient. It's not like that every patient have the availability of getting an electrical knee joint, for example. This needs to be argued for, and especially from us as CPOs, and sometimes also from physiotherapists that need to complement the application. The doctor, the CPO, and also the patient, him or herself, signs this application form, and then it is sent to the Norwegian Labour and Welfare Administration for processing. So if this application is approved, the patient doesn't pay anything for the prosthetic treatment. They will also have the travel expenses covered within their own health region related to the treatment and services regarding the orthopedical device. Next slide, please. So the funding form and the funding system is very beneficial for the patient, and it should not be misused. Therefore, we have a really high responsibility as CPOs of following the regulations and the rules that are set to keep the trust from the government and the departments under the government. I would like to go through a little journey, how the patient journey in Norway can look like for our patients. Please, next slide. So depending on the cause of amputation, there will be a slight difference in pre-amputation approach for our patients. If the amputation is an elective amputation, this means that it's a planned amputation, often because of wounds with chronic infection due to cardiovascular diseases, as been talked about before. The patient will have a multidisciplinary team approach with healthcare professionals, including doctor, nurse, physiotherapist, us as CPOs, and in some cases also psychologists when this is needed. The patient will be prepared and provided with information from each healthcare personnel relevant to their working field. If they want to, the patient can also talk to a peer support. What this is another amputee which is selected by the hospital to match the expected level of function as much as possible of the patient. And this, I think, is very beneficial for the patient because the peer support, another amputee patient can speak directly through their own experiences, which we cannot provide. So hopefully most of the patients that gets this option acknowledges and accepts it, because we think that this is very beneficial for the continuous rehabilitation. We talked about post-operative care between Anton and Olga, but here it's more or less the same. It starts immediately at the surgical table. Often we use a vacuum-assisted closure for transtibial amputees in combination of compression. So the compression therapy is super important. The rigid dressing for below amputees starts immediately, and the gauze is used for above knee. The rigid dressing is removed after roughly 5 days, and this initiates the usage of a post-operative liner for compression. At this time, the patient is often discharged from the post-operative orthopedical unit and transferred to the initial rehabilitation unit of the hospital. If the functional status of the patient allows, they can start using an interim prosthesis at day 7, the interim prosthesis that was shown earlier by Olga. The stitches of the wound are removed after roughly 2 to 3 weeks, depending on the status of the limb. And once the stitches are removed, the first measurements and imprint of a prosthetic device are taken. The first prosthesis is fitted, and from here, the patient can start his rehabilitation with focus on prosthetic usage. Ideally, I would say that the time from amputation to the first custom-fitted prosthetic device is done within 3 to 4 weeks after the amputation. The sooner we can get these patients up and start loading their residual limb, the better rehabilitation they will have. Of course, it depends on the health status of the patient, the level of amputation, and none of the less the severeness of the amputation. Please, next slide. So once the first custom fitted prosthetic is done, the patient then gets transferred to specialized rehabilitation centers for further rehabilitation and further adaptation. There are limitations in terms of length of the stay and available spots at these centers. Therefore, there are other options as well for those who do not require the same intensity of training and rehabilitation. The options are health centers and, in some cases, nursing homes that is done within their home region. The negative aspect in those cases, I would say, is that patients might not receive the same specialized treatment as is given at the specialized rehabilitation centers, where we have highly qualified healthcare personnel with often long working experience with the patient group. Can I have the next slide, please? Once the patient is discharged from rehabilitation center, the further training continues at home and often in contact with a local physiotherapist. Some orthopedic workshops offer a physiotherapist in-house, and the patient can continue their training here. So we see a lot of advantages having a close collaboration with the local physiotherapists, or even better is, as I previously said, that having a physiotherapist at the local orthopedic facility. I would like to share one example of a case where a patient was visiting some of his family members here in Norway, was traveling from abroad, and had to go through an acute amputation due to osteomyelitis. Because of the fact that the patient was not registered as a resident in Norway and therefore not under the guarantee of the Norwegian healthcare system, He could only stay in Norway for 6 months from the time of arrival and would not have financial coverage for his prosthetic treatment. He was working as a local farmer back in his home country, and as you can imagine, he was very anxious of his situation because of the fact that his work is obviously very physical demanding. So what we did was we achieved through contacts of product delivery, of networking, donation products to help him recover locally at our prosthetic or P&O facility, as he was not approved to have rehabilitation at his rehabilitation centers. Why I want to show this is basically if you have the right focus from a team with a local physiotherapist and nevertheless dedication from the patient, you can still manage these patients with a high result. And in this case, he managed to go travel back to his home country after roughly 2.5 months with rehabilitation locally at our P&O facility to continue his work as a farmer. And what I've heard the latest from his son-in-law is that he's doing great. So this is really nice. Have the next slide, please. Now I want to focus a little bit about the responsibility of the employer. But I think that the employer is playing a very important role for these patients. The process of becoming reintegrated into society and work, it starts immediately during the sick leave. So when an employee or the patient is put on a sick leave, the employer receives this notice immediately. Thereafter, the employer is obligated to carry out follow-up with concrete follow-up plans for the employer within the first 4 weeks. After this, the employer is also obligated to have regular follow-ups with the employee and the patient, and have dialogue meetings with the employee and involving the Norwegian Labour and Welfare Administration. The employer here should always be encouraging that to have the employee coming back to work, having working tasks regulated and adjusted if required in relation to their physical or psychological status of the employee. This is super important when it comes to being reintegrated back into society. There are, of course, goals and sub-goals that are need to be set up. And to be reintegrated back into society, it can be all the way from returning to the family life, which is super important, or getting back to social environments that was before the amputation, and nevertheless getting back to work and getting back to our workplace. The employee have rights. They are protected from dismissal during the first 12 months of period of the first day of the sick leave. If the employee is not capable of returning to work thereafter, the employee might risk losing their job. But this is not until after 12 months, and the importance of the employer to adapt the work situation for the employee is therefore really important. It's obligated for the employer to do the best to get the employee back to work and to all the social settings that follows. This means you can be working only 10%, 15, 20, or 50% before getting back to work in full time. So what I think is really important, what really matters during this vulnerable period is for the employer and the national system to do everything they can to help the person getting back to everyday life and back to society. With this said, please next slide. I would like to say thank you for your attention and stay strong in Ukraine. Slava Ukraini.
Oh, sorry. Thank you, Robert. That was very comprehensive. We might have some questions. Let's see. Чи є питання? Стосовно як організована
Are there any
робота в Норвегії?
questions regarding how the work is organized in
Чи
Norway?
інші аспекти?
Maybe
Будь
any
ласка,
other
запитуйте,
aspects?
поки є можливість.
Kindly ask you to write down
There is
your
a question.
questions.
Can the military with limb loss continue the military service in Norway?
Sorry, one more time, Tonya. Can you repeat the question?
Yeah, can the military with limb loss or amputation continue the military service in Norway? Is this allowed?
Yes. Yes, if the employee is considered to be on the full-time work of the military, so the employee here, the military, has its same responsibility as other employers. So they need to do what they can to reintegrate the patient back into the work and maybe adapt the working tasks for that patient or for that employer.
Will that patient be allowed to be in active duty, or would it just be modified duties?
I think this is an
Or depends on
individual,
the situation.
yeah, in the individual status and individual focus of that particular case. So depending on the situation, I would say I can't say yes or no to that question, unfortunately. It's depending on the situation.
Let me check if there are other questions. Питання. Sports prosthetics, is it covered? Or activity-specific devices, is it covered by the government? How does it work?
Yes, it can. Yes, it can be covered by the government. Also, this requires a special application to have this funding completely. But if it is approved, it is completely funded by the government.
Is there a limit on how much the government can fund? How does the prescription of prosthetics works? What does that process look like?
Yeah, so the application form, it has its own section for us as CPOs to fill out specifically of highly costly components. There is no limitation in regards of the amount, but it needs to be specified the cost of components that are considered as highly costly components. And maybe most importantly is that we as CPOs, and sometimes together with the doctor and the physiotherapist, need to argue for why this is needed for the patient. If the argue is not enough, there will be it might not be approved. So we have a high responsibility in order to keep our loyalty and honesty towards the payer, that is the government, when we apply for these components. It should not be misused.
So the patient cannot just say, I want this device, and the patient will be given that device.
No, it's not that easy. So if the patient come to us and they ask for a specific component, we always make our own decision, but it is in dialogue and in communication with the patient, of course. And if we don't consider the specific component to be relevant for the patient, regarding the functional status of the patient, we really need to make the patient understand why we don't apply for a specific component, so that the patient understand how the system works. With that said, it's not that we close any door. It might be because of the current state, that the physical state that patients are. Maybe it is too early to have a specific component for the patient, and you can always apply for these components in a later stage.
Yeah, that was the next question in chat. What are the expectations of of this physical state of the patient to get a microprocessor knee, as well as can the decision be changed throughout the life cycle of a person? How does that process work
Yes.
Along the life journey? And also maybe whether it depends on what the person does or the activity.
Absolutely. And I mean, in some cases, if we have patient in early rehabilitation where we see that this patient meets up all the criteria when it comes to functional level and expected functional outcome, we can apply for that kind of components immediately, so that the patient gets to use these kind of components in an early rehabilitation phase. I think that would be really beneficial for those kind of patients. Most of these electrical high-tech components now have different modes that we can activate or deactivate depending on the phase that they are in their rehabilitation. So say some electrical knee joints, you can actually put it in a locking mode just to have them load in the prosthetic before we go further in the rehabilitation, and then we can change the parameters of the knee joints in relation to the progress of the rehabilitation.
You have prosthetic workshops separate from the actual hospitals and rehabilitation departments, right? So how does this transfer of information happen, and how does the system make it fluid and continuous and not abrupt?
Yeah, so we collaborate with the hospitals. So we travel to the hospitals to work in multidisciplinary teams. So the facility of the P&O facility might not be at the hospital, but then again, we travel to the hospital to work multidisciplinary. And also at some or most of the P&O workshops, there are doctors working with their own consultation clinics. So we have orthopedical specialists within the walls of the P&O facility, which is really beneficial when it comes to consultation or advising for medical advisements. This is super beneficial as well.
Thank you, Robert. Вадим Сверденко, будь ласка, ваше питання.
Vadim Sverdenko, the floor is yours. Hello. Heard about the peer-to-peer system provided at your medical institutions. I have the following question. Do they work officially as a multidisciplinary team, or are these volunteers? If this is a targeted approach, what kind of program it is, and where do you teach them peer-to-peer approaching?
Is it an official
Thank you
program?
for that. Yeah, so they are not a part of the multidisciplinary team. We're talking about the peer support now, but they are often a part of what's it called, patient organization. So in Norway, there's a patient organization that is called Momentum, and they do a great job. They have people volunteering and are listed up as peer support. So the hospital knows which these people are, and they can select these patients regarding to the functional status of the current patient that is in the hospital, to try to meet the same level of expected outcome as much as possible. But they are not a specific part of the multidisciplinary team, but they are called in from the hospital
Do
and
they
through the
receive
patient
specific
organization.
do they receive specific training for this, or are they just patients who wish to support?
They have their own internal training within the organization. So from the patient organization itself, they have training.
Okay, thank you. One more question about osseointegration in Norway. What does it look like? The procedure, and is it common, and who does?
I would say it's not common in Norway, but now they treat patients with osseointegration in Norway since just a couple of years back. Before that, the patients of Norway was sent to Sweden, to Gothenburg, to receive treatment with osseointegration. Now it's conducted in Norway, but only at one hospital. It's here in Oslo. And it's a really regulated program or regulated process for these patients in order to receive osseointegration. There are two specialized orthopedical doctors that together with the CPO makes the evaluation. And if they meet all the inclusion criteria and there are not any other options with conventional socket treatment, they might get osseointegration treatment, but it's limited and it's very regulated.
Thanks. Okay, so from what moment is the prosthetist allowed to start working as a prosthetist? Is there a licensing procedure? And are prosthetic workshops licensed too? Do they license them?
The short answer is yes to both. So it's a protected title. So you need to have certification to work as a prosthetist here in Scandinavia. It's just quick summary is 3 years of bachelor degree in university and then 2 years of residency in Norway before you can apply for certificate. So it's a total of 5 years, and then you need to be approved by the Directorate of Health. And for the TNO workshop, as I said earlier, it's an agreement approval that needs to be handed out by the Norwegian Administration and Welfare.
And there's more questions coming. Are there any institutions that control the appropriateness of prescription, or for prosthetics or any type of assistive devices? How do they ensure that it is not being abused?
So all of these applications that I spoke about earlier that are sent in, they are treated by a specific person at the government institute. So even though we as specialists, the doctor, the patients that needs to sign the form and the CPO argue for a specific kind of orthopedical device, it is up to this institute to grant it or not. So it needs to be supervised by this department. And sometimes they need more information. They can contact the CPO immediately, directly, through telephone, for example, to discuss the specific case that or the specific application. And then the CPO needs to argue for why they consider the specific component to be relevant for that specific patient case. And if it's declined, the patient can also not overrule, but they can send in a complaint, right? So it needs to be treated once again. But it's also that if it gets declined, it's not that that's you can still send new applications for the future. So it's not a lifelong dismissal.
Thank you, Robert. Sorry, now we had so many questions all of a sudden.
That's good.
Oh, well, there is an interesting question. Last one, I guess.
Yes.
Do prostheses differ in Norway and Ukraine with regards to the difference in the climate? So do you have to do something differently with the prostheses, considering that it's colder in Norway?
That's an interesting question, and it's relevant because yeah, it gets very cold here. As I talked about the topography of the country itself, it's a lot of mountains. And it can get very cold during the winter time. So you need to have this aspect considered in terms of electrical components. So informing the patient, I think it's super important when it comes to components that needs to be charged. That you maybe have a power bank or something available in order to recharge your electrical knee joint if it suddenly goes out of power because of the cold. And especially if you're in a geographical place where it's not that easy to find power supply. But it's a quite developed country, so most of the houses, cabins, and everything have electrical outputs. So, but yeah, you need to take that in consideration. But other than that, I don't think there is that much else to consider. I just want to comment briefly about Anton mentioned in Stockholm a quite interesting aspect, which I think is so true, is that we go to Ukraine, we come to you, and we do this collaboration for us to learn about our experiences and knowledge and to share that. But I think we learn so much from you as well, of all the situations that you're up to and up against, and the experiences that you are gaining now will come back as knowledge sharing from the other way in the future. I'm definitely positive about this, and it's we will learn so much from you and the work that you do right now in Ukraine. So thank you for that, and keep up that good work.
Thank you, Robert. We're grateful for your time, and thank you so much for this useful and detailed presentation. It was really interesting to hear and learn more about it. And we thank you for everything that you do as well. Thanks so much.
Thank you so much.
Have a great day.
You too. Bye.
Ну, а ми йдемо на перерву до 1:00
Now we
І в
have a
першій
break
повертаємося.
until 1 p.m. 1 p.m.
всіх, хто приєднався щойно і хто з нами з раннього
Welcome
ранку.
everybody who joined
Дякуємо,
us
що ви з
right
нами.
now and who
Thank
joined
you
us
very much,
in the
everyone, for
morning.
joining. And our next speaker is Simon Ramstrand. Hi. We're very honored and happy that you're here with us today. Thank you for joining, and thank you for sharing about Sweden and the system in Sweden. Please go ahead. Thank you.
Thank you very much for the introduction. Oh, that's a picture where I look much younger, isn't it? Speaking pictures, that's good.
Could you turn up the volume, please, though?
Oh, should turn it up more. Thought I had it maxed. Is that any better? Huh? Or can you not hear me?
No, the quality of
That's a
sound
little
is
bit better,
poor.
but still quiet.
Why is that? That usually works for these.
Seems okay
Right
now.
it.
Okay, I think it was just a glitch.
How is it now?
Yeah, it's fine.
Oh.
Yeah, it's good now. Okay, thank you, Simon.
Then we hope it works. Well, thank you very much for the invitation. It's an honor to be here. My first time in Ukraine was actually in 1991, so it was a few years ago. Lots have happened since then. And now I haven't been there for the last 15 years, I think. So it's about time that I return. Yeah, I got the invitation to talk about the Swedish system and how the Swedish system alleviates possibilities for returning to society, work, and function. I realize now, in hindsight, that I should probably have synchronized my speech with Robert, who spoke before, since Norway and Sweden are quite similar. So I will adapt my presentation a little bit and shorten some bits I think that he has already covered, and then we might have more time for questions in the end. Let's see how we go. Sometimes I talk too much anyways, we'll see. Okay, next. Is it coming, next one? Yeah, so you can actually take the next one immediately if you already talked about that. That is the university where I work most of the time, Jönköping University. Also tied to Örebro University, where I am a doctoral student up there doing my PhD studies. Otherwise, at the moment, I am head of the Department of Nursing Science, which needed new boss. I am dividing my time between prosthetic orthotics and nursing science and doctoral studies within diabetes and the diabetes relation to amputations and ulcers. Okay, can I take the next one? So, who am I? I used to, up till what is now 8 months ago, be the industry director for prosthetics and orthotics in Sweden. So I worked lots on national level with the policies and regulations and procurements that we're going to get into a bit. I'm also certified prosthetist and orthotist and a doctoral student, as I said, and I'm a university lecturer and also at the moment head of Department of Nursing Science. And next to me in that picture is my lovely wife that a few of you have seen before. She's a professor in prosthetics and orthotics too. We can take the next one. I'm going to divide my speech today in two sections. First, I'm going to talk about the industry and conditions, and that's where it becomes a bit similar to the Norwegian model that Robert presented so excellently just before. And then in part two, I'm going to try to be a little bit more philosophical about the rehabilitation framework in Sweden and how we think about rehabilitation as an ideology. Next, please. So prosthetics and orthotics industry in Sweden, fairly similar to Norway in size, even though we are twice the population, we're around 11 million, so still not a very big country, but a bit bigger than Norway. But we have 300 to 400 prosthetists and orthotists, and we have 200 to 250 prosthetic and orthotic technicians. And then within the workshop, we also have other professions, which equals 300 to 400 also. And we have around 50 places where you can work as a PNO. So it's not very many either, but we come back to a bit how it's organized in the coming pictures. We can take the next one, just to paint a picture of the size. We have different companies in patient-oriented practice. In Sweden, as we're going to talk about, we have two systems, you can say. We have the private companies, which, for example, is Ottobock Care. We have Formotion, we have Campro. I actually forgot to update the names on the left side, I think. We also have different parts of Sweden that's publicly run and by government agencies instead, so by public funding runs. So everything is funded by public, but they are organized in different ways. We're going to come into the differences and pros and cons with that too. So we can take the next one. It used to be in Sweden that the suppliers and the caregivers were different companies, but after Össur and Ottobock bought respective companies that also handle patient care, it's now a bit more mixed. But we have lots of companies working only in materials and components, and then we have the few big ones then that is marked with the stars there that also owns service companies, which is Ottobock, Össur, and Camp. The other ones are pure component companies, and we have lots more of those, of course. We can take the next one. We also have some professional associations, similar to what Robert presented from Norway. We have the Technicians Association, and we have the Prosthetists and Orthotists Organization, which then works for interest of respective profession. So not business representative, but professional representatives. And they also are a big part of communicating with the government regulations on the national level. So the Department of Government want to implement new guidelines, etc. They quite often refer to SOIF, the Swedish Association of Prosthetists and Orthotists, and ask for their input. So they have not just to protect the profession on the local level, but they're also a big part of the policy making. The next one. And then we also have something called the Swedish Orthotic and Prosthetics Industry Advisory Council. A very annoying name to say because it's very long. This is where I used to work as industry director, and they represent then 12 service companies, where 4 is private and 8 is public. This number has changed lots in the later years, in the last 10 or 15 years, because it used to be lots more different private companies, but lots have been bought up by Össur and Ottobock. Now then the service bit is called Ottobock Care and Formotion. And we have 8 public ones. But so if you look at that number, it can look like the public is dominating, but it's not. Around 80% of the prosthetic and orthotic care in Sweden is done by private companies. It's just that they are much bigger than the public ones. We have 22 supplier companies, and the members of this organization accounts for more than 90% of the prosthetics and orthotics made in Sweden. And this also makes it a very strong player, a bit like I said before, when it comes to regulation and implement rules. It's a place where all companies can come together to discuss how we think that prosthetic and orthotic care should be run in Sweden. We can usually agree on lots of points that this is good for the business, even if we are competitors in many to a big extent. But the general how it should be run, and that we have a good regulation that serves everyone, that's a very good forum, and it works very well. Can take the next one. And then, of course, like Robert mentioned before too, we also have the interest associations. We have ISBO, that lots of you are familiar with, that arranges conferences and courses. We have Momentum, which is the patient organization. That's very strong in creating activities and trying to promote active life for amputees. We have the Swedish Diabetes Association, which is a very strong player in the field of healthcare in general. Political influence. They have quite probably the strongest association we have. And then we have the Swedish Rheumatism Association, which is also another big one we cooperate with. And then that's other ones, but that's the big ones that we cooperate with. Next one. For education, it's very similar to what Robert presented too, so I won't go into it in much details. But we have the prosthetics and orthotics bachelor degree in Jönköping, at Jönköping University, where I work. We also there teach prosthetic and orthotic technicians in a 2-year program at a more practical level. We also have the Master Product Development, which is have a specialization in assistive technology. So that's a master level you can continue to. And then we also have the research school where PhD level studies are possible even within prosthetics and orthotics. So we cover from bachelor up to PhD level. And we have an international program at the bachelor's level. So we have a place for 30 Swedish students each year, and we have up to 10 international students, both from Europe and from outside Europe. Yeah, I think I settled for that. And next picture, please. So the governance system in Sweden is a bit special, one might say. I'm not here to present the ideal model because I don't think the Swedish model is ideal. It has its strengths and it has its weaknesses as any other system. A big difference compared to Norway is that we have this region division. We have on the map to the right there is regions, which are 21, which have the main responsibility for healthcare. I'll come back to that soon. And then on the left side map there is municipalities, which are 290 of which are responsible for the patient care in a more close area. And this makes our rules a bit diverse, you might say. So unfortunately, we can't say that we have exactly the same care in the whole of Sweden. So some areas might be better covered when it comes to prosthetics and orthotics, and some worse off. That's a difference to Norway than that having this one NAV organization that handles the rules for the whole of Norway. You can take the next picture. So I do know that the picture to the left is in Swedish, but I'm going to explain it. So there is the statutory responsibility for healthcare that is shared between those regions, which is to the left there, and municipality, which is the red ones. And the regions have the overall responsibility for health and medical care and must work for good health among the population. That's a government mandate they have. But the municipalities are also into healthcare, since they must offer good health and medical care in special housing for the elderly. They are responsible for short-term housing special services for people with disabilities, and day activities. And primal healthcare is also divided by those municipalities. And within these, you can then do different kind of procurements, how you want the business to be run. You can have public procurement, or you can have a selection system like we have in Stockholm, where you have several suppliers competing for work. Or in lots of Sweden, otherwise you have a procurement one time every 4 to 5 years, and then you have one company that is solely responsible for provision of prosthetic and orthotic care for that period of time. Or you can choose to have it run in public hands. So there's really 3 different versions of Swedish prosthetic and orthotics organization. If we can continue to the next one. And as we start with, we have different actors that relate to all actions within prosthetics and orthotics. We have the region then that runs and commissions activities. They are the one who tax people and get income and are responsible to then finance healthcare. Government level do some parts, but the main responsibility for healthcare is in the regions. The municipalities are responsible for ordering and responsibility for users, adaptations of homes and works, etc. We'll come back to that in the following here. We have a National Social Insurance Agency. They are responsible to do an assessment of workability. They have their own doctors. It's not only the normal doctor that refers them. They have their own system to be unbiased. And if they assess them that workability is, say, 50%, then they can also decide about the salary, like a kind of a pension that you get them for the other 50%. So you get an income assurance. We also have the employment service that is responsible for requirements for jobs. So they can see if you actually have a full capacity for a job. They are responsible for finding a new job, or help you find a new job if you can't do the one you had before. the accident or the amputation. They can also pay for adaptations in both workplaces and access to work. So it's a very important part for the ones who are in an age where they're still working, because then they have lots of support from the Employment Service Agency. And then we have the responsibility in Sweden at the employer level too. The employers, it's a bit similar to what Robert talked about in Norway, that they are responsible to adapt the work so it actually can function in the new order of things after an amputation. They can apply for funding for this adaptation, but they are responsible that it happens. So you can't actually, similar to what you can't fire someone because they get amputated, but it's your responsibility to try to make work for them, so to say. We can take the next one. And then how do you get an assistive device in Sweden? Also a bit similar to Norway, some of the differences. We have a slightly different prescriber system because it differs in our different regions than who can prescribe a prosthesis. In some areas, it is the medical doctor, usually an orthopedic surgeon or a neurologist. In other areas, it's actually the prosthetist and orthotist who's the prescriber, and then instead get a referral from the hospital system, usually a doctor. And then it might say to the prosthetist that this patient referred to you because it's a transfemoral amputation, but then there is nothing more in the referral. It's up to the prosthetist orthotist to decide the action and decide for the prosthetist and orthotist diagnosis and come up with a care plan for that, and then decide on that. So it differs a bit. In the classical doctor prescribe what's needed compared to the prosthetist and orthotist that is responsible for the care. We have some fees in Sweden. Healthcare is generally free, but there is some fees, like usually for each treatment you pay like, what's that in euros, 2.5 euros, something in that region. Some regions have higher fees for specific kind of aids, but it's usually nominal fees. Similar to Norway, there's a discussion on what kind of aids, what kind of prosthesis you get. I mean, in the government regulation, it says that you should have access to the best possible care in accordance to evidence. That statement from the government always collides then with goals versus financial reality. And the financial reality out in the regions is that you can't give the absolute best thing to everyone. But I will come back to that soon with a patient's role in the whole thing. But you do get aids that cover your daily needs. In some regions, you get a prosthesis for free time activities like sports prosthesis, etc. In some, do not. You can choose to pay for one yourself if you don't get it, but it's not provided by the regions in all parts of Sweden, but in some. So we have some unfairness there, unfortunately. And we have assistive devices within agreements. Like I talk about that state sponsored, you get everything paid for, you get everything from first treatment to service after provision. But then you can also have outside agreements with private companies that you can buy your own things, or rare cases where insurance companies actually pays for prosthetics provision too. That's very, very rare still in Sweden. I'll take the next picture. So the Swedish system is to a big extent built around procurement, public procurements and agreements. And that since, like I said before, 80% of the business is run by private companies. And then you need a system to keep it fair and keep it effective and cost effective. So procurement, why you should have procurement is then lots of this, that you want to keep costs down. You hopefully want to keep the quality up. We're going to have a discussion on that, price versus quality too, because that's always discussion. So in the public sector, you have, even if it's public run, you have procurements, but then you have procurements to buy components instead, that they do with the supplying companies, and they do procurement in that area. But the big service procurement is in private operations, and they also have product procurement, but then it's up to the company after they get this deal to run care in, say, Stockholm for 4 years, and they can make contract with their sub-suppliers of components, etc. The indicators in procurement differs quite a lot since we have our 21 regions again. We keep coming back to that. So in some cases, it's been that quality is the indicator and they set the fixed price. And then companies have to prove how they can give the best quality for that price. Or, which unfortunately I should say, has become more common, is that price is the indicator. And then they set the quality indicators as mandatory, and everyone who wants to put in a tender has to live up to the standards. But then it is price that is a deciding factor. And the one who controls the terms and conditions is the regions then. That's why we have lots of different systems, since we have 21 regions who can decide independently which kind of indicators in the procurement, depending on the need they see on the local level. It's not all bad because the regions are closer to the regional level and they see the needs in that part of Sweden. So it can be a benefit, but then the bad thing, like I keep coming back to, is that it's not always fair and it's not the same care for everyone in the country. We can take the next picture. This is what I mentioned. Price versus quality, the eternal question for everything, including prosthetics and orthotics. There is arguments for and against procurement with price as an indicator and how you handle the quality within this, like I said. The ones that argue that price is the best indicator claims that then the regions can state in the procurement documents, the basis for the tender, that this is the quality that we want. This is the level that you have to reach, no matter what, and then they use price. And then they mean that they can decide exactly what quality of care that they want. The one who then against this system, then of course say the opposite. Yes, you set the limit, but you never get anything better than that. You limit yourself to exactly the quality criteria that you have set in the tender. You will never improve care. You just go lowest price. So that's the argument there. Then you have the arguments for against procurement with quality as an indicator instead, and how you handle price in those. Because if you have quality as an indicator, of course, what the companies compete with is then how can we give the best quality to this region? And that quality can be type of care, it can be type of prosthesis, it can be accessible times that you have open later in the night, you can be having teams going out to the countryside region to have a great accessibility. It can be lots of different quality arguments. And then price have a bit of, I think actually I have, we can go to the next picture. We can talk a bit about handle price in this. Next picture, please. Yes. Okay. What's the next one? Skip that picture. We take the next one. Not to the normal model anyway. Next picture, please. Oh, that was the forward one. Two forward. One more. Next, please. I'll call that one. Thank you. Yeah, because a new model that has come in a lot where we have quality improvements as a monetary value is this the good example I have called added value model, which is a new thing. It's been around for quite a long time in different areas, but in prosthetics and orthotics it's quite new. And then it is really a price procurement, but quality improvements are given a monetary value, which means that if I say that my company will increase opening hours, we will increase patient care by having much more, let's say, gate school activities, training with different free time activities, etc. And if the region then thinks that this would be good, it's a good quality improvement, then they put a value, monetary value on that. For our constituents, this would be worth 2 million euro. And then that value is deducted from the price of that tender. So if you increase the level of quality, that makes it possible for you to get the tender even if you have a higher price than others, since you then get to deduct the value of the improvements, the quality improvements you have done. I wonder if that was clear. Otherwise, you can yell at me. So anyway, so the whole idea in that model is that you should be able to make quality improvements even if it's price indicated model, and then be able to get the tender so that patients and healthcare givers get a better quality of care. We also have some bad examples of new models where we have a fixed price for running prosthetic orthotic service. So they say you get this amount of money for running prosthetic care for 3 years in this region, when it's no connection to volume at all and how many prosthetics are going to be done and what kind of components. And that just creates a very odd situation, because in the end of that term you might be running out of money. We also had a model where we had price per assistive device on each article level. The one who put in the lowest price for each component won that tender, which meant that there was lots of different suppliers. It could be one supplier was responsible for providing a transfemoral prosthesis, a different company was responsible for service the same prosthesis, and in worst case, a third one could be responsible for repairing it. So it was a mess. So that wasn't very good. Don't do that. This is a general tip. We can take the next picture. So that was a bit quick introduction to what the system looks like in Sweden. And now we're going to talk a bit more about rehabilitation, how we see rehabilitation in Sweden, which I think is similar to Norway, but I had a bit of a different approach to it here. So we can take the next picture. In general, the International Classification of Functioning Disability and Health, the ICF system, I think most of you are familiar with. The government in Sweden usually say that we follow this in general, but adapt it with quality of life. You see the circle around the picture there, that is the common goal, that you should increase quality of life, and then we use ICF to reach this goal. Historically, we had lots of focus on body functions and structural impairments. You had an amputation, and then we focused lots on what you couldn't do. You lacked a leg, you need a leg to be able to walk. And then with environmental factors, we then supported. We made sure we got the prosthesis that worked and biomechanically functioned well. And that was the focus. The focus now have much more tended in ICF to go to the right side with participation, activities and participation. Where we look at the patient as an expert in the team, we're coming back to that too, and where they can express what participation they would like to do to have a good quality of life. Which could be that, yes, Simon, he wants to go with his book club to Vienna in spring on some book exhibition. And then that is the goal, the participation, that's important for me. And then we consider how the body functional structures need to be, how we can alleviate that goal. So we turn it around a bit. So we don't focus on the biomechanical things and then we hope the rest works out. Instead, we try to focus on the goals of the patient, and then we try to fulfill that goal by providing a prosthesis. So just twisting the view a little bit there. And we have a big focus on society's responsibility to facilitate environmental factors. We have lots of rules in Sweden about building codes and construction and accessibility. Sometimes get criticized because I think it makes building very expensive, but I think it's very good because it means that every public building in Sweden should be accessible by a prosthetic user or wheelchair user, etc. We still have ways to go there, but the government aim is to facilitate for everyone to access in society. Can take the next picture. So rehabilitation or habilitation, because since, of course, if we have prosthetics, we have an amputation, and then it's not generally just rehabilitation, it might be habilitation. Historically, we had a little bit of, how we share responsibility. From the beginning, it was a healthcare task. It was the main hospital. They were responsible for rehabilitation after surgery, everything related to that. But now we have a little bit broader view of rehabilitation and habilitation and how that has emerged. Where, as I said, we have quality of life as an overall goal. So it's a bit wider. We try to see the patient's whole picture a little bit more. What exactly does this patient want? We have to the right the rehabilitation process and the different actors, everyone that might be involved with the patient. And we then have the patient in the center, patient-centered care, as we call it, as I'm sure you all are aware of. That means that patient is just not someone that all these professions look at and trying to help to the best of their ability. This means that patient is an expert in the team on its own health, which sometimes can be a bit challenging because we are, of course, experts in our field, but the patient is expert in their life. And this means that we have to include their wishes and the desires. They have to be given options of care. We can't just say that this is what you get. We have that to actually present and give them a possibility to be active in the whole rehabilitation process. This doesn't mean that the patient decides everything. Prosthetic autism, for example, is still the expert and has to decide that this type of model of prosthesis works for your needs, but you have to have the discussion with the patient, and we have to explain why this model is the best for you. So the patient has quite an active role in this. We have areas of Sweden where this have come much further and others where it hasn't come that far yet. But that is the definite goal of the government, is that patient-centered care is where we should aim. And the idea with that is not just to personalize care, it's also actually to use the money in rehabilitation effectively. Because the idea behind it is that if we just tell the patient or give the patient what we think they need, we also give them lots of stuff they do not need. So if we can get effective care that lives up to the patient's expectation, we can actually also get a more effective rehabilitation process. If I talk too fast for interpreters, they can yell at me. I have that problem. Yeah, we can play the next picture. So we have what we call 3 arenas of rehabilitation. We have the medical interventions, and then it's done at the hospital, which could be amputation, which can be like Anton was into before with ulcer treatments, etc. We have the general authorities, like the insurance agency that I talked about before, employment agency, and then we have the employer that then are the production leg, if you say so, the employer out in workplaces. These 3 different arenas needs to work together for creating a good possibility for a patient to return to work if it's working age, or return to an active life if it's a retired person. The problem, of course, is that they might have a bit of different driving forces. In general, in medical interventions, we look at, for example, amputation is done well, ulcer is healing correctly, there's no infections, etc. That's the focus there. The social insurance company looks at the total cost. Can we get this person into work again, which then finance care and is good for the whole society's economy. And we have the employer who looks more narrow at this patient is doing this work for me. Can it still produce in this role, and what adaptations do we need to do to increase production or keep the level of production that was before the amputation? So a bit different driving forces and different objectives. So coordination is vital, as I wrote them. There's also sometimes a bit of confusion of concepts between this when the social insurance says that this person has 100% working ability, but the employer says, no, this person cannot do this job. And then they have to come together and discuss, and then the agency normal means this person have 100% working capacity for some job, not necessarily the one you were in before. And then it can come to that you get finances from the National Social Insurance Agency to re-educate yourself or get a new job and adaptation to that, if that's needed. So lots of coordination job, and that's we sometimes wish we had this Norwegian system with one national agency, because it would be easier than the regions, but it works. Can take the next picture. So this is the 2 that we discuss when we talk about the rehabilitation ideology at school, etc. That we have the disease-centered care versus patient-centered care. And of course, the first thing is that the disease center focus on the need for help. If this person has lost its legs, it needs a leg. And in patient-centered care, they would, like I was saying before, then say instead, what is important for this patient and how do we reach that goal? Might be the same thing in ideal like this, but it's different approach to it. In the disease-centered approach, you search for information about what the patient cannot do. And in patient-centered care, you're more interested in opportunities, resources. They have this strength, they live in this society and have this kind of housing, and what works best for the patients then. And in disease-centered care, you inform the patient of the best course of action. And in patient-centered care, you expect the patient instead to be involved in the decision. So it's a different approach. It's not right and wrong. In general, in more emergency cases like traumatic amputation, that's unfortunately very common in Ukraine at the moment, for example, then patient-centered care in the initial state might not be suitable, because then you need quick action, you need to decide what happens, you need to do an amputation, take care of a wound, get to the healing stage. And then disease-centered care is much more effective. Then it's quick, it's decided what we do, and we act according to that. But once you reach the rehabilitation stage, then I think the patient-centered care might be more effective, because, like we mentioned before, you might take into account the person's interest and care, and the environmental factors around it, the personal factors this patient have, strengths and weaknesses, and how you tie that into rehabilitation with the prosthesis, and what focus you should have. So as you notice, I'm probably generally a patient-centered care advocate, but I think that both models have their position and their need. I think we can take the next picture. This Socialstyrelsen is the National Board of Health and Welfare in Sweden, a very strong organization who handle all the certifications from different professions. They handle in case someone misuses their profession or hurt patients, etc. They can be reported to here, and they can lose their license to work. So that's a strong government organization that regulates the whole field of health and welfare. And they have this public definition of rehabilitation that I think I'm actually going to read for you, and you can see it there too. Rehabilitation in health and medical care stands for early, coordinated and comprehensive efforts from different areas of expertise and activities. That mean that medical, psychological, educational, societal and technical efforts are combined based on the individual needs, conditions and interests. So this is a guidance for the whole healthcare system about how we should approach care for individuals. And as you see, they're very clear that it should be combined based on the individual's needs, conditions, and interests. It's not just medical needs, that Simon needs a prosthesis. It's more much wider concept of quality of life that is government mandated, that we have to live up to. And this then should be reflected in the procurements, that the companies can show how do they live up to this. Not always done, I should say, since we have our different systems. But the idea is that that's how it should be done. I think we settled for that. We can take the final and last picture. And that is, thank you very much for your time and for listening. And I'm very, very thankful that I got invited to this. And if any time we can, if you want to talk more about rehabilitation ideology, I like that subject. We can do that sometime.
Thank you, Simon. Well, we're very grateful to you and to Nerland. Nerland's doing an incredible job with supporting our universities and Jönköping University in general. It has been a great partner to so many things that we have done and that where we were able to progress. So thank you. And we do have a few questions. Yep. So we're not letting you go yet.
That's good. We have time.
So we have a question. What type of adaptation of the workplace should the employer provide to the employee with an amputation? Is there a specific regulation for that, or specific requirement?
No, there's no specific requirement. There is the work has to be adapted. And then it comes within reason that you have to discuss with that national insurance agency I talked about. If you as an employer say that it's not possible, we can't adapt work enough for this person to be able to function in this workplace, then you have to have a discussion with the national insurance agency. Is this true, or could we tweak it somehow, or could we even change the tasks a bit within the company? So it could happen that because sometimes it's not possible. But as far as possible, you are obliged to adapt the workplace. But you then get government funding for it, of course. So it's nothing specific. It's very wide, but that intentionally kept wide because you don't want to limit the efforts you should do to keep it at work. Was that an answer?
So do advocacy organizations like Momentum, do they collaborate with employment agency or employers on that? Do they have an input?
Not much, unfortunately. Patient organizations are mostly cooperating with the National Social Security Board. So they ask for input, but they have very little cooperation directly with companies. They can, of course, be referred to if, for example, contact the industry council and ask for advice. We can refer them to patient organizations, but they don't have a public role in it.
Well, the civil society in Sweden is very strong. You have many NGOs that play a significant role, as far as I know, in influencing the government's decisions too. What is one way that a person, for example, a person receives poor services and is not happy with the prostheses or the service in general? What are the ways that what can the person do about that?
You have in each of our 21 regions, you have a healthcare board where you can appeal cases and report errors or damages. So there is an official system for that where you report it to, and then they are mandatory that they have to investigate the issue and get information and then decide on that issue. And then you also have, if it's larger cases, the National Health and Welfare Board can also go in and regulate areas. But for the patients, normally the regional appellation court, almost not a court, but advisory board.
Is that a complex process, or can they just do something online? And
it's quite easy, actually. Yeah, you can call them, or you can fill in a form and send in and get the first contact, and then they can follow up with an interview usually and see. But you can do a written form otherwise and send in a complaint, and then they have to investigate it, and the healthcare has to answer whatever question they ask you. So processes and authorities might be included in this. If they think that I have done something wrong against the patient, I might be contacted by this board, and they say that they have a patient to report this wrongdoing or error, and they need to investigate it. And then they listen to the patient, they listen to me, and they take in all the facts they can, and then they decide to proceed after that. And it could be that nothing happens. It can be that you have to change the care somehow, or it can be, in worst case, that I would lose my license if I done something really bad.
Right. So for the prosthetist, orthotist, it's a licensed profession. Do you have to do the national exam in order to obtain it, or is it just the university exam?
The university has the mandate from the government, so we are regulated by the government, and we are assessed by the government that we fulfill their criteria. So every few years, like 5 years or so, they just control that we live up to the level. And then they say that we have the mandate to do it. But then after the student finishes school, they still have to send in their documentation to the national board and get the certification from there. But they have all the testing. They have, they let the university do that. And since in Sweden we only have one university, it's our school that does it.
One more thing about research. Sweden has an ethical board, right, or ethics board,
yes.
or something like that.
Yes, several.
Could you share more about that? How does that work, and what do they do? What's their role?
We have also regional ethics boards, of course, since everything is regional. But they're a bit bigger regions. They've joined up a few, so we have I think it's 5 regions now that have an ethical board, and they control. But it's within research, and so everything you do in research that somehow handles either information about the patient that can be leading to identification of a patient, or if you do testing on a patient, or say test a new prosthetic knee joint or whatever that could potentially mean an intervention on a patient, then you need ethical approval, and you send it into the ethical board. It's quite a lengthy document you need to send in where you declare exactly what you want to do, exactly how you recruit patients, you have to say then risks and ethical considerations, and you have to weigh those risks against the possible positive outcomes and explain why we think that this study is worth doing. And then if you fulfill everything, then you get approval, and then you can start the study. So it's quite a rigorous system with that.
Yeah, thank you. Чи є в когось ще питання? Any other questions? Поки є можливість, ставте питання.
You still have a chance, the last chance to ask questions.
There is an issue, a constant ongoing issue that Olga was also mentioning, wheelchair issues, that for some patients, a wheelchair would be a better option than prosthetics. However, not always specialists are able to find a way to deliver that message to the patient, or the patient is not accepting that idea. How does it work in Sweden? What's the
we have a little bit of problem there because we have two different organizations. We have prosthetics and orthotics who do not handle wheelchairs, and then we have a different agency that handles medical assistive devices, which handles hearing aids, some sight aids, and they also do wheelchairs. So you have communication in between there, but there is nothing. It's no competition between it. So if you have a patient, when you do this patient-centered care, and in the team you come up with the conclusion that the wheelchair would be much better suited, you can then just refer them on to this assistive technology company instead. And you could get a prosthesis that's very simple, just for movement from bed to chair, etc. And then you complement that with a wheelchair. So it's no contradiction there.
And one more question, how long does the process of complaint take? If a person is not happy with something and they have filed the complaint, how long does it take for the body to react?
You almost know what I'm gonna say, and don't you? It differs in the regions, unfortunately. So it's not same, but they're usually actually quite fast. It doesn't take very long. If they get the complaint, and it depends on the seriousness of the complaint. If it's bodily harm, it counts as an emergency, and then it's done very quickly within a week usually. Otherwise, if it's smaller complaints, it might take longer depending on workload. But it should be handled with urgency, it said. So within a month, you should see some kind of progression in the case, no matter what it is.
We have one more question. Sorry, it's like an interrogation here. So many questions. Everybody's curious. If a patient wants a more functional prosthesis, but it is slightly more expensive, how is the issue resolved?
Yeah, that's a bit of a problem actually, because as I said before, patients could theoretically pay for their own prosthesis. But when you come into that, you want to pay for a slightly more expensive knee joint, for example, then we don't have a good system for that. So then it's either more you pay for the whole thing or you pay for nothing. And then you argue for the more expensive part. So yeah, but how should we say it? I mean, there is no price ceiling of a product as such, but if it's lots of expensive products and it breaks the budget, you still have to get special approval for it. Usually in a procurement model, you have that 90% of the patients should be within what we decided in costs and component cost, etc. But then you also have this other 10% that could cost more if you can justify it. A bit like in Norway before that, you have to justify and then you have to get approval to do that. So if this patient had a reason for the slightly more expensive prosthesis, it might very well be possible to get it. But then you have to apply for that extra cost. It's a bit of a process. But the patient can't just decide.
But when the costs of the prosthesis are calculated, they're based on the catalogs, right? Of the company catalogs, whatever the company has listed.
No, not really.
What is it?
Since you have the procurement system, they put in the tender to each region what the prosthetic going to cost for the coming years. And that price, of course, is a negotiation. So it doesn't have to be what it is straight on the catalogs. So, for example, if I have my own reading in Sweden and I decide that, for example, us or Promotion would get this contract, then we decide on the price for what prosthetic care would cost, and for example, what the provision of a transfemoral prosthesis would be allowed to cost. And then it's up to them if they want to buy cheaper components somewhere else, as long as they live up to the quality standard they agreed upon. So then they can make deals in their part or come with cheaper ones or buy more expensive, but the total cost have to remain the same.
So the total cost cannot be higher than a certain thing, but they can
if that's
manipulate the cost within it.
Yeah, because usually we do everything at provision. That prosthetic care is one big thing. We set the number for approximately what the transfemoral provision should cost in total. So then you can vary a bit if you have a cheaper foot, more expensive knee, or how you play with the components. But it's different in different models, unfortunately.
Right. Sounds good. Vadim, we have a question from one of the speakers. Vadim, будь ласка.
Доброго дня. Чи є різниця між протезуванням дорослої
Is there
людини?
a difference between prosthesis for an adult and a child? And if there is a difference, what kind of?
Regulation-wise, there is no difference, really. Children is generally treated more generous when it comes to costs, both because they're growing and they have other needs. So there is no limit to how many prostheses you can. Usually kids can also get like a free time activity or swimming prosthesis if that's needed. So in general, it's a bit easier for children, but it is the same regulation. It's no separate regulation.
So how does the government prevent price gouging and abuses? How does that? Is it just they rely on the integrity of professionals?
Yes, so you have the procurement where you set up standards. So this is what the company has to live up to. And then it's up to each region to follow up on that. So they can do continuous follow-ups during this 4 or 5 year period if they want to. Some regions do it by taking samples by random and look at how these patients are treated and if they live up to expectations. Some does not, but they do it after or follow up on in very long periods of time. So it varies quite a lot, actually. But in general, if you sign the contract for procurement, then they expect that you live up to it. Since you work very well in cooperation with the orthopedic department staff, they usually see and if they have any worries, you have usually like a little council you can meet and discuss the questions to live up to standard. And if someone complains either to this appellation board that I mentioned before or to the orthopedic surgeon that we don't get the care that we're supposed to get, then you have to look into it. And I mean, technically, you could lose your contract if you don't live up to the quality. So yeah, so there is an appellation process, but it's up to regions to follow up, really.
So the accent is on the quality and of the product and the services mostly. Yeah. One more question about peer-to-peer. How does that work in Sweden? Is it an official role, or do patients just help each other as part of the community?
It's very similar to like Robert presented before in Norway. It's no official capacity. It's a patient organization usually come with representatives, and they have their own like the mini courses to how to handle the job, etc. But they don't have a official capacity. But they are invited to different care teams, but they're not part of the professional team. But, so most common is, for example, if you have a gate school that you then have a patient come in and talk, and they have some coffee together, and talk together, they train together, but no official capacity.
Right. We're out of questions now. Thank you, Sam. Thank you so much for sharing your knowledge. Thank you for your time on the weekend, and thank you for supporting us throughout.
Always.
Great. Thank you.
Thank you very much. Bye-bye.
Bye. Ми продовжуємо. Вже багато ми дізнались сьогодні
We
нового
continue.
і
We have
цікавого
learned a lot
і
of new
корисного.
interesting things
І
today,
далі ми переходимо до
and we
педіатрії.
proceed with pediatrics.
Claudia з
Claudia.
нами зараз. Hello, Claudia.
Claudia
How are
is
you?
with us.
Hi, hello. Very well.
Thank you
Thank you
very
so
much for
much.
joining. Thank
No,
you.
thanks for having me. This is such a great event you're organizing. So thank you and all the other organizers for just planning these 2 days.
Thank you. We're ready for your presentation. We'd be happy to learn more about it. And please go ahead. Thank you so much.
Thank you. Yes. So good afternoon, everyone. I'm Claudia. I'm at the moment doing a PhD focusing on children with lower limb amputation. Just a disclaimer, I am a biomedical engineer by background, so I'm not a clinician, but I try to get the research results that I think could be interesting to rehabilitation professionals. And I have some ideas of like what this could imply for clinical practice, and I'm gonna throw them out there, but I think you can have better ideas of like what this could mean in clinical practice. So yeah, I look forward to the discussion with you all. Next slide, please. Or do I go next on my own? Okay, yeah. That's the title. So we're going to look at pain, compensation strategies, growth-related problems, and then general challenges in provisions with pediatrics. Next slides, please. And yeah, this is obviously a team effort, and these are only few of the people that helped me throughout, and all the funders as well. Next slide, please. So unfortunately, we know that the burden of conflict on children is extremely significant, both during active conflict. There are direct targets of shelling attacks on school, orphanages, and we see an increase of this. Fortunately, in Ukraine, I think most of the children have been fled from the front line, so perhaps that risk is slightly reduced. But there's going to be a very big legacy of the explosive remnants of wars. So unexploded ordnance, landmines. Ukraine is one of the most contaminated countries in the world with landmines. And unfortunately, children are 50% more likely of being injured by such devices because they interact with them differently. They are interested by a weird object, so they might pick it up, and so they have more chances of being injured. And also, in a lot of places, perhaps they play in the playground or in football pitch, and they end up being injured by a landmine. So next slide, please. So this is going to be a significant challenge, and amputation is a likely injury when there is an explosion from a ERW. As you can see, like amputation rate varies from 26% up to 87%. And traumatic amputation is a unique type of injury. It's not like another amputation from vascular disease or congenital cases or cancer. This is a extremely high energy injury. So there is bone loss, soft tissue destruction, wound contamination. In general, surgeons find themselves with a very complex surgical case. So oftentimes the residual limb it's suboptimal. And unique to children, there is the fact that this may lead to the loss of the distal growth plate. So the growth potential associated with that. If you go to the next slide, please. So what happens is that if children had an amputation at 6-year-old and the residual limb was appropriate length, because it's not going to grow as much as the intact limb, there's going to be this progressive comparative shortening. And so they will arrive at skeletal maturity with a very short residual limb. So this is going to be an ongoing challenge for you when you provide. And perhaps it's important to think, that's what I think, about muscle strengthening so that they can still control the prosthesis, even if the residual limb is not as long. And then in the next slide, please. another issues and ongoing challenge you're going to have, especially with children below 12 years of age, is these two problems, which are terminal bone overgrowth for transtibial cases and heterotropic ossification for transfemoral cases, which is abnormal bone formation. We don't know yet what are the drivers. There is someone in my group doing some research to try and understand why this is happening so that we can look at some mitigation strategies. But at the moment, the only solution is revision surgery and socket modification. So if children start telling you they have pain at the distal end of the limb, perhaps it would be appropriate to do a low dosage X-rays to see if this problem is starting to come in. Next slide, please. And then another challenge is that there is not much development of prosthetic components for children. This challenge is hindered in low resource environments, but also where we have the top components, sometimes they're not small enough, they're heavy. And as you can see, because the musculoskeletal system of children is so plastic, they actually have very significant consequences, such as scoliosis. You can see this girl has significant lordosis because she really has to compensate for that. But children will still cope and go around because they're very active. So it's really important to try and really check the alignment, really think about what is the best component and just check them throughout growth so that we can minimize this long-term complication that may develop. Next slide, please. And so these are the main three research areas I'm gonna address, which I think can be of interest and relevant to some of you, at least, hopefully. And so I split them in three studies, so it's a bit more digestible throughout. And I'm gonna present methods, results, and the key home messages separately so that we can either have a discussion or a little break in between, or just, conclude one topic at a time, basically. Next slide, please. So the first aim is to identify what are the provision challenges by talking with children and prosthetists. Next slide, please. And basically to do so, we have, if you please go to the next slide. We have developed this toolkit with qualitative interviews and patient-reported outcome measures that we administer to the child, the family, and the prosthetist. This is the start because we're really focused on prosthetics, but obviously to get a full overview, we recognize that we should also talk to the surgeon, physiotherapists, occupational therapists, psychologists, because this is really a team effort. But we started with this. So for the caregivers and the prosthetists, is standard interviews that we develop. They're adults, so we can just have a conversation. But for children, we really try to make it engaging. So we did card games, functional outcome assessment in the gym so that it's a bit more active. And so really try and gain information from the child, but in a safe space for them where they can feel at ease and really share what they do and what they want. And also a lot of drawing activities to relax them. So there's the QR code if you're interested, perhaps of using this in your clinical practice to understand priorities of children. And the next slide, please. And we also then collected some patient-reported outcome measure to look at quality of life. And we got 3 scores: mental health, physical well-being, and an overall total score. So it's really good because you can start really understand what factors are at play. And then a pain questionnaire where children can color in where they have pain, so really express themselves. And in other areas of the body. And then the socket comfort score, which is, I think everyone is familiar with this, but it's not really used much with children. So it was interesting to look at that. And the next slide, please. So these are the results. We deployed this study both in Cambodia and the UK to try and understand what are the challenges in different environments, depending of the provision available, but also on the different causes of amputation. In the UK, it's predominantly congenital, whereas in Cambodia was a lot of traumatic amputation. And you can see they're quite young children, mainly males. The numbers are as well, but mainly males, sorry about that, unilateral, and then transtibial and knee disarticulation cases. And then we talked with 6 prosthetists from Cambodia, so the results are gonna be just from that environment, but we're starting to recruiting prosthetists in the UK as well. Next slide, please. So this is what prosthetists told us. So the first thing I want to share with you is that working in a multidisciplinary team is key to success. They mentioned that this is not just one healthcare professional doing all of this. It's really like from surgery and then physiotherapy kicking in immediately, and then prosthetic provision again, gait training, occupational therapy, psychologists, and part of the team and the family. It's also part of the team. So they mentioned that it's really important to have them involved from the start, because they're key to understand the child, and in general, the reaction of the parents or the caregiver can really influence the outcome of the rehabilitation. So really try to get them on board and not too, just not too anxious and stressed about the process, because this is gonna negatively reflect on the child then. They also mentioned that fitting and gait training are challenging, especially for young children. They don't want to walk on a straight line. Sometimes they want to run around. And so this is quite challenging. But also they did say that despite all the challenges, it's really rewarding to work with children. They're very active and they want to use the prosthesis. So that's great. Next slide, please. And this is what children told us. These results specifically are only from Cambodia. I'm done analyzing the one from the UK. And if you reach out, I'm happy to share those results, because I think they may be more relevant to Ukraine, because in the UK years, they also have running blades, swimming prostheses. And so a lot of like the wishes or like desire for improvements may be closer. But this is what children in Cambodia told us. And in some regards, it's similar to the UK, especially for wanting to running and play sports and being independent. So I think when we talk with children, it became really, really evident that they really knew what they wanted, what worked, what didn't work. So I think it's really important to include them in the process and work on a common goal together, so that they're also engaging in the rehabilitation process and all of this, and they know that they're working towards a goal they want. So it's not really like do that exercise because you have to. It's really like, come on, we're gonna do this so we can play basketball. Next slide, please. And then here it's some results on health-related quality of life. On the left, you look at histograms where we compare the scores for pediatric lower amputees in blues and control in pink. And what we see is that there is a significant decrease. So they're doing worse than their peers. And then on the right, concerningly, you see that there is actually a decline in mental well-being and physical score as they get older. This is a similar trend to teenagers. So I think anyone who has been a teenager or as a teenager son or daughter know that it's not the best age, but because they also display already decreased mental well-being compared to their peers, it's really important to have increased tailored psychological support from the start and throughout childhood and development, because they do face a lot of challenges during adolescence, especially with body image concern. So it's really important to not forget about the mental health well-being, because this is then related to the full rehabilitation process. Next slide, please. And then we also look at the physical and mental score separately and see if there was any correlation with other measures. And so what we found is that with pain, if pain increase, mental health decrease. So it really plays a factor in how children are doing. And so it's key to manage pain in order to avoid detrimental consequences of the mental health. And then on the other side, on the right, you can see the correlation between the socket comfort score and the physical health summary. And unsurprisingly, what we found is that with a more comfortable prosthesis, they are doing better physically, they can do more things. And so pain and socket comfort are really two key measures to look at. Next slide, please. And then these results is specifically for Cambodia only, and it's about peer-to-peer support, which is very key in this cohort as well, not only adults. And we could look at the differences that the school factor played in the mental well-being of children. And so, because in the UK, all the children went to mainstream school, whereas in Cambodia, one child didn't go to school, and some children went to a school specifically for children with disabilities. And we see that they do much better in terms of health-related quality of life. And so this really tells us that the benefits of peer support cannot be understated. So not necessarily having school for children with disabilities, but I think having perhaps rehabilitation centers that are specialized in pediatric care would be really beneficial, or organizing sports and arts days for children with disabilities. Then it means that they can still go to mainstream school, but get the benefit of peer support from other settings. And I think we have colleagues in Turkey, they establish only a pediatric center, especially after the 2023 Turkish earthquake, and they're finding really similar results in terms of the benefits of peer support. So I would recommend this is something to think about and could really benefit rehab without much effort or expensive components or anything fancy, just children sharing the same challenges and overcoming them together. It's really, really help throughout. Next slide, please. And then these are the results from the pain maps. So what we did is that we color the different part of the body depending on the pain intensity. Unsurprisingly, we see that for both above and below knee, children report pain in the residual limb, which is unsurprising. Like this is expected because of the use of the prosthesis, because they grow and it may become tight. But what is really concerning is that they also report pain in secondary locations. So you see already in the intact limb joints, the back, especially for above knee. So this is really concerning, and again calls for pain management early on, but also I think there is room for perhaps rehabilitation intervention, so tailor physiotherapy exercise that can help reduce the strain on the muscles. Next slide, please. And then finally, we split our cohort based on the type of surgery they had. So emergency surgery, such as trauma and sepsis, and a planned surgery, so for congenital cases or cancer cases. And what we found is that children with an emergency amputation had worse outcome, unsurprisingly. So increased scar tissue, increased pain, and severe contractures. So if you go in the next slide, please. This really calls again for pain management and appropriate surgery at point of wounding. This is really the moment where we need to act. And these are some resources that we develop. They're open source. They're available in Ukrainian. And I think it's something really useful to have when you have a child on the operating theater and you may not be a pediatrician. And so because they're not just small adults, there are specific things that needs to be done for them, and that if you do in that moment, then it really helps the long-term outcomes. Next slide, please. Okay, now we're gonna dive into AIM2. Next slide, please, which is based on analysis of clinical case files from Cambodia. So their clinicians there take notes every time the child comes to the center. And so they're really informative to try and understand what are the drivers for clinical attendance, what are the type of growth problems and durability challenges children face, but also looking at residual limb health, because as we saw from the previous slide, this is something really key to look at. And the QR code, it's the link to the publication where you can see all the results. But basically, we just analyze these notes and categorize them and then run some statistics to try and see if there were any specific trends. Next slide, please. So here what you see, it's simply histograms that shows, depending on the amputation level, what is the reason of why children came to the center. And what we see is that growth is the number one reason. So over 30% of the time, to 30%, children were coming to the center because they had a growth problems. But then we also see that all the other components also have a lot of problems in terms of durability. And I think this comes back to the children being very, very active. So this is a challenge you're gonna have to cope with. And then hopefully this is also a call to action to prosthetic manufacturer to actually start and test prosthesis to the high activity level of children so that they don't have to come to the center as much. But we see that the suspension system, prosthetic foot, prosthetic knee actually have a lot of durability challenges. Next slide, please. And so when we look specifically at the growth problems, we identify two types. These were also known from literature, but just a good sense check. So socket tightness, because the residual limb expand, the socket is rigid, so it gets really tight. And then prosthetic length discrepancy, which comes from that progressive comparative shortening of the residual limb compared to the intact limb I told you about. The intact limb keeps growing, the residual doesn't, the prosthesis, again, static, so they end up walking on a shorter prosthesis and all tilted, which, as you can imagine, can also have some of those nasty consequences in terms of like scoliosis and these kind of things if they keep using something that is not the appropriate length. So next slide, please. What we did is that we look at the frequency of these problems every year, how often did they happen, and what we found, which I think it's a useful finding to know if you don't treat children in general and you have someone walking in, to know depending on their level of amputation that they can have different problems. And so what we found is that prosthetic length discrepancy is a universal issue. So regardless of your amputation level, you're going to face this challenge. And this is unsurprising because of the continued growth of the intact limb, which should be unaffected. Whereas the socket fit, it's a significant challenge for transtibial and true knee cases. So really try and like look out for that and monitor if there start to be skin redness or some sign that the socket may become ill-fitting with this cohort. Next slide, please. And then in terms of durability of components, in the center in Cambodia, they have two types of component. So they have the standard local components made in polypropylene, and then they have donated components from a charity. And what we found, which again calls out for manufacturer to really try and test their prosthetics to high standards to make sure they're appropriate for the intended environment, is that actually the donated one are significantly less durable, 3 to 4 times less durable. And I think this is because they were not designed for the intended environment and perhaps not considering the high activity level of children. So this really increased the burden on children, their families. They need to take time off of work and school to go to the center, increased burden on clinicians, a low workforce of prosthetic, like there aren't so many prosthetists and orthotists in the world. So I think if we can reduce that kind of burden, it's really beneficial. Next slide, please. And then we also look at the residual limb health conditions, because this is obviously a challenge that affects prosthetic use. And we wanted to see if there were any difference depending on the amputation level. And again, what we found is that transtibial cases are more affected by bone overgrowth, wound, skin issues. The latter two may be related to the fact that they have increased socket fit problems. Whereas we found that for transfemoral cases, they are more likely to have excessive soft tissues. So this is just some of the things to be aware of, again, when a child comes in your clinic, what to expect depending on what amputation level they have. Next slide, please. Then I gave you a hint in the previous slide, but we did also look if there was a correlation between the number of socket fit problems children had and the incidence of residual limb condition. And unfortunately, what we found is that it does play a role. So children that have more socket fit problems are more likely to develop conditions such as wound and calluses, which again then may hinder prosthetic usage. So it goes back to really like timely check the socket fit and be really mindful for transtibial and true knee cases, as they are the one most affected by this issue. Next slide, please. And then these are other common problems that were identified. So significant scarring, skin discoloration, but also weak muscles on the residual limb, neuroma, and contractures. Next slide, please. Right, so this will be the wrap up from the first two studies that I have presented. So just have the key messages there. Working in a multidisciplinary team is extremely important. It's key to the success of the rehabilitation. The family and the children are part of this team. They know, especially children, what are the challenges they have, what they want, what's their wishes. So really try and include them in that conversation, because they can really be a team player in this process, that it's a lifelong rehabilitation process. Physical rehabilitation is challenging, especially with the little children. They don't want to walk on a straight line. They want to run around. Maybe they are tired. So if you ask them to give you a good walk, they're just going to give you a bad walk on purpose. So this is really hard, and it's going to be an ongoing challenge. We also identified that there is still need to innovate in pediatric prosthetics. In both high and low resource settings, components are not small enough. They have good functionality, but could be better. And we saw that durability, it's really a challenge, because again, the international testing standard was designed for adults, which are not as near as active as children. And so even if the prosthesis passed the standard, it doesn't mean it's appropriate for that cohort, or if it's used in harsh environment for that environment. So there is a lot of space to innovate here. And obviously, as a biomedical engineer, I'm quite biased, but this is really my area. So call to action there from me. Then we look at the psychological support challenges. So children are doing worse than typically developing children, and there is a decline with age. So it's important to really integrate that psychological support from the start. And I think because children in Ukraine will also have to face and accept the trauma of war, that's gonna likely be more significant. We found that socket comfort influences physical well-being. So this is expected, and it's key to consider. Again, importantly for transtibial and true knee cases. We also found that pain negatively affects quality of life. So it's important to have pain management strategies, and also perhaps thinking at rehabilitation exercise, because we saw children have pain in the residual limb, but they also have pain in the back, in the intact limb joints. So really an ongoing challenge. And I think it will be beneficial going forward to really start and work together, researchers and clinicians, to test interventions and see if there is actually any long-term benefit to this problem. We also found there is worse residual limb outcomes for children in emergency amputation, so increased pain, increased scarring, increased contractures. And again, the resources I share, I think it's really important to use them in the operating theater, and then starting the pain management very early on so that these issues can be mitigated. And then, as hinted throughout, growth and residual limb problems are different depending on the level of amputation. So it's something to keep in mind when a child walks in the clinic. Okay, it's transfemoral. I need to be mindful of excessive soft tissues, control issues with the prosthesis, whereas for transtibially, maybe look at the socket fit, monitor it really closely, look for residual limb conditions, and so on. Next slide, please. And then this is the last aim. I've been talking a lot, but I promise this is the last 10 minutes or so. So here we really wanted to start and look at how children compensate for the loss of the limb and for the ongoing challenges we identified. And this is also came from the fact that we look from that pain map, heat intensity pain map, that actually children have pain in other locations. So we ask ourselves, is there something to do with the way they move that may be influencing that? So if you go in the next slide, please. So basically the aim of this study is to compare the gait, to identify the gait compensations compared to control, and look at how this changes when the prosthesis becomes really tight and short due to growth. Because we know this is an ongoing challenge, so it's important to investigate this gait compensation, first of all, to be able to realize maybe earlier on if this child needs a replacement without necessarily the socket become really, really tight, and then it's like, okay, now it needs to be replaced, but can we do it more timely? And then the other thing, again, this is for all of you, but once you identify these compensation strategies, it's really thinking about what exercise can we do to reduce them, to help the children, which muscles need more strengthening, and so on. So if you go in the next slide, please. So what we did is that we did the optical motion capture with the Grail system. So this is a very nice piece of equipment with an instrumented treadmill with force plates, so you can record the forces. Then you put markers on the lower limbs, so you can track the movement of the individual segments. And there is also a screen with virtual reality, so children remain engaged and they just feel they're walking towards something, not just on a treadmill. And we didn't use it for research, but for people who may be interested in looking at some equipment for rehab, or maybe one that, this equipment, it's really useful because you also have a lot of games for rehabilitation. So you have games where the treadmill moves sideways with perturbation. So it really helps improving stabilization and all of these things. And there are several games like that. And in the hospital where I worked, it's really used for this kind of thing. So maybe it's something good to be aware of at some point if there are investment, and this may be useful to have. Anyways, so we collected the data when children needed a new prosthesis. So when it became really tight and short, they got a new one, and then we did data collection with both prostheses. And then we used the open source database of children, typically developing children, that we use that control and that we match based on age, height, body mass, and limb length. Next slide, please. And again, because we were successful with these questionnaires, we also took collected the PETSQL pain questionnaire and the socket comfort to see if they were useful tools, perhaps for clinicians to use and to see when the prosthesis became ill-fitted due to growth. Next slide, please. So this is our cohort. So we started with children with a below knee amputation. So you see a lot of ankle disarticulation cases and transtibial cases, mainly ankle, sorry. But we still, so in the UK, that's one of the most common level of amputation, because children have a lot of amputation due to congenital causes. So because you can choose the level of amputation, then ankle disarticulation, it's better because you have that end bearing advantage with the socket. However, they also exhibit stunted growth. So actually it looks like a transtibial amputation in terms of like length of the residual limb, but then obviously they can unbear. So we could say in terms of limb length, it's similar. And then you can see they're quite young, on average 8 years of age, and predominantly male. And you can see they're quite well matched with the controls. So we were quite happy in terms of like age, height, limb length, and mass. Next slide, please. So these are the results when we compare the two prostheses, the one that needs to be replaced because it's tight and short, and the new one that was just made. And we find that there is significant difference in socket comfort score, in pain score, and we also see that actually the difference in height is quite significant, so almost more than 2 centimeters. So this is quite concerning, but it also calls out for socket comfort and this pain score as useful measure to start and like deciding when perhaps the prosthesis needs changing. And again, including the children in the process, I think it can be really beneficial. And these measures are quite easy for them to express what they think rather than try and maybe talk with them as if they were adults. And then you also see in the pain map that they do have a lot of pain in the residual limb when the prosthesis is tight, which is expected, and then this improves with the new prosthesis. Next slide, please. So this is going to be the last results I show you. It's quite intense, but I think it's interesting to see. So what we did is that after we collect the data, we did a lot of computational work and get the inverse kinematic results. So the angles of the hip, knee, ankle, and so on. And we compare it to the typically developing children. And what I'm presenting now are the results that are statistically significant, so that they are significantly different than controls. And we call this the compensatory movements. So when I highlight one movement, it means it's an exaggeration compared to what it should be. And I'm going to walk you throughout the gait cycle for the intact side and the prosthetic side separately. So if you go in the next slide. In the next slide, please. Sorry, yeah. This slide, don't go in the next. Oh, well, it's okay. So we start, basically they start the intact stand phase with a hip hyper-abducted on the intact side. So this is expected because when you hyper-abduct your hip, I don't have to tell you, but you have a wider base of support. So this is to increase the stability. Whereas on the prosthetic side, just before the swing of the prosthesis, they have the hip hyperflexed. And I think this is their way to start and clearing the ground. Also, some of these children had running blades, so they're quite compressible. So I think some of that flexion may be coming from that when they're just about with toe off, propelling the limb forward. I think that blade might be compressing a bit. Then we see during the prosthesis swing, there is also a lot of compensation going on. So I think because they have poor control of the prosthesis, it's really tight, it's not really fitting well, they are compensating a lot on the prosthetic side to clear the toes, the prosthetic foot. So they have, again, a hip hyper-abducted, so hyper-abducted and also externally rotated. And they also slightly flex the knee a little bit. So you understand they're doing all this movement to try and clear that prosthesis from the ground. So then what they do is that on the intact side, they assume a crouch gait. So they are really like hyperflexed in their hip and in their knee to try and stabilize throughout this complicated movement. And then if you go in the next slide, please, they start the prosthesis stance with the prosthetic side hyperabducted again. This is similar to the intact side during stance. So they want again that wider base of support to really feel safe on the ground. And we see that the ankle on the intact side is hyperflexed. So I think this come again from that compensation, and also because now they are relying on the prosthetic side just before swing of the intact side, and that prosthesis is much shorter. So I think to try and level the pelvis, they really need to be flexed on their intact joints. Next slide, please. And then we see that, again, because of these shorter prostheses, they need to also compensate on the intact side to clear the ground. So again, hip abducted and the knee flexed so that they can clear the ground even if the prosthesis is not the appropriate height. And then I'm not gonna walk you throughout all the same results for the well-fitting prosthesis, so the new prosthesis when it fits well, but I'm just gonna tell you the two main changes. So if you go in the next slide, please. So with a well-fitting prosthesis, what we found is that there's still a lot of compensation on the intact side. So similar significant hyperabduction and flexion in the intact joints, but they're much shorter in duration. So this suggests an improvement. And then we also found that all those compensation during the prosthesis swing to clear the ground are gone. So it's good because I think they have a better control of the prosthesis, so they don't really need to abduct and rotate the hip as much, and also no need to flex the knee. So that's good. But it's really concerning, all this hip abduction we're seeing and the intact joints flexion. So it's something to be aware of and bear in mind. Next slide, please. So again, this is a first study that really look at the inverse kinematic for children, and we found they do have clear compensation strategies. And as I said, hip abduction really concerning for both sides, for the intact side, but also the prosthetic side, and concerningly the intact joints hyperflexion. So this can be really detrimental in the long term. So I call out to all of you to think about what we can do, what rehabilitation intervention can be developed so that we can help and mitigate that. We found that with the new prosthesis, when it fits well, these compensations are reduced, especially on the prosthetic sides. And we also found the improvement in comfort and pain, which from previous findings, we know that really influence the physical well-being and the mental well-being. So basically, it's really important to timely replace the prosthesis. So try and be really schedule follow-up and make sure the prosthesis is well checked so that children don't have to work on something that doesn't work well for them. Next slide, please. Yeah, so this is just my conclusion, a wrap up of all this finding, which I hope can help you in your provision. Because of the high number of explosive remnants of war, amputation is gonna be a big challenge in pediatrics. We know it's gonna be challenging, but there is a lot that can be done. You can think about establishment of pediatric center for peer support and specialized care, or organize pediatric days so that children can come and get together, professionals can share experience and really try and build that community. We identify there is a need for innovation in prosthetic design, need for increased psychological support from early on for the trauma, and then as you progress throughout childhood. And again, I think the last slide was very clear on the need of tailored rehabilitation exercise and intervention for this cohort to mitigate the pain and the compensation strategies, and then in turn help them with their overall physical and mental well-being. And then I can't stress enough the importance of socket fit, again, to reduce pain, residual limb condition, and improve general well-being. And the next slide, I just want to finish off with a nice video and just say that children are extremely resilient, they're very active, they're gonna cope so well, much better than adults would do. So we can do a lot for them, and they are very strong, so they're gonna be fine, and they're gonna have a very beautiful childhood and life. So I'm very confident of that. Next slide, please. This is just to acknowledge all the people that helped me and all the funders and the collaborators. This would not be possible with them. And the next slide, just want to conclude with some of other works that we do, that it's in the next slide, please. Some outreach activities. Sorry, I think maybe it froze. Could you go to the next slide? Yes, so we do a lot of outreach activities to spread the word and say we need to do more for children. And so we had the honor to welcome Madam Zelenska to our lab, and she's very interested in children. So it was a real honor to share with her what we do. And we're gonna continue to, just do key outreach activities and support children to the best of our effort and knowledge. And the QR code is just with all the resources if anyone is interested. Thank you very much for listening. Sorry, it was very long, but
no, it was just right. Thanks, Claudia. It was very interesting and useful too. We have a few questions here. So we'll start with the top one. Give me a second. Does the amputation, the SIME level amputation, does it have a better functional result than a transtibial amputation?
So in theory, it does, in the sense that it's similar to transfemoral and knee disarticulation amputation, because if you maintain the end of the bone, you can end bare. So in the prosthesis, you can make it differently so that it actually loads through the distal end of the limb. And also another advantage for children is that you retain that growth plate, so you don't lose that growth potential, and then the residual limb is going to be longer at skeletal maturity. But from our research in the gait adaptation, we still saw that even if they have technically better functional outcomes, they do have a lot of compensation. That was not expected,
Thank you. Another question. This is from one of the professors at one of the universities. Our students' theses involve improving existing prosthetics and customizing them, including for children. This must be done correctly based on current industry norms and standards. However, standards for permissible design loads and test modes are not publicly available. How can universities gain access to these documents?
Yeah, thank you. That's a very good question. And I think they should be made publicly available because they do cost a lot of money. We have a partnership with Pinoff from our group that now it's developing prosthetic limbs for challenging settings. So conflict zone, post-conflict zone, low and middle income countries. And they have access to this standard. So they shared it with us. And if you email me, I'm happy to send you the document so that you can have a look. And I think it's a great standard in terms of testing. But what we found when we look at what it needs to be done for children is that the loads are not appropriate. So they're very high. And at the same time, the number of cycles are very low because it's like 3 million, which would represent like 3 years durability. But then children do way more than 3 million cycle over 3 years. Like they just run so much. And also I think it doesn't account for like the ways they may use the prosthesis. So playing in the mud, like kneeling, jumping, like it's so many activities that they do that the average adults wouldn't do. So I think the standard is great, but again, as pediatric specific section would be really beneficial.
Thank you. Another question about upper limb. So regarding the transradial amputation or pathological limb loss at the transradial level or the transhumeral level, is there any experience of fitting kids with myoelectric hands in such case?
Okay, so I'm not really an expert on upper limb, so I'm just gonna say what I know a bit from experience and talking with people, but don't take my word for it. But for instance, in the rehabilitation center in Turkey, they did have funds to get myoelectric hands. I'm not too sure about like the level of amputation for which they fitted them, so if that would play a role. But they did say that it was too heavy for the children. So whereas they would be like really good at activating like the hand with the muscles, they were only able to do it with the prosthetics resting on the table. So effectively it's then useless, because the moment I want to stand up and like just grip something, then it's too heavy for me because I'm too little. I don't know if you're familiar with Koala prosthetics. It's a startup, and they made sleeves that are really, really successful with children because they're comfortable, they're easy to put on. There's a lot of different tools. So, I mean, you need to change that, but it seems to be really, really working well for children. So perhaps this may be something more appropriate, especially for little children. I think as you get older, then a myoelectric hands is obviously like great, but if you're very little, like you just want something that it's a bit easy, a bit like durable, like if you smash it somewhere, it's okay, like it's not, yeah. So that's, I can put the name in the chat.
Thank you. Вадиме, у вас було питання?
Да, доброго дня. Я ветеран і більше працював як рівний
I'm
рівним.
a veteran and I worked according to peer-to-peer program, but I had quite a few instances working with children. And I thought that adults needed more assistance than children, because children get back to normal in the play and game much faster. My question would be about upper extremities, but you already answered it. And I believe that indeed, if the level of amputation allows to work without prosthesis, then you probably need to work with the child so that they can adapt to living without the prosthesis and then add prosthesis. But your experience is amazing. Thank you so much.
Vadim just supported what you said about upper limb prosthetics.
Okay, I was like, maybe someone is saying it's actually not true, because I'm not a clinician, so, but it's good. Yeah, good sense check. Thank you.
So, any other, ще якісь питання в нас є? Any other questions? Let me just check all the chats. Here is one. How often is the sleeve replaced in children?
The sleeve as the socket.
The socket, yeah, the socket.
Yeah. So what we found in from that medical case file analysis in Cambodia is that usually every like 12, 15 months it gets replaced, but then often like every 6 months or something, there is an adjustment to be made. So we actually, I didn't share it today, but we did an analysis to look at like how prosthetists adjust the prosthesis, so all the techniques that they employ. So for instance, heating the socket. In Cambodia, they have polypropylene sockets, so that's a thermoformable material. So they really have that advantage of heating out the socket, which you don't get with carbon fiber sockets. So they were actually saying perhaps polypropylene is a better option for children. As a prosthetist, you do get that increased degree of adjustability, and then swapping socks, the cotton socks you put on the residual limb, grinding off material. So we should publish these results soon, and hopefully they can be useful if you start treating children and see how they're doing. But yeah, roughly every 6 months they need a little adjustment on the sleeve, and then every year and a half, it needs to be replaced.
Thank you, Claudia. Another question about parents. When a child is getting prosthetics and the whole process of going through it and so on, how are parents usually involved, and what is their main role in that whole process?
Yeah, so I think the parents are they need to be involved and prepare quite a lot. I think what we found is that oftentimes they are facing almost not as much, obviously, but almost more challenges than the children. So I think a lot of the work, it's also just calm the parents, walk them through what is gonna happen, explain, really try and convince them. Sometimes, for instance, surgery is the best way forward. We found that parents are really struggling with accepting surgery. So I think really try and include them very early and explain them what needs to be done with rationale. That's the best thing for their children, because I think then their reaction can really affect children. So for instance, what clinicians were telling us as well, it's when children are too little, they can get knee joints, and then at some point there is enough space to put the knee joint. And whereas children are keen and they want to try it, actually it's the parents that are really worried they may fall. And whereas actually these things should be normalized. It's yeah, you're gonna fall, you're learning, you fall, then you stand back up. So I think really try and work with them and explain them things. It's gonna be beneficial, because otherwise their worrisome is gonna influence the child, and then they're gonna get scared, and it's kind of a vicious circle. And I think the parents also need psychological support, because it's really challenging for them as well, that seeing their children has a lot of challenges and difficulties, and then as an adult you see more things that could go wrong, you think about their future. So I think some support for the parents would be great, because often the caregivers are forgotten because it's not them with the disability, but they take a big toll.
Thank you. And one more question. From what age can a child be fitted with prosthetics?
So in the UK, they start from 1. So roughly if it's a congenital case, so when they start pull to stand, obviously there aren't many components. So usually it's just a custom socket, and then oftentimes you have to manufacture the foot because they're not small enough. But then just something so they start stabilize, and also if they're very little, they integrate prosthetic use so much more easily. In terms of other components, if a child has an amputation at 5 or 6 due to trauma or something, it may be that the prosthetic knee joint doesn't necessarily fit, because again, sometimes they're not small enough. So I think it depends on how much space you have distally, because obviously they're very, very tiny, and then the socket, the knee, the pylon, the foot, there's just not space. But technically from 1.
The liner size selection, can you imagine?
Sorry, I'm unprepared on this one. I think
I just made a comment that it could be a challenge for sure.
Oh yes, sorry, yes, that one definitely is a challenge. I think small sizes is not really something that the prosthetic industry loves. because yeah, they are very tiny. So I mean, it is a challenge to make them. So I think it's really to the prosthetists and the technicians to custom made the foot. Yeah.
Thank you, Claudia. I don't see any more questions.
Thank you very much.
Thank you. Thank you for the presentation. It was informative for sure. Thank you for spending time with us and sharing your knowledge and expertise. It's always great to have you. Thank you.
Thank you for inviting me. Have a lovely day and
have a good day.
Continuation. Bye-bye.
Bye. Друзі, в нас перерва півгодини. Так, дивимось.
We have half an hour break.
35 хвилин. Так, до
Actually,
15:30
34 until 15:30, and then we reconvene. We have two more very interesting lectures about prosthesis, restoring confidence and reintegration.
Усім, повертаємося на наш марафон.
Welcome again to everyone. Yeah, moving back to our marathon.
Morning, still, but close to, well, morning, afternoon, nobody knows anymore. So we are continuing our marathon. It's been great so far, and we're excited to have our next speaker, and his name's Christopher, and he is one of the icons in the prosthetics orthotics industry, and he has shown a great example of resilience, of perseverance, and how a person can overcome challenges and move forward. Hello, Christopher. Thank you so much for being with us today. We're happy to have you, and please share your story and your innovations. Thank you.
Thank you very much, Antonina, and thanks for having me. And as Antonina said, this lecture of mine will focus on my story and the things that I've been through since my accident. And I really hope that this can serve as an inspiration, especially for all of you out there suffering from limb loss. I think this can, and I will point out throughout my story and my lecture that life will continue, and opportunities will arise in many unexpected ways. And I hope my story can show this and be an inspiration for many of you out there. So with that, let's get started. And can I get next slide, please? Excellent. One more, please. Excellent. So the story of this starts, of course, with my accident. So my accident, it happened in the year 2006. Back then, I was 17 years old, and my accident happened during the summer. And I had summer break from school, and me and some friends, we decided that we wanted to go to this car event this particular night. So we do, and we have a great time, and it's a little bit of a party evening. But during the early night, I think it's 12 o'clock at night, I start to feel quite tired. I've been up early the same morning working at my summer job. And my friends think it's way too early to end this great night. So it all ends up with me starting to walk home towards our camping tent that we have put up this particular night. So I walk through downtown and then start my way on my journey towards out to the camping site or the camping tent. And when I'm walking and actually passes some industrial areas, I suddenly see that there are 3 guys walking behind me. And immediately I get a strange feeling that there's something wrong in this situation. And I continue to walk, and that feeling is just increasing. And eventually I feel that these 3 guys walking behind me, they're following me. And then my thoughts start spinning up in my head, and eventually I decide that if I just continue to walk straight ahead, I can actually get back to downtown of the city, and I can meet up with my friend in downtown. So that I will do that. So I continue to walk and increase my speed a little bit. And after this decision, it's just blank. I can't remember a single thing more. But of course, after my accident, I tried to collect all kinds of data and info just to understand a little bit more what could have happened this particular summer night in 2006. And eventually I came to the conclusion that I think that something has happened with these three guys behind me. I think that I started running, and I also think that if they did something, I think that I outran them. But when I'm running, I'm crossing some train tracks. And I don't know, in the dark, maybe I was looking behind at the same time I kicked my foot in the tracks. So I'm falling handlessly and hit my forehead badly. So I crush my forehead and I pass out with both my legs still up on these train tracks. And at 4 a.m. in the morning, this cargo train comes. And I believe you all can imagine what happens next. The cargo train, the train driver, he sees me, but when he sees me, then it's already too late. And of course, he tried to do everything he can to get stop of this train, but it's impossible for him. So the train runs over me, and the train amputates both my legs immediately above the knee. And I had jeans on this particular night. So we believe my jeans got stuck in the wheels of the train, and then my entire body is thrown towards the train, and the left arm got in under as well. And eventually he gets stop of this train. He calls 911 or 112 in Sweden, and this alarm goes out to all the units like ambulance, police, everything get this. And there are 3 policemen first on site. And after the accident, I've spoken with them several times. They initially thought it's no chance that him or her that's been under the train is still alive. But they start walking behind the train, and eventually they find me, and they literally save my life with shutting all the bleeding, because there were 3 main arteria were off, so I was bleeding intensely. And they literally saved my life until the ambulance got to the site, took over, and then it was full speed up to University Hospital in Gothenburg, where it was stated that I lost more blood than should be possible. So my heart shouldn't be able to keep on pumping. But thanks to that, I before this accident was an elite junior swimmer, made that my heart managed to keep on pumping due to the severe blood loss. And I survived this accident against all odds. And we can take next slide, please. And at the hospital, I wake up at the hospital approximately 10 days after my accident. I have no clue of what has happened, and how could I even continue from this. It was a really, really tough time. And here in the beginning, I get a lot of morphine. So in the beginning, it's a little bit hard for me to take it all in. But approximately a month after my accident, they start lowering the morphine dose. And that's when I wake up and I realize that I lost both my legs above the knee and almost my entire left arm. And at this point, I had no clue. How can I continue from this? Before my accident, I had never even seen an amputee. And now I had 3 amputations myself, and I were in severe pain. And I was in this hospital bed, and I could hardly go from lying on my back to lying on my side. So that was a really tough time for me. And I truly believed that I will stay in this hospital bed for the rest of my life. Because what is possible to do as an amputee? But then one day I get my hands on a VHS tape, if you remember those, from about this guy. The man on the picture is Cameron Clapp. He's an American amputee. He's from California. And a few years before my amputation, he was in a very similar accident in California, where he was also run over by a train, lost both his legs and his right arm. And in this TV show, he shows he's up on his prosthetics, he's walking, he's running, he's even skiing with these prosthetics. And I usually say that this is the absolute biggest turning point in my whole rehabilitation. because before I've seen Cameron, I had no clue how I will continue, and I had not any big hopes for my own future. But after me seeing Cameron, he like showed the way for me and gave me so much inspiration and motivation that I knew that it will be a lot of effort. I will have to put my training in and do all these struggles. But one day I will be like Cameron, up and walking once again. So this was the biggest turning point, and I truly hope that this can inspire many of you out there with limb loss to show that it's possible to get back and to continue your life thanks to prosthetics. Next slide, please. And after I've seen this video with Cameron, I was really eager to get back. And I just wanted my prosthetics. I wanted to be up and walking, the first thing. But the journey back wasn't really that easy. At the rehabilitation center where I ended up, the first thing I needed to learn again was just to sit up and keep my balance at sitting, because I lost a big counterweight being my legs. So I needed to learn to keep my balance once again. And from there, I needed literally to learn everything once again that I could do before my accident. I needed to find new ways to do those things once again with my new body. And here, really just putting the effort in and doing all the struggles, the trials, and have the physiotherapy helping you out in exploring your new body and how to solve all these matters. That's really crucial. And as I said, I was an elite junior swimmer before my accident. So after my accident, I was also really eager. I wanted to get back down in the water once again. And with my new body, I had no clue how this will end up. And I remember this first time I'm getting into the water. It was approximately half a year after my accident, because it took a lot of time for my wounds to heal. But when they were healed, I was approved to go into the water. And this first time, lifting the patients from the wheelchair down into the pool, it was broken. So the lifeguard at the pool, he said, you have to dive in if you want to get in. And I remember thinking, diving in, I'm not even sure if I will float or sink. But I did take a deep breath and I didn't dive in, but I did some kind of falling or jumping into the water. And slowly I start to sink towards the bottom of this deep pool. And I remember thinking that I'm lucky, at least I can hold my breath for some time. But eventually I take this first stroke with my last hand or arm. And immediately I feel like this is it. This is how it's done. And the closest thing that I can compare it with is riding a bike. You just feel how you will move, in my case, in the water. I get up to the surface, I put my head down, and I start swimming freestyle. And during my first hour, I swam all the 4 different swim courses. And they were buried into my muscle memory, and I could easily pick them up once again, now with just one arm. But still, I managed to do all the 4 different swim courses. And in water, I was weightless, and it was a fantastic experience. And I just wanted back to this pool. And I wanted more and more times in this rehab pool. But eventually, the lifeguard told me that, hey, Christopher, there's more guys than you that want to be in this pool. So you can't have all of the time slots. So then I reached out to my old swim team, and they took me in with open arms. They had no adaptive or disabled swimmers since before, so I was their first one. But it really worked out great. And I became a champion in the Swedish team. and eventually also managed to get into the Paralympic Games in Beijing 2008, which were 2 years after almost exactly 2 years after my accident, where I ended on 2 fourth places. And even though I missed the medal, I was kind of happy because I qualified to the Paralympic Games as the 10 best swimmer, and I left the games as the 4th best. So I was happy with those results, and I was eager to put in the effort to really grab a medal in the next Paralympic Games, which would be in London 2012. Next slide, please. And when I'm training with my prosthetics and also training with my swimming towards the Paralympic Games in London, I'm also training with my prosthetics. And when I'm training with my prosthetics, I have quite many difficulties. And I think this picture is really good, showing all of my amputations. As you can see, I have a fairly long stump on my right-legged side. This side works really good with the socket fit. But on my left side, in my accident, I had a lot of soft tissue damage. So during the accident, they re-amputate my leg at this height. And due to my short left stump, I had a lot of socket difficulties on my left leg. And you can also see I have a fairly short upper left arm amputation. And on that level, I had a totally functioning prosthetic arm that I was using with the harness and everything. So with my prosthetics, I was up, I was walking, but first of all, with the short prosthetic limb like that, it's really hard to find to get a stable prosthetic socket on that high level because I can move my femur bone within the socket a fair amount. And also when I was walking with my socket fit on my left leg, actually the entire prosthetic leg came off. So in the year 2008, after I've been in the Paralympic Games in Beijing, I did the osseointegration surgery. So I did it in Sweden, in Gothenburg, and back in 2008, they only did this surgery in Gothenburg, in the entire globe. So people or patients came from all over to Gothenburg, Sweden, to do the osseointegration surgery. So I did the surgery and I managed to get osseointegration both in my left leg and also my left arm, mainly due to my short stumps. And actually, I was the first patient ever to do the osseointegration surgery in lower and upper, so both on leg and arm in the same surgery ever. Next slide, please. So on my osseointegration on my left side, I now have my prosthetic leg is fixed to the bone, creating it's really stable, and also it's fixed so it don't come off, which is also critical. So the leg actually stays on. But I'm still using the socket on my right-legged side, because on my right-legged side I have a long stump and the socket is totally functioning. And I would say when you have a functioning prosthetic socket, there's no benefit in doing the osseointegration surgery also. I would state that only if you can't use your prosthetic due to all kinds of different reasons, it could be a lot of that you have a lot of problems with your with your socket, and therefore can't use your prosthetics, then osseointegration is a great alternative to prosthetic sockets. But you get other drawbacks with osseointegration instead. For example, you can get deep infection. I had a deep infection in 2011. I needed 3 surgeries and a lot of antibiotics to get it healed out. and you can also break the system being too active. So I would say if the socket is working, stay with it. If it's not working, then you could consider it. And all of this, I would say, on lower limb. Speaking about my upper limb, my prosthetic arm, I would say on above elbow amputees, osseointegration is a really good alternative because the weight of the prosthetics gets much lower. You can really use the prosthetic you can put your entire body weight on it. You get full shoulder movement. So on upper extremity, I think osseointegration is a really good alternative. Next slide, please. So when I had my osseointegration done, my prosthetic started working, and I became a full-time prosthetic user. I was up, I was walking with my prosthetics, and as I was walking, especially in indoor terrain, that worked really good. But I'm an outdoor guy, and I love fishing, and I love being in the coastal areas and those type of places. And in the beginning here, I'm feeling that it's really hard to keep my balance with two prosthetic legs above knee amputee when you're out and walking, for example, like this on a gravel road or on the beaches or on lawns and those type of places. And here in the beginning, I'm thinking, it's me. I need to practice more with my prosthetic legs, and then I will be able to walk also in these outdoor terrains. But the years go by, and actually before I'm heading to the Paralympics Games in London 2012, I'm walking on a gravel road like this with my fiance Martina besides me, and suddenly I'm stepping on a route pointing up from the gravel, and it totally catched me off guard. So I'm losing my balance and I'm falling due to this unevenness. And when I'm down there in the dirt, I'm so angry and I'm so frustrated on my prosthetics, because back then I knew I've been practicing with my prosthetics for several years. I knew I had the best prosthetic equipment there is. I had tested all kinds of different solutions, and I was fit. I was soon to go to the Paralympic Games, but still I couldn't go this fairly simple gravel road. And with all this frustration, I take that frustration with me back home and back to the university, where I'm studying to become an engineer within the field of product development. So at the university, we start looking into this particular area. And the question we're asking is, why does I have good balance walking indoor, but really poor balance walking outdoor? And eventually, we came to the conclusion that it's the prosthetic foot that causes this. Because if you compare a prosthetic foot to a human foot, the human foot bends and adapts to all kinds of unevenness that we are stepping on. But a prosthetic foot is, in comparison, very stiff. And that's what creates the stability issues when you step on something uneven that the foot cannot adapt to. That creates, in that case, a momental force trying to push you out of your balance zone. Next slide, please. So we developed a solution to it and developed a prosthetic foot that really can bend and adapt in a higher degree to the unevenness. So you can keep your balance even if you're stepping on something uneven. And this, now we're really fast forwarding in time. This took years to develop. This was a cooperation between many different universities in Sweden, prosthetists, and also prosthetic users. So in the end of 2015, we launched this product, and this is what the first 6 patients said when they trialed the foot. And my own personal favorite is the one to the top to the right. It feels like I have my own foot again, because this was exactly what I was developing this foot to be. I don't want a prosthetic foot to feel like something robotic down there that I am not in 100% control or in charge over. I want something that feels like before my amputation, like a part of myself. That's why I was really happy with that quote, that it feels like I have my own foot again. And next slide, please. So this is actually a study not made by us at Lindextend. And maybe I should say, so when we developed this foot and launched it to the market, of course, I also founded this company, Lindextend, along the way. I got a lot of help from different, both universities and different startup communities in Sweden to launch this new company. So this study is made actually by Otterbach, and it shows how much can other prosthetic feet, commonly used prosthetic feet out on the market, actually flex in inversion, eversion. As you can see on these graphs, the majority of flex is around 4 to 6 degrees of inversion, eversion. And side flex is up at, I believe, looking like 9 degrees. Unfortunately, they didn't test our foot in this test, because our foot can flex 17 degrees, and I will show that a little bit more later on. And next slide, please. So this is actually to show a little bit what happens if you have a prosthetic foot that don't do the adaptation. You're out, you're walking with your prosthetics, and you're stepping on something uneven. Let's say it's a rock that creates 10, 15, or 20 angle displacement at foot level. How much displacement is it then up at socket level? It's 10 degrees creates 15 centimeters of displacement up in socket level. 20 is all the way up to 30 centimeters. So this is the momental force that I spoke about earlier, trying to push you as a prosthetic user to one of the side. If you don't fight these forces, you will fall. If you fight them, you will be up, but you will not be stable, because you will still be standing on this small object, instead of having a prosthetic foot that actually bends and adapts, and then you're standing on the whole sole of the foot, just like a human foot actually works. Next slide, please. So we have several different measurements on this. This is from the University Hospital in Gothenburg. It's a 6-minute walk test. Since this foot is very flexible and adaptable, this study shows that we still have good energy return to our foot, because the patients, they walked for this 6 minutes a longer distance than they did with a regular carbon fiber foot. Next slide, please. So this is how it looks. This is actually the 3rd generation. In the beginning, we had a lot of, in Swedish, we call it child disease. I think it's called in English growing pains, that the initial product actually did break down. And that was because all the flexibility in this prosthetic foot lies within the material itself. And we're really pushing the limit of what this material can handle. When we push the limit, we initially got micro cracks, and when you keep on walking, those micro cracks, they expand, and eventually the foot is breaking due to that. So this is the 3rd generation, and the 3rd generation has the same amount of flexibility, but it doesn't break down, which is really good. So this is how it looks. Looking at the forward laminate, that is in glass fiber, and the heel laminate is also in glass fiber. Glass fiber can actually elongate or bend 3 times more than carbon fiber before it snaps. And there are several versions of prosthetic feet out there on the market, but fiberglass doesn't have as good energy return to it. So that's why we're combining it with our sole laminate, which is in carbon fiber, glued to the heel and to the toes, giving it the best out of 2 worlds. Good energy return, but also a very flexible prosthetic foot that can adapt to the unevenness of the ground you're stepping on. Next slide, please. Yes, and here's a short video showing what the foot actually can do. Maybe it's lagging a little bit, but I hope you get a feeling of what this foot actually, how it actually moves and bends to the surface that you are stepping on and adapts. And you're in total stable movement throughout the entire step cycle. And the absolute best way for all of you out there to see more in detail what this foot can do is to try it and get your own feeling of it. Next slide, please. Next slide, please. Perfect. And we can start this one immediately. So the second product that we developed with LindExtend was this, and this comes straight out from my personal need of a better solution for living with prosthetics. When we launched this product, there were no other solution out on the market that could do this as quick and without any tools and a double security for safety. For example, putting trousers or pants on and off. The foot is locked in a 90-degree angle, which makes it really hard and tricky. And now with this, you just can take the foot off and put pants on and then put the foot back on once again. And it just makes living with prosthetics so much easier. And one of the big things that I really would like to stress is this, that it has double security, because if one of the lock fails for any reasons, it could be that, for example, I forget one of them, it shouldn't come apart. It shouldn't be able to come apart in any way, unattendedly. Next slide, please. Perfect. So this can be used in many different situations. For example, as I said, getting dressed, sit in a vehicle more easily, change if you have like a running blade and a regular, or a water leg and a regular, or just for sitting more comfortably in a chair, a sofa, those types of areas. So it just makes living with prosthetics so much easier. And and next slide, please. So, and here is from a survey that we did with amputees. And the first question is here, why is it complicated to change pants? And it's a bunch of different reasons, but I think the most interesting is just that 17% thought it was not complicated to change pants. And now I can do it in a few seconds, just disconnecting the foot, putting them on, and then putting the foot back on. Same thing with shoe. Slide, please. And also during long travels, like every time I sit in the car for a little bit of a longer time, I'm always disconnecting my prosthetic knees, because these knees, they are really heavy. And when you're just sitting, that weight creates like a pressure inside your prosthetic socket. So I can actually get blisters just by sitting with my prosthetics. So then I disconnect my knees, take away all the weight, and then I can sit much more comfortably. And when we arrive, I just snap on the leg in a few seconds, and then I'm good to go. Also, when you're traveling, instead of bringing many prosthetic legs, you can just bring the spare parts you need instead. Next slide, please. This is also something that I really want to stress for all of you out there, bilateral above knee amputees. I would say you must use stubby legs. I still use my stubby legs. I first of all got these when I was in rehab, getting to be weight bearing and or actually to stop using the wheelchair, to just use your stubbies at home or at the rehab center, and just be able to walk around with these. They're really lightweight. And if you fall, you won't hurt yourself because you're really close to the ground. And then I would say when you can walk in all terrains with these, out in the forest and everywhere with the stubbies, first then I would say you should start with the long prosthetic knees. Before that, it's you need all that core muscles and build up the muscles in your hips and stumps and all of that. So yes, I really just want to stress this. So wait with the long legs until you can manage all terrains with your stubbies. Next slide, please. And here's a little bit regarding our quick adapters. They come in many different variants. So you could, the main idea here is to replace the static adapter that's been looking the same for 40 years. To have something that actually kind of funny, still looks the same, but it has an added function. And the added function is that you can safely disconnect your prosthetic leg and safely put it back on. Next slide, please. And if you think it's hard to find which solution that fits your prosthetic leg, on our website of lindaextend.com, you can go in and we have a configurator and you can actually build your own prosthetic leg and use it for the area that you find is most suitable for your case. Next slide, please. And this is what happens. So this is Diane. Diane lives in Florida and she runs a charter boat company. And she got our adapter, the Extend Connect adapter, because she has a water leg and a regular leg. But when she's on her boat, and as you see on the picture here, fixing with the ropes, then she realized that her prosthetic leg, actually, it's just in the way when she's fixing the rope or she's getting into the engine and it's a really tight spot, then the prosthetic is just in the way. So then she quickly takes off the leg, fix what's need to be fixed, and then snaps the leg back on once again. And these things, we didn't anticipate this. Diane didn't anticipate this before she actually got the device on herself. And then she realized that in this situation, this is really useful to just take my prosthetic apart, leave the socket on, and then snap it back on quickly. Next slide, please. Yes, so literally the sky is the limit. And this is a video recently posted by me when I show that I go gliding and just disconnect my legs and go gliding without them actually. Because when I'm sitting in the plane, I don't need my legs. Next slide, please. And here's a new version that we just launched. This is developed for especially for foam cover use. This one is actually quicker than the previous Extend Connect Prime that I showed earlier. So this is quicker. It still has double locking. But I would say if you're a high active user, then I would stay with the Extend Connect Prime version of it. So this is more especially developed for foam cover users. Because foam cover use with the previous one is really hard not to crack. So this one is specifically designed for that use. Next slide, please. And this is how it works. You need to push both these buttons and then and only then it will release. Next slide, please. So this is definitely not a one-man show. It's a team effort, and as I said during the development, I've been really open, cooperating with universities and doing all kinds of studies, projects on all of that. This is actually the team of Linda Extend. So we're a Swedish-based company based in Halmstad, Sweden, on the west coast of Sweden. And we are 10 employees in Sweden, and then we also have a US entity in Florida, which has customer support and sales represent in the US. And we are 6 in the US. So it's really team effort, and all the developments we do in Sweden, and we also produce everything we do in Sweden. Next slide, please. So what we developed. The foot was really to, first of all, to help myself be able to live a free and mobile life in all types of areas and terrain, to really be out there living my life as I want to do. The second one was the quick adapter, the Extend Connect Prime, and just make it as easy as possible living with prosthetics. And in that case, sometimes it's actually easier to disconnect your leg, do whatever you need to be doing, and then put it back on. And then we realized that all the foam cover users, they can't benefit from this. So then we developed a solution also for them. And then we have the question mark. My point of view is that the prosthetic field, there's so much left that needs to be developed. There's so many things needed out there. And we're a really small company. We can't be all over. We have to focus on some areas where we see the most benefit, but there's so much needed. So we will definitely develop more stuff from us. But I also really encourage you listening to this, that, as I said, there's many things needed. So please, help out in developing it. And next slide, please. Yes, please follow me on social media. I'm on, I believe you can scan this. Otherwise, just type in Christopher Linde on Instagram, TikTok, YouTube or Facebook, and you will find me there. And with that, I want to thank you all for listening. I think I am right on time-wise.
Yeah, perfectly. We might have a few questions if you don't mind, Christopher, but that was awesome. Thank you so much.
Thank you.
I'd love to connect with you for personal consultation. Well, Chris has all his contacts here, so go ahead. Any questions? Якісь питання в когось може є? Питання про будь-що, про
Are there any
те,
questions regarding anything,
обирав собі протези або
regarding
його технології ще працюють?
the choice of prosthesis, regarding the technology, anything?
Вадиме, будь ласка.
Vadim,
Да, доброго дня. Ну, Крис дійсно показав, як він
good afternoon.
реабілітувався в гострий період. І
Chris
якраз спорт
showed
його
us
витягнув.
his rehabilitation
Дуже
journey in acute period and how sports helped him
такої, ну,
and
людини з травмою, те, що дійсно він
what has
зробив.
to be used
І
in
якраз
order
це
to
казав
stabilize a
про
person with trauma like
тіло, це
himself.
дійсно могло стабілізувати
And
спорт, тому
he
що було
said that
розвинені варіанти, він розумів,
that
як їх
sports helped
реабілітувати.
stabilize,
Однак,
and
скажи, будь
he
ласка,
had
Крис,
heart
для
muscles
оце
well
загальної
developed, which helped him
підтримки,
too.
оце виклик,
I'm not
знаєте,
a proponent of
як ми можемо робити,
osseointegration,
дійсно не
and
можна
you're right
замінити
that
повністю
we
замінити
should opt for that only in case
протезуванням.
conventional
Тому що дійсно дуже
prosthesis
багато
doesn't
факторів
work,
розіграють
because there
свої.
are too many
Це
complications following
тому дійсно дуже
osseointegration.
треба
Indeed,
бути
you have
обережним.
to be
От як
super
ви себе,
careful here.
ви адаптуєтесь,
But I
застосували свій
watched
протез
you
з тим, що
adapting and
знаєте, тобто
adapting your
вправ
prosthesis to
нові,
make your
правила, як ви
foot
одягаєте.
flexible, how
Знаєте,
it flexes
в
left, right, how
Україні
you don and
адаптацію
off.
вирішили за рахунок
In
адаптивного
Ukraine,
одягу.
we came up to
Тому
different
що дійсно
solutions thanks to
використовуючи, у
adaptive
нас дуже
attire,
багато
adaptive
травм і
clothing.
різні
We have a lot of
травми
combined
є
traumas. These traumas are
нижнє,
absolutely
нижче коліна, вище коліна.
diverse,
Ось
above
і
knee,
через те, що ми
below knee.
використовуємо
And
зіпери,
because
там
we use
замки,
zippers, we use
різні
different
магніти,
locking mechanisms,
адаптивно
magnets,
допомагає,
etc.,
і це
it
стабілізує
helps a lot
наших
stabilize
військових, ті, хто потрапив
our military,
отримав ампутації. Скажіть, будь
those
ласка,
who
ну,
sustained
які
amputation.
методики, в принципі, в цій
The
реабілітації я зрозумів.
techniques and
Розкажіть, як ви
methodologies that you've
фантомом
shared
боролися?
are quite
У мене свій
understandable.
метод
How did
боротьби
you
сам, в принципі, я
overcome
валідно
phantom pain?
використовую
I understand that your
стабільність була
psychological
для мене дуже була
condition
недовгою, але все ж
was
таки
probably more or less stable, so
вона
this
була
period
повідомлена
of
моя травма.
instability was not lengthy. But how did you overcome phantom pain and phantom
Chris,
sensations?
were
So
you
that
able
will
to
be of
hear the
interest.
translation?
No,
No.
unfortunately
Oh.
not.
I figured, like I realized by your looks. So Vadim and a few other people asked about osseointegration first. Same question, that it should probably be used as an extreme resort rather than a routine procedure. Now, do you agree or disagree? And the
I
second
agree.
question
Yes.
was the second question was about phantom limb pain, how you were fighting it initially. Thank you.
Yes. Okay. Yes. So also, I totally agree. Osseointegration should just be used as a last resort. So really try socket first and see if it works out. And if you end up like this isn't working, then osseointegration is a good alternative. And regarding phantom limb pain, that's I would say my experience is that it's very different from person to person. For myself, I got when I was in the hospital, I had a lot of phantom limb pain. I got medicine for it, and it took it away partly, but also when I stopped taking these medications, it was still much better. But my experience is that you should trick the brain somehow that if it starts hurting, do something else and focus on something else. And I believe being active and doing things helps out taking phantom limb pain away. So try to focus on other stuff and do other stuff. And I know that's really hard when you wake up in the middle of the night with a lot of phantom limb pain. In those cases, I would say, if you can't sleep and it really hurts, get up and just try to do something in the middle of the night, and focus on something else to prevent phantom limb pain.
Thank you. John, did you have a question? Do you want to go ahead and ask?
Yes. I'm John Batstorff. I'm a prosthetist, and first of all, very good presentation. Thank you.
Thank you.
And I think I know that this Lind Extend, very many patients would appreciate that. And you showed two different designs of that. One is the one with the knob that you turn, and the other has two buttons.
Yes.
Do you recommend the one with the two buttons now? If you had to choose, do you think that that's the better one to use?
I would say that it's depending on patient. So with the knob, the one that you push in and turn, I would say for high active users, we have it on Paralympians. We have many patients that use it in salt water or fresh water. So I would, for high active users, I would stay with that. If you have maybe you have problem with this knob turning, then it could be really good with the button solution instead. And also, if you just need an easier, if you have problems with that locking mechanism, it's easier, it's quicker, the other one. But I would still state that high active users should use the first with the knob turning.
Okay. So you could run, if somebody was running, for example, they could run using the one with the knob that you turn.
Absolutely. So we have several using them during the Paralympic Games.
Okay. Thank you.
Yep. Thank you.
Thank you, John. Robert, go ahead.
Hi, Christopher.
Hi, Robert.
Hi, nice to meet you here in this session. And I could take my question in Swedish, but for the audience, we'll do it in English. I was wondering a little bit about your thoughts on the relationship and collaboration that you have with the CPO that follows you. How important this is for you as a prosthetic user, if you could just mention a little bit briefly about that.
So you mean my own CPO or yes?
Yeah, how important it is for you as a prosthetic user to have a collaboration with your CPO, and what this have meant for you.
Yes, thank you. And my CPO, that's I heard it was another amputee once told me that the CPO in an amputee's life is the most important person in the amputee's life. So it really is something to it, because together with the CPO, it's a team effort. What do I need? What do I want to do in my life? And you discuss this with your CPO and really try to find ways and try to find solution. You test things, so it's really a collaboration with your CPO. And without a good CPO, it's much harder, because then it's not a team effort anymore. Then you're on your own, and that would make it much harder.
Thank you.
Thank you.
Thank you. We have one more question. You were directly involved in the development of personalized prosthetics. What are the main materials used in your prosthetics, and what criteria were used to select them? This is from a professor who teaches biomechanics and biomedical engineering, all that. So that's the question. Thank you.
Yes, thank you. Very good and interesting question. So in our foot, I was a little bit onto the topic. We are using both glass fiber and carbon fiber to get the best out of those two material, to get energy return through the carbon and to get the flexibility from the glass fiber. Speaking of our quick adapters, the first one, the Extend Connect Prime with the knob that you turn to lock it, that one is in stainless steel. It's a high-grade stainless steel that you can use in, as I said, in all types of mortar and those materials. And we did pick that material because it's a strong material. It has some weight to it, but still it can take the load from high active users. You could argue, why don't you do it in titanium? Titanium is lighter and stronger, titanium is maybe a better choice, but it's much more costly. So the cost will be more than twice of the component. And when we did our calculations, we didn't believe the market wanted to pay more than twice for the product. So that's why we ended up with stainless steel in that one. But if there would be a big demand for it being lighter and stronger, absolutely, we could do it in titanium instead. And the new one with the two buttons, also the quick connect, we call it Extend Connect Shape. That one is made of aluminum, which is lighter. It has a totally different design compared to the other one due to that it's in aluminum. But it's lighter, and therefore it needed also the strength of the material needed to be a different design due to that.
Thank you, Christopher. We won't keep you any longer. Thank you so much. That was an inspirational presentation and a very useful information about the Lind Extend. We're already being asked to share all the contacts. So with your permission, we will include the contact in the e-blast once we send out feedback form and everything, and so that people can contact you.
Yes, please.
Thank you.
Thank you.
Thank you for your time, and thank you for your presentation. Have a great
Thanks, everyone, and thanks for listening.
Thank you. Bye-bye.
Thank you. Bye-bye.
А ми рухаємося далі до нашої фінальної презентації.
We keep moving. Our final presentation is by John Batstorff, the person who made great impact and contribution on prosthetics and orthotics in Ukraine, and introduction of multidisciplinary approach for the patients with amputations back in 2015, when no one knew about that in Ukraine, or very few people knew about that. So John is the leader who gathers teams and does training across the globe. We are grateful to John for finding time and joining us today, and we are grateful for his experience that we are ready to listen to. Thank you.
Thank you for the introduction. I am, just by way of introduction, I am a prosthetist, and I've been a prosthetist for over 40 years. I'm going to be bringing you today the experience as a prosthetist of what are the most important aspects of having an excellent outcome in a prosthesis, and the difference between somebody really using a prosthesis well and not being able to use it. So I'll be talking about some of these aspects. For me, I'm located right now I'm in California, USA, so maybe it's the earliest for me. It's now 6:30 in the morning here. So anyway, I have my coffee and I'm ready to speak to you. So next slide, please. So what is the best prosthesis? First of all, you've seen in the previous presentation all kinds of several new developments and several very exciting developments. So there are different components that you can use that give really good advantages, like the limb extend, and there are different types of knees and different types of feet and different types of socket. The best prosthesis is the one that's most appropriate for that specific patient. There is no answer as to what is the best prosthesis because every person is different and their needs are different. So it's important to have a very good evaluation of the individual amputee to know what is the best prosthesis for that person. And then once they try it, they may have to change because they will learn something, and then you have to be flexible. So that's what we'll be talking about during this presentation, is to make sure that the amputee has the best prosthesis. Next slide, please. In general, we know that the loss of a limb for everyone that experiences it is a devastating experience. When it comes time to look for a prosthesis, the new amputee has no way to know what to ask for. And so many quickly turn to the internet to try to get some information. I would certainly do that. I turn to the internet for everything. And so this is the way they come to me as a prosthetist, often with a lot of information. But it's still very confusing because the internet is full of videos, and each person thinks that what they're recommending is the best. So the patient, the new amputee, often demands the most advanced, expensive, and technical foot or knee that they can find, assuming that that is the best. Next slide, please. And I say that's wrong. The reason it's wrong is because there is no specific formula. There is no one knee that's best for everyone. And you certainly can't tell by looking at a video whether that is the correct one for that one person. Again, there are other considerations. That's what we're going to talk about. Next slide. So this is a very good example. Here is a patient that I fit with a transtibial amputation, and you can see she is quite active. This is her the first day on the prosthesis, and this is a very, very simple prosthesis. This is yeah, very simple. It's a thermoplastic socket, and it is a very simple foot as well. What is the secret, or what is the main most important thing that allows her to do this activity? And the most important thing about this prosthesis is a comfortable and functional socket. The socket is the portion of the prosthesis that fits on the residual limb or on the stump. And this is the most critical aspect of the prosthesis. This video shows that if you have a comfortable, functional socket, that you can walk at least to some extent, and in this case, dance, even on the most simplest foot. And that would be also for an above knee prosthesis. You can walk. I'm not going to say it's the best, but on almost any knee or foot, if you have a comfortable, functional socket. If the socket is not comfortable and not functional, you can have the most advanced knee or the most advanced foot, and it will not work. It will not be useful. So the socket is critical. And again, here you see a person on a very simple prosthesis, And maybe if she was going to do other activities, even she would have some more activity, and she could certainly use the limb extend and things like that. But this shows that for her, this may be the best possible prosthesis, even though it's very simple. She's very happy with it. Next slide. So more times than not, the amputee that just goes by a video and just selects a certain type of knee because they were impressed on the video, many times they end up disappointed and angry because the prosthesis did not meet their expectations. They learned the hard way that the most expensive and the one with the best videos are not always the best. I'll just say sometimes they are the best for that person, but not always. So again, the socket is the most important, and then having the appropriate knee and foot is what's the best. Next. So what is the goal of rehabilitation? Of course, again, it's different for each person, but I would say in my experience, in general, the goal is to return to the maximum function that they're able to return to. So when we do the assessment, I always ask the new amputee, what was your activity before you had the amputation? And when we look at all the aspects of what an amputee can expect out of a prosthesis, the most important function is what were they able to do before they had the amputation. And that's what we aim to do after the amputation. So return to maximum function. And secondly, reintegration into the family and the community. So right after amputation, often psychologically, the amputee feels that they're no longer part of the family, that they're no longer part of the community, and they feel very isolated. So even though the prosthesis is a mechanical device, sometimes this is one of the main tools to be able to re-enter the family and the community. And this is what we try for. Next slide. The goal of the prosthesis technically are four main technical goals. Comfort, that's very important. That is the basic importance. And again, that is all about the socket itself. Function, and function is a consideration for the socket, for the knee, for the foot, and for any additional components such as the limb extend that you just heard about. So these all have to do with function. So we have comfort, function. The third is cosmetics. That means that it has the appearance that the amputee would like. It doesn't mean that it has to look just like a leg, but if the amputee wants a cosmetic cover, then it can be covered. On the other hand, if they don't care about that and they would like the components to show, then they can have it look like that. And often the function is better if they don't have a cover. But we do want them to match their expectation on the cosmetics. And the third, very important, is reliability, that they have to know that the prosthesis is not going to break or crack or fall apart. So very important that the material is strong enough for that person. Most amputees would like to have their prosthesis to be as lightweight as possible. However, again, what is the best prosthesis for that person? If they're going to be very high activity level, they might have to use a little bit heavier prosthesis, but they all want reliability. Next. So the different levels of amputation, just as a review, the highest level of a lower limb amputation is going to be hip disarticulation, where the entire leg has been amputated, or not always amputated. Sometimes the person is born without a limb, but hip disarticulation would be the highest level. The next, transfemoral, which is above the knee. Next, knee disarticulation, which is right at the knee. The next is transtibial, below the knee. Then we have cyme amputation, which is right at the ankle, and then partial foot, where part of the foot is amputated. So each of these different levels of amputation requires a different solution. So part of knowing what is the best prosthesis, the very beginning, is to know what the level of amputation is. Sometimes people come in and they say, why can't I walk like the person on this video? And I explain, because you have a very different type of amputation. So the amputee should understand the different levels, and we discuss that with them. Next. So this is just a picture. You can see a hip disarticulation. Both of these are people who have lost the limb, the total limb. So they have here an artificial hip joint, an artificial knee joint, and a foot, as well as the socket. In this case, the socket has to go around the waist because there is no residual limb to attach the prosthesis to below the hip. And lightweight is very important, by the way, for the hip disarticulation amputee. But at the same time, there are more advanced knees that will give higher function and more advanced hips. So again, very important to assess the individual patient to find out, can they tolerate the extra weight of the higher functioning limb? And in this case, they're using a very simple lightweight components because this is their very first prosthesis. And we often start with the lightest weight to give them early success. And then we can always change to different components. This is very important to know that the components can be changed on the prosthesis. So during the initial trial fitting, we could try different components and see, the patient can see what they like the best and what works the best for them. We can see, and the therapist can see. So we all work as a team and we decide. You cannot always make a decision until the patient has tried the prosthesis. So we stay very flexible and we make changes as they try the prosthesis. Next slide. Here you have a transfemoral prosthesis for the first two. And again, we have different types of sockets and different types of knees. There isn't any one that's good for the prosthesis and or for every patient. And on the right, you see a transtibial prosthesis, and this is a person. All these people are trying them just for the very first time. These are in the first few minutes of use, and they're going to try different types of feet during this process, and we'll select which is the one that works the best for them. Next slide. So levels of amputation in the upper limb. Almost everything I'm saying now applies to both the upper and the lower limb. Very, very important in the upper limb, because the upper limb is quite different. As a bit of background, the upper limb amputee, because they're not walking with their limb, they're using their limb for the functions of daily activities. And many people who lose one upper limb, they use the remaining limb in order to do most of their functions. So many don't use a prosthesis, they just use the remaining limb. So if they're going to use a prosthesis, it has to be something that's very functional and something that gives more benefit than just using one arm. So with a bilateral, where they're missing both arms, then they almost always have to use a prosthesis because they can't be functional. With a single arm, though, it has to be a very appropriate prosthesis so that they will use it. So we have different levels. The shoulder disarticulation, in which the entire arm has been amputated or is missing. Transhumeral is above the elbow. The elbow disarticulation, where the amputation is right at the elbow. Transradial, which is where the amputation is between the elbow and the wrist. Wrist disarticulation, where the amputation is right at the wrist. And partial hand, where the amputation is part of the hand. And again, the solutions are very, very different depending on the amputation, and very different depending on whether they are a unilateral, where it is just one arm, or a bilateral, whether it's both arms. The assessment is very, very important. Next slide. So what are these assessments? These are the things that we consider. The first, the length of amputation, which we just described. The second, bilateral involvement. And the question is, are both legs involved, and are they, or both arms, and is the amputation at the same level? Because, for example, with an arm, if one side is a shoulder disarticulation and one side is transradial or below the elbow, then that's a very different consideration than saying they're a bilateral shoulder disarticulation. So in that case, most likely they will use the prosthesis on the lower level of amputation or on the transradial, but they may not choose to use an prosthesis on the higher level of amputation. So again, we discuss that with them. The next is scarring, or what type of scarring do they have? Are there burns, and what's the condition of the skin, and what is the sensation? Do they have pain? And if they do, sometimes that has to be addressed before the prosthesis can be fit, or sometimes at the same time. Contractures, very important. Sometimes the amputation level is very acceptable, but they do not have full range of motion. In that case, that limits the amount of function they have, and they may have to have either additional surgery or physical therapy to straighten out the contracture. I'll mention that before I go on with this list, that when we fit the prosthesis and when we work with an amputee, it's an entire team that works together. That means the doctor, the therapist, the prosthetist, the patient, and the family. Everybody works together as a team. And so when we have contractures, for example, the patient can't do it alone, or the prosthetist. It has to be the whole team that addresses it and comes up with solutions. So going down the list, we have additional challenges or limb involvement. That means besides an amputation, there may be paralysis, and there may be additional challenges with vision. Sometimes the person is blind or has some other problems with vision or hearing due to their injury. And finally, at the end, but this may be the most important aspect, is what is the goal of the amputee and the individual? So these are all considerations that we must consider before we recommend what is the best prosthesis to start with. And again, no matter what we start with, we may add or make changes as we go along. Next slide, please. Okay, what are the different options? So the first option, the basic one, is will they have a prosthesis or no prosthesis? For example, sometimes we have people with bilateral hip disarticulation. That means that there is no residual limb, no remaining residual limb below the hip on either side. So some of them want a prosthesis, but will be much more functional with a good wheelchair than with prosthesis. So why would they have a prosthesis? So this requires a lot of discussion with them. Even with a single hip disarticulation, will they do better with a prosthesis or walking with crutches and the remaining leg? They will walk faster with crutches and remaining leg than with a prosthesis, and it will be much lighter. However, if they require the use of both arms for their activities, then they might want to use a prosthesis. And so again, is the most important thing the speed of walking and the light weight, or the most important thing is the use of their arms and not having to use crutches? So this requires a very individual discussion. So the first is prosthesis or no prosthesis. The second, more than one prosthesis. So one prosthesis can't always do all functions. If they were going to be in water, they may need a different prosthesis for use in the water. If they want to run, they may have a running prosthesis and then another for walking. So we decide if the goal is more than one prosthesis. Additional assistive devices, for example, crutches, a cane, a wheelchair. Maybe they want a prosthesis to use some of the time, and sometimes they will be using a wheelchair. Again, this is a decision that can be made. What is the socket design? There are all different types of sockets that are designed, and we have to decide on the best one for that person. Also, be willing to make changes if that socket design we decide that it's not the best design. After we've tried it, we can change it. And then we have the different components, which we talked about, different knees and different feet. And finally, training, very, very important. And especially with the upper limb amputee, if you don't have training, you can fit the best possible device and it's not going to be usable because the patient has not been trained how to use it. And so the training and the team is very important for that. Next. The process. The very first thing we do is the assessment, which we just talked about. And that's done with the entire team. The next is the planning. Once we've done the assessment, we decide and discuss what we're going to try out and what type of plan of a prosthesis. And that's done with the whole team deciding together. The next we do is measure and make a mold or a cast, or sometimes electronically we make a scan. Whatever measurement is appropriate for that patient, we do. The next is fabrication. And while we're fabricating, the physical therapist or occupational therapist can already begin with training. But then we try out the prosthesis and we have to do the trial fitting, and the alignment is next. Next slide. Continuing with the process, we have training, then we have adjustment and fine tuning. After the patient has been training and starts to learn to use the prosthesis, we often have to do different adjustments, fine tuning, and very often we change components at this time because we want to try some others, or we find that one is not working as well as we thought, and we want to change to a different foot, a different knee. If it's an arm, we want to change to a different hand or a different control system. Finally, after they've tried it and they're using the prosthesis, then we finish it. And then, very important, is follow-up. Once they get the prosthesis, the follow-up is critical. And this is the reason why it's very helpful if all members of the team live close to each other. Sometimes amputees go abroad or they go far away to get a prosthesis. And the problem that they have is in the follow-up for repairs, adjustments, replacement, continued training. And this is a big, big compromise when they can't get that follow-up. Before, there was a question to the previous speaker about the importance of the CPO. And people often ask, what's the best location of the CPO. Where do you want your prosthetist to be located? And the answer that some of the amputees have told me is the best location is if they're right in the next room, if they live in your same house. That would be the best thing. So, but that's not always the case, but having them close by. So remember that when you are encouraging somebody to go to a prosthetist or a therapist that's far away, there's going to be huge compromises. So this is why we really support training and building local capacity for the capability in all areas and in all regions, because you have to have that ability very close by. So follow-up, repairs, replacements, and adjustments are all part of the process, and very, very important process. So next slide, please. So prosthesis, again, the socket is the most critical component. Next slide. And then the functional, again, here we have a person walking, first day in their prosthesis. They're very functional in it, not just because of the components, although the components are working very well, but the socket and the alignment of the component is very important. So again, you can have a very good component, an excellent knee, an excellent foot, but if it's not properly aligned according to, first of all, the manufacturer's recommendations, because every knee and foot has a specific recommendation, but also according to the dynamic alignment of the patient. They have to try it, and then we make adjustments to the alignment as we go along. Again, this is why a prosthesis is such a custom device. It has to be made specifically to that patient. It doesn't come out of a box and be fit on the patient. It can't come in the mail or be sent and expect it to fit. It will not fit coming right out of the box or right out of the mail. It has to be aligned and fit and adjusted. Next slide. Here's an example of another person. First day, they're fit, excellent knee, excellent foot, and the socket is not necessarily a bad design, but they're not able to use it. Can you see if you can make that video play one more time? I don't know if you can do that. Yeah, that one. Okay, so if we took this right off and put it on the patient, you would not know that he's non-functional. The only way you can know is when they start to walk with it. So this prosthesis and this patient ended up to be very functional, but it required adjustments to the knee and to the foot and to the socket, because this was not working well at all. And the question, is it because of the socket? Is it because of the knee or the alignment? I can't tell you from this picture, because this requires work on all three of them, and also training. This could also be just a training problem. So this is the whole team has to work to do that. So it's not just a function of whether it's the best knee or not. You could be just as non-functional as this person, even with a very good knee. And the problem is that it's not finished. We have an expression that this came from John Lennon came up with this, and I'm going to mention this again at the end, but everything works out in the end. If it's not working out, then it's not the end. And that's the case with this patient. Next slide, please. So a good outcome requires a good assessment, a good plan, a comfortable, functional socket, proper training, and follow-up. So these are all important for a good outcome. Next slide, please. Okay, the do's and don'ts first of all, don't try to use a formula to determine the best prosthesis. So remember the question that I asked at the very beginning of the presentation, what is the best prosthesis to use? And I said that there is no answer for that. The best prosthesis is the best prosthesis for that person. You must treat every person as an individual. And you must also work as a team, and that team includes the most important person, which is the amputee themselves. Next slide. So the best prosthesis is the one that is comfortable, functional, and matches the patient's activity, needs, and desires. Next slide. Here we have that same person that I showed you in the beginning. Very simple prosthesis, but very comfortable socket and very good training. You see the prosthetist is watching at one end, the therapist is watching at the other end, and I'm in the middle taking a video. All right, next slide, please. And this is a patient. This is in my parking lot outside of my facility. And this is a young man, 13 years old, who lost his leg. And this is 6 months after he's lost the leg, and he's running in the prosthesis. This is not the simplest prosthesis. In order for him to run like that, he is using a prosthesis that is a blade type of prosthesis. It's a specific running leg, and we fit him with that. But again, if you could play this video one more time. Oh, there we are. And he's a competitive runner, doing very well with that. So he does need to have a prosthesis designed specifically for running, and then he also has a second prosthesis that he uses for his everyday walking. Next slide. So as my final slide, I'll just say again what I said before. Everything will be okay in the end, and if it's not okay, it's not the end. And what is okay? Does it mean that it will be perfect or that they will be able to have all the function they had? No. Okay means that we've gotten the most possible function that we were able to achieve, and that we've done the best we can. And if we haven't done that yet, then it's not the end. We keep working on it. And in the case of working with an amputee and the prosthetic, when is the end? It goes on forever. We always can improve, and it's always a changing target, a changing goal, because it doesn't stay the same. The limb changes, and also technology improves, and we can always offer new solutions. So this is continuing. We keep working. We keep trying to do better. Next slide.
I think this is it.
Oh, I didn't have one that says thank you. All right. Well, thank you for. All right. Thank you very much for your attention. I think we finished a little bit early. So
yeah, but we have questions. Don't worry.
So if we have questions, then I can answer the questions, and then
yeah,
maybe
we have
also.
So there's a question here. A very frequent request from patients with upper limb amputation is being able to drive. Does it require special prostheses, or should it actually just be the adaptation of the vehicle?
Very good question. Is everybody getting a translation at the same time?
Yeah.
Okay. All right. And I know it sounds like I'm always giving the same answer, but it depends very much on the level of amputation. So I would say that, well, the first question is it unilateral or is it bilateral amputation? If it's a unilateral amputation, meaning that only one arm is missing, they will probably be able to drive most vehicles with one arm. I'm very lucky that I have both of my arms, but very often I have a cup of coffee in one arm and I'm driving with the other arm. And I shouldn't say that I'm texting with one arm and I'm driving with the other, but you see many people driving with one arm. So if it's a unilateral amputee, and most upper limb amputees are unilateral. So if it's just unilateral, they should be able to go with no adaptations on the car. If it's a bilateral amputee, they'll probably have to have some adaptations, and it just depends on the specific level. They should talk with an occupational therapist about that. And there are also videos available, and it's also very helpful to talk to people, peer support, and talking to somebody that already has experience. And you can talk to either a prosthetist such as myself to find a referral for somebody that's already gone through this. And again, even if you get a referral, every person's situation is different. So you have to try things and then make changes and then try again. So it's not a very good answer, but I think it's the honest answer. Next question.
Thank you, John. Вадим, ти включився? Так, будь ласка.
Да,
John,
доброго
you must remember Vadim.
Yes. Hello. Good to see you.
Thanks. Да, ну, мене більше турбують, знаєте, такі
I'm worried
глобальні
more about
запитання.
global
Все-таки
questions.
нас багато в країні
We have a lot of people in our
11 років війни.
country. Well, over these 11 years of the war.
Секундочку, я спитаю Джона, чи він чує переклад. John, can you hear the translation?
No.
Can you turn it on? Click the globe in your Zoom. Click the 3 dots more at the bottom.
Oh, interpretation.
Yeah, and then choose your language.
Okay, let's try again.
Дякую, вибач, Вадиме.
Да, зараз ви мене чуєте,
Can you
переклад?
hear me now? Can you hear the
Yes.
interpretation? Yes.
Yes, I do.
Дуже дякую. Ну, тоді
Thank you.
продублюємо.
So
Ось,
let's repeat the question again.
Мене дуже цікавить глобальне
I'm
питання. У
interested
нас
in the global
за ці
issue.
11 років
Over the
багато
11
зроблено
years,
завдяки
we
вам,
have done a lot
завдяки
of things through your support,
людям, які
through other
цим
people
займалися. І це
who were taking
потужний
part in the
рух
process, and
вперед.
this is a
Але все
powerful
ж таки
movement
питання
forward.
якості,
But at
воно
the end of the day,
завжди залишається
the matter of
гострим.
quality is still
Протези я маю на
acute.
увазі.
I mean, when it
От,
comes to
що б ви нам
prostheses,
порекомендували, як
what would you
зробити
recommend to
кращу
us?
перевірку
How can we
цієї якості? Як
check the
краще
quality of
зробити так,
prostheses?
це на державному
How
рівні
can we ensure, at
запитання.
the state level, probably in the first
Звернення,
place,
можливо, звернення
can we
тих, хто користується протезистом,
refer
що неякісно зроблено.
the
Як оце у вас в
prosthetics
країні
experts
побудовано?
or those
Як
people
ви
who
це
use
бачите?
prostheses? How is this process built in your country, and how can you see it?
Let me see if I understand the question. I think tell me if this is the question. The question is, how do we ensure the quality of the prosthesis?
Yeah.
When there are so many different,
Абсолютно.
there are so many different providers and so many different type of prosthesis. Is that the question?
Абсолютно. У нас просто,
Yes,
ви знаєте,
exactly.
кількість
Because as you
бійців,
understand,
які
we
потребують,
have the number of
військовослужбовців, які
servicemen,
потребують протезування,
militaries
у
who
нас дуже
require
багато.
prosthetics.
Кожен
Like
день
this number of
у
people
нас
is
все
very high,
більше
and
і
every
більше
single
їх.
day we
І
have more
це
and more
різні
of such
комбіновані
people.
травми,
And
і
these could be different
нам дійсно
kinds of
треба
combined traumas.
задумуватися
So
над,
we may need
над
to
тим,
think
скільки нам треба
about
протезних майстерень, а як
how,
покращити
not about how
якість
many
тих
workshops
протезистів
we
і
need,
їх
but how to ensure the
відповідальність.
quality of prosthetists and their responsibility.
Okay. First of all, it's a very, very good question. The first thing that I want to say is that when we look at the quality of a prosthesis. It's the outcome that is the most important thing, and not how does it look, or did they get the best component, or did they get even whether the prosthetist is the most qualified prosthetist according to their training. But what is the outcome? Is how is the we look at the function and the comfort of the patient. Are they able to achieve their maximum function? And that's the question. So I think that establishing outcome measures and establishing a standard way of measuring the outcomes is very important. And I think that often the people that are making the decisions about quality and about whether, for example, whether a certain center or a certain prosthetist is the one that's being referred to, that those people don't really understand outcomes and quality. So I think that having the decision makers be educated about these important aspects of quality and outcome measures, that it's patient-centered and not centered around components or about the costs of the prosthesis, but it's really around the outcome measure. So this is one aspect. I think that the appreciation, again, in this presentation, I've tried to show that the importance of evaluation, of working as a team, of a custom design, of the training of the prosthetist and the team, and the care and that's important. And I think that if the decision makers and the people that pay for a prosthesis, the people that decide who is qualified to provide a prosthesis, if they understand these things that I was talking about during this presentation, then the quality will be improved. But many times they don't understand even that it's a custom prosthesis. They don't understand why you can't just order a prosthesis or decide it's going to be, we're going to provide everyone with osseointegration, or we're going to provide everyone with an upper limb prosthesis with a myoelectric prosthesis, and therefore it's going to be the best outcome. So many times they don't understand this. And so I think education of the decision makers is also very important. It's a very big question and a very complicated answer. And we could probably discuss this for a long time. It goes everything from individual training all the way to politics at the very top.
Thank you, John. Luckily, we have already developed the rehabilitation standard with your help as well, and it does include outcome measures in it, and it is at its final stages at the Ministry of Health being approved. So hopefully, it will be released soon, and the multidisciplinary teams will have to use the tools, the validated tools, the objective tools, and patient questionnaires to establish what level of mobility or activity the patient is, so that it is a more accurate prescription rather than just a want. John, there is one more question. How do you know if a patient is abusing the attention of a prosthetist and a physiotherapist, if visually the gait in prosthesis is fine, but the patient keeps saying that he's not comfortable still, or something's not right?
Um, that's a very good question. And again, I'm as a prosthetist and as a prosthetist with a lot of experience and quite busy, I'm kind of working every day with amputees and with prosthesis and fitting. And when you have, I always have to listen to the patient, and I want to hear, are they happy or are they having an issue? And so this example, so a patient says, I'm not happy with it. This could be with the comfort or with the function. So let's say what's with the comfort. So they say the prosthesis is hurting. I'm watching them and they're walking fine, but it hurts. I have to listen to this because I'm not the one wearing it. So I stop immediately if there's a concern with comfort, and I try to get them to specify exactly where it is. And I look and I listen and I feel with my hands, and I have to be able to pinpoint, and it requires it requires communication, very, very good communication with the patient. So when it's an issue of comfort, I don't like to say, well, just keep trying and maybe it will get better, or maybe it just takes time. But I have to say, sometimes there's discomfort just because they haven't used the muscles before. If it's been a long time and they're just starting to use the prosthesis, sometimes it takes a little bit of time. And this takes, again, communication and experience to know that. And we try things, but so sometimes it's like that. And sometimes they're walking very well, or appears to be well, and they're still complaining. Then again, what I have to do is, it's about communication. I have to listen and I have to find out what it is very specifically that they're unhappy about. And I think in many cases, we can solve the problem just by in communication. And I guess at the end, is it possible that you have a patient that's just going to keep complaining, and no matter what you do, they're not going to be satisfied? It's possible. And once in a while, you do have somebody that continues to do that. And if that's the case, sometimes I sit down and I explain that we're working as a team, and there's some things that I can do, but there's only so much that I can do. There's some things the therapists can do and only so much they can do, but also that you as the amputee have a responsibility also, and some things you have to adjust to. So we work as a team. So sometimes this is kind of a tough thing, but sometimes you have the patient and they want, they have a lot of frustrations, and it falls, they put the frustration sometimes on the people around them, and not taking the responsibility themselves for having to just work at practicing and using the prosthesis. But most of the time, we can work together as a team and get it solved. So I hope that answers the question.
Thank you. And we have one last question. For the lower limb amputee, consideration is focused on weight bearing, and this is also the focus for alignment. What will the focus be for upper limb in terms of alignment and function?
Oh, that's such a great question. I mentioned that the socket is the most important thing in the prosthesis, and that's the case mostly with lower extremity, because they do have to bear weight, and they have to bear a lot of weight. They have to, every time an amputee steps on a prosthesis, it's 100% of the weight bearing. And if they're going to run, when the amputee is running on a prosthesis, it's 5 times the body weight. So if a person Imagine that every time they step or every time they land on the foot when running, it's 5 times the body weight. That means that it has to be a very comfortable socket, and it has to be a very functional socket. So the most important thing is the socket for that lower limb. But also the function, the knee, when they come down with five times the body weight, if that knee is not reliable and if it buckles or it doesn't bend properly, then they will fall down and they'll have an injury. So the socket is important, but also the selection of the knee and the foot and the alignment is critical, and the function of it. So, but that is for the upper limb, it is not a weight-bearing limb, and the socket it's important in terms of being secure, but the function of the prosthesis. So in an upper limb, we have a socket, and then we have the control system. So the control system, the way that the amputee controls the prosthesis could be with myoelectric, using the nerve signals and electronics, or it can be a cable system. In either case, no matter what the component is, whether it's a cable system, whether it's a hand, whether it's a hook or an elbow, the amputee has to be able to have very good control. The system has to work and the training has to be there, and they have to have practice. So I would say that the control system, having the proper control, having it work well, and having good training is going to be the difference between them using the prosthesis and not using the prosthesis. So a good socket fit, a good control system, and then the component selection, very, very important. So the function of the prosthesis is going to be probably the most important thing in the prosthesis. So when we talk about comfort and function, comfort is important, but it's not as difficult to achieve in an upper limb prosthesis. But the function, especially with if it's above the elbow or at the shoulder, it's very difficult. This requires a lot of skill on the part of the prosthetist and the technician. And let me just say again, prosthetics is not easy. It's really what we do here as a prosthetist, as a technician, as a therapist, and as the patient. This is a lot of work, and it's not a simple thing. It's not out of the box. So yeah, but anyway, very different for upper limb and lower limb. Next
Thank
question.
you. And we still have Vadim. Go ahead.
Дякую. Ви чудово розповіли
Thank
за
you.
гільзу. А скажіть, будь ласка,
You were
зараз дуже
very
багато
elaborate when it came to socket.
Чи у вас була така
Today,
практика,
they talk a lot
що
about 3D printing. Do you have experience with 3D printing, and what's your attitude?
Good question. The most important thing I want to say about 3D printing is that 3D printing is not a socket design. 3D printing is a means of manufacturing. So when we talk about comfort, 3D printing is neither more comfortable nor less comfortable, because it all depends on what the socket shape is that we're going after. And the socket shape begins with the capture of the shape of the residual limb. So if we take a cast of the residual limb, then if the cast is well made, then we get a very good representation of the residual limb, so that when we make a socket, whether it's 3D printed or whether it's made out of thermoplastic or laminated, that we're beginning with a good capture of the shape of the socket. 3D printing, often we start with a scan. The scan is not a cast of the socket. Sometimes we can get a very good scan. Sometimes we get a very poor scan, just like a poor cast or a good cast. So I think the first thing is to realize that 3D printing is not a socket design. It's just a system. So for example, if you say, is lamination is that a good solution? No, it's just a means of it's just a means of making a socket. So 3D printing, all it is a fabrication system, and it's not a socket design. So in itself, the potential is to make a good prosthesis or a terrible prosthesis with 3D printing. It's not a solution in itself. And probably the most dangerous thing about it is that people think that it is a solution in itself. And so, and they don't understand that just like everything else, that the most important thing here is that you have a skilled prosthetist, a skilled the entire team is skilled, the process and the therapist, and that you have outcome measures. So if you want to know if the prosthesis is good after 3D printing, I want to see the result. If it's a leg, are they able to walk with it? Are they comfortable in it? Is it robust, and is it going to stand up to the pressures of walking or running? So this is the answer I have.
One more question. So it's like a case. There is a patient with high transfemoral amputation. The stump is shrinking, like losing volume, and the socket is becoming loose.
Yes.
The muscles are well trained and quite strong. Neither the prosthetist nor the physical therapist can do anything about this state, and the prosthesis seems to be comfortable otherwise. What is the solution in a situation like this? Change the socket, remodel the socket.
I think you said that the muscles are good and the socket fits, but the patient has
lost volume in the stump. Mm-hmm.
Oh, okay. So this happens with every patient. So first of all, I want to say that every patient, that after they have the amputation, the limb changes and the socket doesn't fit. So most important thing is that's the reason that you have to have follow-up. That's the reason that it doesn't work to go to another country and get a prosthesis and expect it to work when you get home and to continue working, because always that residual limb changes and it shrinks down. And always you have to have adjustment first and then replacement of the socket. So the first thing we do is adjust it and try to tighten it. And often we can make changes and tighten it and make it work better. And then after a certain point, we can't do adjustments anymore. And then we have to replace the socket.
Got it. Thank you so much, John. We're all good now.
Okay.
Thank you for your time. Thank you for sharing. And it was a very meaningful lecture. Thank you so much.
And thank you for putting together this really great conference. I think this is really, really important. I wish more people, you have a lot of people that are listening. I wish everyone involved in the field of prosthetics could hear this. It's a really good international Congress. Thank you.
Thank you, John. We'll have a recording in both languages, so we'll share it so that people can listen it later too. In the meantime, that's it for us for today. Thank you for
all right. Thank you.
For finishing our marathon on such a great note and with such great insight. Thank you.
Thank you.
Друзі, ми завершуємо. Дякуємо усім спікерам.
We have finished for today. Thank you, all the speakers. Thank you, all participants who were with us today. We will reconvene tomorrow, 8:30. Please be with us at 8:30 to get connected, and we will start our marathon at 9:15. There will be a lot of interesting presentations. Please invite everybody to join in. See you tomorrow. Have a great